bring a group of gastroenterologists, pancreatico-biliary surgeon, oncologists, radiologists, and basic scientists to discuss about the disease. And through the interaction, hopefully we have a better understanding about this area. I would like to send a thank you in advance to our sponsor, Olympus Australia, and Device Technology for their support and make this meeting happen. I still hear a lot of echoing. And of course, without the delegate today, this meeting would not be happening. Now, for some of you, or many of you, you might not know what AEG, it stands for Asia EUS Group. And this is a non-profit professional group that aim to train, educate, and promote research in the area of endoscopic ultrasound. And it have grown significantly. And today, we have the honor to have the treasurer of the group to be our special guest. So I'm going to play a short clips to showcase again the AEG. For the interest of time, we're running a bit late, so I'm going to cut short the video. I should also actually mention this is a hybrid meeting, so the content will be live streamed today over the next 2 days. So I would also actually like to welcome the candidates that watch this on live stream. So without further ado, I would officially open this symposium. A few housekeeping. Because this is live stream and you can see that we're struggling a little bit already with our audio, we would actually strongly recommend that you talk to the microphone if you have any questions. And this includes for our chairperson and presenter. Please actually talk to the microphone, otherwise we will not hear you from downstairs, or the live streamer doctors will not be able to hear what you say. So I would actually hand over now to our chairpersons for the first session. Thanks, Andrew.
Thank you very much. Hello? Is that working? Yeah. So, fantastic. Thank you to Nam, Will and the team for putting together what looks like such an amazingly interesting topics for the program today. And without further ado, we're going to open things up today with such a small topic like tissue acquisition in pancreatic lesions. So to open, our first speaker is Chris. He really does need no introduction, but I'm going to do it anyway. And I'll summarise because his bio is 50% of all the bios for the weekend. But just to say, we were thrilled when Chris moved over from Nottingham to grace us with his expertise. He's now working in Perth. He's an editor of multiple international journals and has authored over 150 peer-reviewed papers and 4 book chapters. So he's the perfect person to let us know about the current topic today. And I will read that now, although it is in 7-point text, and I have middle-aged man eyes. So it essentially says, and I'll read it like I do in restaurants these days, but EUS guided tissue acquisition of solid lesions from the pancreatico-biliary tract, best practice. So thank you very much, Krish.
Thanks, Andy, for your generous introduction. Thank you very much to Nam for his kind invitation and all the organizing committee. Thank you. Can I have a presenter mode, please? Can you go to presenter mode here?
Oh, I can't give you presenter mode.
Can I show?
Then you get presenter mode on here as well.
No, okay. I thought it went into presenter
Do you
mode.
not have your notes?
Can you go into presenter mode?
Oops.
Okay, brilliant. Thank you very much.
That's the same on there.
Oh, okay. Then we'll go back into that. That's fine. Sorry about the hiccup. Can you switch?
Yep. Takes forever.
Can you go to presenter mode?
I know, because it's the same output. Yep, okay. Yep.
No, it's all right. I mean, you can go back to that. It's all right. Okay. What do you want to do?
They're just using the house PC. There's no laptop.
I'm not using laptop, so duplicate slideshow. Okay, that's fine. I'll manage. Yeah. Sorry about the interruption. So how many other times you try and rehearse it, it doesn't come up. Anyway, these are my disclosures. So what does best practice means in 2026? When Nam mentioned this to me, I was trying to put up a presentation where I thought all the key issues of tissue acquisition in EUS-guided pancreatico-biliary tissue sampling. So a good EUS-guided tissue acquisition procedure starts before the needle starts the scope. So the next 15-20 minutes, I'll focus on a few areas, which will be on choosing the right target, sampling the lesion, which will give you the answer, and also alter the staging and treatment options. We'll go through high-yield devices, what we're currently using, and then we'll optimize the number of passes and how you do the procedure as well. So this is going to be what I'm going to be talking in the next 15-20 minutes, and how you handle the tissues. And why is it important now compared to how it used to be nearly 15-20 years ago when I first started? Because when you first started, it was just to make a diagnosis of whether it's a cancer or not. But however, now it's moved on from that. Not only confirming malignancy is important, it's also because if you want to go into neoadjuvant therapy and so on, then you really need a good quality tissue. And two, you also need to differentiate it from other mimickers like autoimmune pancreatitis, which increasingly we are seeing now, and other conditions like neuroendocrine tumors, lymphoma, and metastasis, because all these things has a different way of managing them. And it not only gives you a diagnosis, it also gives you the architecture for histology, and it is becoming more important nowadays for immunohistochemistry as well. And if you're going into precision oncology, you really need the amount of tissue that is needed for next-generation sequencing, so on. So all these things makes it more important for us to have a good quality specimen when you're doing EUS-guided tissue sampling. So this is the pancreatico-biliary target map. As you can see, most often we will be going for the primary pancreatic mass. We'll be sampling, or it might be a high-level mass, what we are doing. We sometimes are asked to do gallbladder masses as well, although quite often it can be done percutaneously, and nodes and liver metastasis. Sometimes it's important to sample them because it makes a difference to the staging and treatment options. Ampullary and periampullary EUS makes a big difference, especially when you can't really see the tumor on your ERCP images on side-view scope. So the principle says biopsy the safest lesion that answers the MDT question. So that's what the principle is. You can get tissue on various ways. You know, if you have a biliary stricture and there is no mass, then ERCP and brushing becomes an issue, becomes an option. If you have a definitive mass, then EUS-guided one. And for liver metastasis, actually a transabdominal ultrasound and biopsy really gives you good quality tissue. And when you compare sampling the pancreas and sampling the liver, actually you get better quality tissue with the liver because there's not much of desmoplastic reaction there from the metastasis. So in fact, that is better when you have liver metastasis. So it's important to have some proper pre-procedure planning. You need to make the diagnostic route explicit. The clinical question needs to be answered, and it's important to see what your oncology and surgical colleagues want you to answer. So that's important to understand about the patient you're going to be handling with. Cross-sectional imaging needs to be reviewed so that you have a 3D view of what you're going to see, especially the vascular anatomy and so on. And then the sequence, when would you do ERCP, when would you do EUS is also important, because nowadays increasingly, as I said, we need tissue, which means that you don't want to first do an ERCP and put in a metal stent before you take a tissue. Obviously, if it is an emergency, if the patient got cholangitis and quite deeply jaundiced, then the situation is different. So it's important to plan that as well. And finally, the pathology plan. Do you just need a cytology or you need a core biopsy? Because again, that makes a difference how you plan and what room setup you have when you do the procedures. So just to give you a snapshot of the evidence, in the modern day, FNB has become the default for tissue sampling. And you can see in this graph here, the sampling adequacy is about 3 times more than an FNA sample. So this is what you would normally be going for. And the single pass diagnosis is quite high, and the number of passes needed is very less compared to an FNA sampling. It is also important that with similar side effects, better suited to molecular testing, fine needle biopsy seems to be ideal. And you have very good needles nowadays to do that. So what needle you would select? This is a very good study looking into a network meta-analysis looking into various needle types that are being used. And you can see that if you're using a Francine tip or fork tip needles, particularly 22 gauge gives you the maximum yield. So this should be your default needle that you're going towards when you're going to be choosing the needle. Interestingly now, 2 new needles have been launched. One by Olympus called the SecuFlex FNB needle, which has got a dual bell raptor type of a tip, and it is also speckled here, which makes it very bright when you put the needle into the mass, and you can get very good samples. And the other one is the clear core FNB needle, which is a Francine tip, which has got 3 prongs at the end, also gets a good core. So I've been using both of them, and these seems to be dream needles nowadays, and you have a wide choice now. So the needle selection is, you can go for a practical one. There are some default, and then there are some exceptions. So as I mentioned, 22 gauge will be your default needle what you'll go for. 25 gauge FNA or FNB can be used in difficult access, especially when you are trying to target smaller lesions around the uncinate process. Then 25 gauge needle makes a difference. 19 gauge needles we rarely use. We use it when especially in patients where you're suspecting a lymphoma and so on, where the hematologists always want big quality specimens for that, and hopefully those sort of situations you use it. And the FNA needle I hardly use nowadays unless I'm sampling any cystic lesions, and you can use it sometimes when you find very hard pancreatic tumors and you're not getting a good sample or bouncing off with your FNB needles, then you can use the FNA needle, which will be a bit more easier to puncture it. So it depends on what what the pathology is looking for and how you're doing it, and also whether you got on-site cytopathology or not. So the targeting is important because the pass is only as good as the window what you get. So if you're not getting a scope to the right angle, then you're not going to be getting a good sample. So having a stable position of the scope will make a big difference. Minimizing torque, not having too many locks put in there also makes a difference. And use the elevator in a way that it is not forming too much tension on the scope. Always using the Doppler to ensure you have a safe passage is important as well. And if there is any vessels in between, not to compress it too much. You can falsely compress the vessel and making that there is no vessel, but actually if you back off from it, you can see the vessel there. Tip visibility, as I said, nowadays the needles are all quite brightly seen very well due to the texture of the needle being used and the dimpling effect what they have, so it's easy to see them now and make sure that it's seen. And also to go for the viable tissue rather than necrotic tissues. All these things you learn as you keep getting more experience. Finally, try to go to the shortest, safest route, which will give you the diagnosis. So let us talk a little bit about the sampling technique. We all know now the fanning technique is the core maneuver what you'll be doing. Now the Florida group had shown it, and quite a few other studies have been done, and the EAGE also recommends it as the standard way of how you would sample. So try and start it from the one corner and then work your way through, and you can do it by rotating the scope or even using an elevator. And you need to redirect deliberately, taking the needle back almost to the edge of the tumor, and then coming back is important rather than twisting it, which will twist the needle. And then finally, the suction choice. There have been lots of studies in this particular area, and currently what I personally do is a slow pull technique, or you can also use a wet section, but slow pull technique does it good, and it's also recently been strongly recommended by the ESGE 2025 guidelines. So these are some simple things what you can do which can optimize your sampling. Now we'll talk a little bit about the presence of a cytopathologist or not, or whether you can yourself assess a specimen. So US guided tissue acquisition, when you talk about it, we are talking about whether you are assessing the specimen yourself when you do the sampling, which is MOSE or macroscopic on-site evaluation. Especially with the FNB needles, where you express it on a slide and have a look at it. It should be about at least 3 to 4 millimeters of whitish tissue what you see, and macroscopically you are happy that that is a good sample. This is easy to do, it is not expensive, and many of the units use this. The ROSE, which has been around for a long time, and especially more important for cytology, is the rapid on-site evaluation. Here what you do is you have either a cytopathologist or a cytotechnician around you so that they can give you a feedback immediately of how the specimen is, and sometimes they may even be able to give you a diagnosis. So I use ROSE on a regular basis because it's available, and it makes my life easy, especially when we are targeting lesions and to redirect where we are going. So let's talk where it will be useful. If you look into head-to-head comparisons, there is no big difference. The diagnostic accuracy is not different, and so the question comes into, do you really want to use it? It can be a practical surrogate, especially the MOS for ROSE when you're in solid lesions, especially if you're getting a good sample and you're able to see it. But if it becomes bloody, if you're not able to see it very well, then it becomes an issue. And also, when we have ROSE, then you can decide on the cytology how you triage the sample. If you think that it could be, for example, a couple of months ago, I had a patient with a mass in the pancreas, and it was tuberculosis. So that makes a big difference. When the cytologist had a look at it and said, it doesn't look like a straightforward adenocarcinoma, it might be something else. And those are the cases where you think about what sort of samples you're taking and where you're sending the sample. But this is not often, but it can happen. So this is one of our cytopathologists having a look at it. The value comes in when you look into the adequacy of the sample and also having a feedback that I'm in the right place. Sometimes when you do the sample and then the cytopathologist tells you that it looks like it's a lot of necrosis, can you go in a different angle, in a different area, you might get a better sample. So that way you have a feedback, so it is helpful. But as I said, it is a bit more resource intensive and it's more expensive. So if you have it, you use it. But if you don't have it, you don't need to lose sleep for that. So my balanced approach based on evidence is that it remains valuable when immediate cytology or triage can be done and it will change the management. For example, I told you for lymphoma or infection like tuberculosis or sometimes even autoimmune pancreatitis. But most is simple, inexpensive, and evidence supports that it is as good as having a ROSE on site if you are using FNB needles. With the modern cutting-edge needles, routine ROSE is unnecessary, and you can continue with your on-site evaluation. How many passes? If you are using the cutting edge, the cutting tip, FNB needles, 2 passes is good enough, and you can see it very well, and that should be good. However, if you're using FNA needles, because you don't have an FNB needle, then you would need to have at least 4 to 5 passes to get it, and that is the current guidelines as such. Next is specimen handling. How would you handle the specimen? Because it's important, it's a precious specimen what you're getting. It's important to know that you handle it delicately, you express it using your stylet or a slow push. You can use the saline or air as well, and it is important to do that. And you can also see the visible cores. It's important to ask the question, put in the information as much as you can in your request forms to the pathologist so that they know what they're looking for. And obviously, if you're going to be using next-generation sequencing, then additional samples need to be taken, or other ancillary containers needs to be done for flow cytometry if you are looking for lymphoma. So that's important to handle the specimen depending on what pathology you're expecting or what you're trying to answer. So this is one of our own patients here. You can see when you do your FNB and you have your on-site cytopathologist, I tend to do ask them to tell me whether there is a diagnosis there or not and what they're seeing. Do straight away a cytology here, and adenocarcinoma, and then there's a core biopsy. You know you're in the right place, and then you go on and do it, and that you can use it for as a histology and put it in a formalin pot. The quality of the specimen is important, especially for if you're looking for next generation sequencing, and this is a nice good core what you can get with these biopsies, and before that a touch imprint cytology. And next, let us talk a little bit about biliary tract lesions. When you're looking at biliary tract lesions, you are mainly looking at the high-level lesions, what you're going to be sampling, because if it is no mass seen and it's an indeterminate stricture, then it is more often towards ERCP, brushings, or cholangioscopy. But if you're seeing a mass in the hilum, then that's when it helps, or if you're seeing any liver masses. But however, when you are seeing masses in the hilum, then you need to think about resectability and also transplant issues. So it's important to have that discussion with your oncologist and your surgeons to make sure that that's what they want you to do. So it's important to do that as well. And EUS can be very valuable in these sort of scenarios. The special scenarios where the tissue will make a difference in chronic pancreatitis, and when there is a mass, then you want to rule out whether it's inflammatory mass or it is a malignancy. Again, having a core biopsy needles will make a difference here, and also having an on-site cytopathologist to differentiate autoimmune pancreatitis, neuroendocrine tumors, and the presence of myeloproliferative disorders and lymphoma. Sometimes when you have a cystic component, it is important to go towards a mass within it rather than within the cystic area. So the right answer is not always another pass into the mass. It is about the pass what you do at the right spot within the mass. That's what makes a difference. So when the result is non-diagnostic, what would you do? It's important to go through this step. First, you need to review why it was non-diagnostic, and next, you need to correlate it with your imaging and your blood tests, etc., and the way the patient presented. And then, if you're going to be repeating it, you need to repeat it smartly. It might be that might be a situation where you might want to have a cytopathologist on board with you, so that you don't need to be doing too many passes, or you don't get back negative ones. And finally, if still there is a suspicion, then you need to think about other modalities, how you would manage the patient. So it's important that a benign initial specimen will rule out a malignant process, and you need to review the whole picture for the patient as such. And now a couple of slides on quality, how you would measure it. Pre-procedure discussion with the patient and an MDT is vital, because your thought process starts from the time you talk to the patient as well as with in the MDT discussion. So it's important when even doing EUS, especially pancreatico-biliary is part of the upper GI stroke pancreatico-biliary MDT. During the procedure, using the right needle, Dopplers, the specimen handling, and then finally auditing the outcomes and your adverse events and readmission rates is important, and also have a good feedback loop into it. The metric should be not diagnostic accuracy it should be diagnostic accuracy per pass, not just a diagnostic accuracy per procedure. So that's where you need to raise your bar towards. Best practice algorithm, I already mentioned in the last slide. In the interest of time, I'll go into the next slide, which will be the final slide. So a concise best practice checklist, MDT question, try to answer what is being asked in the MDT, biopsy the safest and the place where you think is the maximum yield you have. Cutting edge, the cutting end FNB needles are now the default, and in special scenarios you can use different needles. The slow pull or wet suction would be the technique what you should be using. 2 good FNB passes is good enough. Morse is also good enough for most of the scenarios unless you have availability of rows on site. And cores are often put in formalin, which is better to preserve them. When you are looking into atypical areas, say for example hilar masses and liver secondaries, then make sure that your oncologist and your surgeons are happy that that's what they want you to sample. And finally, auditing the whole process is important. So the best practice is equivalent to best target, best core, best handling, and best communications. I'll leave there and happy to take some questions. Thank you.
Fantastic. Unless there's any, that was fantastic, Chris. Thank you very much. We're running slightly behind schedule, so I think Nam said his fellow will present the first case now today on pancreatic cancer sampling. Thank you very much.
1 second, please. Hi everyone, my name's Tracy. I'm one of the gastroenterology trainees at Royal Adelaide Hospital. Thank you all for coming. We are presenting the first case in Tech Suite 3 at the moment, which is a 34-year-old lady who has a past medical history unremarkable apart from hypothyroidism, and had an incidental finding of a perigastric mass from a CT scan that was done for chronic diarrhea. Her blood tests were unremarkable, and her CT showed a 34 by 25 millimetre lobulated structure without convincing enhancement, which is seen between the lesser curvature of the stomach and the left lobe of the liver, with no internal calcification. We are proceeding with an EUS with FNB for this perigastric mass, and I'll pass over to Tech Suite 3. first case of the day. We'll be faster now.
Can you hear us? Or
We can. We can't see you on the screen at the moment, so we're just getting that up.
see you on the screen, but you can hear us?
We can hear you. Can you hear us?
So we'll wait for the feed to come in. Can you sing out when you can hear us, please?
Do you have the EOS image?
No, they can't see us.
We can see you at the bottom.
Tracy, do you have
move that to
anything
the
on
bigger
your screen, like the endoscopic image or the EOS image?
We can see you, Will, but not the US.
Ah, okay, thank you. So you can see the room, yeah?
We can see the room in the small version.
Okay, great. So we can see the room. I'm just going to quickly introduce Sandeep again, and we've got a whole cast of thousands here. We've got Christy, our superb anaesthetist, and Hanjun, and then we've got 4 nurses. We've got Brody, we've got May Kura, we've got Sunny, and we've got Tegan. Can you see our endoscopic image?
Can you?
Just hold on for a second, Will. You're very small. We'll just see if we can get you onto the main screen.
I'm very small. All right, okay.
But
Okay.
Yeah,
How are you going there?
yeah. Just a second. The CT scan.
so we want that screen to be on the big one, the one with little people on.
Well, you're going to either have over there the camera or the content. So as soon as
We just want the camera.
We just want to share that camera. The main screen. Yes. Yes. Thank you.
We can see you now, William.
Now, thank you.
Great,
Thank you.
So Sandeep is always smiling, right? So
Because I'm standing here.
But if you've seen Sandeep sharing or instructing, he's always smiling. He's a great teacher. He's got this great ability to put people at ease. So I'm actually at ease now. So can you see the EOS image? Can you see the EOS image?
Yes, we can. Thank you.
Okay, so this is using the Olympus top-of-the-line Amplio machine.
It's wonderful.
It's a wonderful machine.
It's the Ferrari of endoscopy.
So he's got a whole host of things. It's amongst the one thing I noticed is that he's got a quantitative shear wave elastography, which I think is one of the standouts. But also, it's got this SMI, which gives you excellent microvasculature sort of imaging. Now, we started looking at the pancreas really because of the history of diarrhea, and there was some suspicion that there is pancreatic insufficiency. So I think looking at the pancreas, Sandeep, what do you reckon? The pancreatic duct looks okay to me?
It looks quite fine.
It looks fine. The
Parenchyma is
also-
okay, except for occasional strands here and there. So
There's some hyperechoic strands, isn't there? But it's not shrunken to
yeah,
me.
I just use the arrow to just show the audience. So these are the few strands that we are seeing.
The
This is
hyperechoic strands,
and that's
yep.
the duct.
That's the
That's the
pancreatic
duct.
duct. And you can see the pancreatic duct coming down here
Yeah,
into
yeah.
the neck.
It's a little prominent, but I think it's as an isoechoic wall. So
We
which
can
is
see, we can measure that. That's
yeah.
in the neck. It's
yeah,
it's okay.
that's quite okay actually. Yeah,
So that's
normal duct.
So we really cannot see anything there to incriminate a pancreatic problem. Now, if you guys seen the CT scan, that CT scan was done 3 months ago. So can you see this? Do you remember the scan?
Yeah.
You remember the scan? So that scan measured the mass at about 3 centimeters. This fast forward 3 months later, and by the way, we're not using any balloon on here. So the mass should be somewhere here.
Touching is okay. Yeah.
There it is.
Yeah, there's a mass.
So there's the mass, Sandeep.
Yes.
So the mass we've measured already, but the mass does not look anywhere near. So let me just freeze it for you.
So it looks to have significantly reduced in size in over 3 months period. Yeah. Can you appreciate the mass? This is a hypoechoic
So this is the
lesion.
mass, and you can see the measurement is, if we measure from there, it's about 15 millimeters.
Yes,
It's actually
yeah.
shrunken in size. So what are the possibilities here that
So
we're
that
dealing
makes
with?
me think that this patient, this is an inflammatory lesion which is reducing in size. One, it was asymptomatic and incidental finding.
The patient had diarrhea.
Yeah, had okay.
The patient had diarrhea.
Yeah. So was it an infection causing a lymph node which is not shrinking, and diarrhea is gone now, William? Has the diarrhea subsided?
I think the diarrhea has symptomatically improved.
Subsided.
She has not lost weight. You can
Okay.
see she's still
Yeah.
a good weight.
Yeah.
So we won't use the quantitative, but we can try and use the
Let's show the
elastography.
SMI in it. I love SMI,
SMI.
on Apleo.
Right. So this is, I'll just put the macro
I'll help you.
vasculature. This is the, whoops, it's a small lesion.
Yeah.
So let's,
Okay.
SMI, there's not a lot of blood vessels, huh?
Yeah, that's very nice. So otherwise SMI picks up very tiny blood vessels. So this is
Not a very
not vascular then.
Yeah. And you can see the normal sort of, that's the normal macro sort of.
Yeah. This is the normal Doppler, the
This is
red
the
and
normal
blue color.
Doppler.
And microvascular imaging shows the tiny blood vessels.
So this is not a vascular lesion, which is somewhat against an inflammatory process. But
Yeah.
I don't think this is a GIST, because GIST will not reduce in size.
Yes, yeah,
in my
absolutely,
experience.
yes, yeah.
I'm trying to see whether it's actually connected. Does so Andy, Linda, and Ken, does the panel have any thoughts for what could be this lesion?
William, would you like to do the contrast enhanced imaging, which is an equivalent to SMI?
Yeah.
Before this, yeah.
Which one is it?
Yes. Yeah, it's outside the stomach wall, so GIST is virtually out, and any tumor now is out of differential diagnosis because the size has reduced. We have the advantage of two imaging 3 months apart, and the size has reduced, which kind of gives us a fair idea that this is not a tumor we are dealing with, but what it is we don't know.
All right, I think it'll be interesting to do the contrast imaging.
Okay, so we'll do a contrast
can we do the
injection.
contrast?
You're using SonoView?
Okay.
Or?
No, we're using Definity here, aren't we?
Okay, so we have a different.
we don't have SonoView here.
Okay,
We have Definity.
So the setting here exactly is for Definity. Harmonic is exactly the best imaging that we have.
Okay, okay. So
Yeah,
we have
SonoView is not available here.
Okay, okay.
Yeah.
So this is a PIP
All right, so
image.
we're about to start, and you can just see whether there's any
vascularity.
uptake. Can we turn the video on just so that we can? Thank you. What do you think there, Sandeep?
Nothing coming
No?
up so far. Otherwise, we'll see some white bubbles coming inside.
There is some intake,
maybe
but
in
not
the
a lot.
periphery.
Maybe in the
but nothing coming to the center as yet.
That's right. So you can obviously see. I'll take this picture as well.
Okay. Yeah.
Yeah. So I think we can say that this is uptake. If this was in the pancreas, we would be worried, right?
Yeah.
So this is not. I think we can say this is not in the pancreas.
Yes.
This is something sort of outside the stomach. So based on that, does that narrow the differential diagnosis for us, Sandeep?
Yes. So it's a non-vascular. No, something happening in the periphery. What's
Yeah.
it?
Oh, so did you want to have a look at that again?
Maybe a late blooming. You can see some. No, not inside. It's outside. Okay.
Yeah, it's.
So everything is outside, which is like.
So we. Contrast,
yes,
we could use SMI as a good clue.
In fact, after Apleo has come, the requirement for contrast enhanced imaging has gone down substantially.
Yeah. Do is we can do elastography and see whether this is a hard lesion or not.
Yes.
So let's just do that. And we'll just make that a little bit bigger.
Yeah.
And then we'll just do elastography and see what it looks like.
So we'll see some colors there on the as we abut it little firmly. Yeah.
All right. So
a little
there you
more
go.
Blue. Yeah.
So
mostly
it's actually
blue.
quite a stiff lesion, huh?
Yeah. Okay.
So so that's interesting. So it's so we get the next step. We really can't see the muscle. It's not.
It's
not
outside
a
the
gist.
muscle. It's outside the
not,
muscle.
Yeah, it's not a gist. It's something that.
Yeah.
Absolutely, it's hypoechoic. Yeah.
So what's the differential you would also consider? Sorry, maybe I can take the audience poll.
Yeah. So maybe the audience would like to have a guess as to what this lesion is likely to be. It's an unusual lesion, isn't it? Okay, so I think we will probably...
okay, so let's FNB
let's
and
FNB that. So we're going to try the new needle. Yeah, there is this on the left margin. If you go on this left margin, there is an edematous wall here, isn't it, on that left margin?
You can use
I think the arrow's here. The arrow's here. Oops.
You can use
Maybe. Oh, sorry.
Otherwise, use this ABC. This also gives an arrow.
Yeah. So, Tracy, I have to defer to Tracy.
So
neuroendocrine tumor, but neuroendocrine tumor should actually
they are very, very vascular.
They should be very vascular. Be very. So Sandeep, we're going to use the new Olympus 22 gauge secure flex needle. So we're very happy with this needle.
Yes.
And there's a nice picture of you on the pamphlet in AIG. So you're one of the clinical trial centers of this. Do you want to tell us about the shape of this needle?
So the needle has a fork tip at the end. And
I believe the actual term is a dual beveled raptor.
Yeah. That's
I think they've actually spent some time coming up with the name, right?
And it's
so
very flexible.
Bevel, so it's got two cutting surfaces.
Yes, two cutting surfaces.
And the raptor sounds good too.
The most important thing is it's very flexible. This is the sheath, the metallic sheath is very flexible, so you can go in
So it's a nitinol needle.
Nitinol needle.
So it's kink resistant. But actually what Sandeep was talking about, I don't know whether you can zoom in.
You can keep it next to you.
Sheath,
keep it next to this, and then the camera
the sheath is actually a coil sheath. Now this is actually quite unique because I think the Easy Shot, the Olympus Easy Shot, which we can probably showcase later, is also the other needle that has the coil sheath.
It's the same coil, which is so it allows us to go into different
so that to me is a great advance because it just maintains the position of after you biopsy. So even if you're D2 and all that, so it doesn't actually in that sheath too much. All right, so we go ahead and do the biopsy.
So don't worry about this tiny vessels which will be on the way.
2 minutes. Okay. So the other thing, if you can zoom in, this is a metal-to-metal thing. So it feels very satisfying and very secure when you lock it in place. Right. So I'm going to bring the sheath out a little bit. There's the needle. So it's actually the sheath.
Yeah, you can.
So it's actually very visible.
You can see the sheath on the.
So this one you actually have to pull up a little bit. And because it's a
here comes the needle,
so because it's quite a stiff needle, so we'll see whether that goes
sometimes
in.
transgastric FNA can be a little challenging because stomach moves.
You can see that. No, we're not, because we have utmost faith in the fact that we can get tissue with this. So. Nearly.
But we can also look at MOS,
we can.
The macro on-site evaluation of what is the length of the tissue that
and I think you demonstrate that in your thing. Okay, we're nearly in.
It's a little firm to enter.
Yeah, it is. As we know from the, it's nearly entered. Okay. Okay,
yeah,
so
now
I think
we
we're
have
in.
gone deep in.
Yeah.
We'll pull back and William will now take it back inside the lesion. It's overshot, but maybe, yes, we can come back. So that happens sometimes. It's not
I
a
think
problem.
because it's such a stiff lesion, sometimes we have to do the door knocking technique.
Yeah, yeah.
Oh, sorry, I pulled it out by mistake.
Okay. And plus, stomach is always a very, very flexible and a mobile organ. It doesn't stay there. And if the target is also moving, it makes it even more difficult. Unlike pancreatic tumors, which are a little
so that's
easier
in.
because at least the target is not moving.
Okay, so we'll take that up.
Yeah, okay. Now we see we're right inside. And
Full
now
suction,
pulling back
please.
the stylet. Yeah, it's a good idea to have suction because this is a firm lesion. The suction would get some more tissue. And since it is not vascular, we're not really worried about too much blood coming in. Unlike in a vascular lesion, we avoid using our negative suction.
Yeah. So it's not on, so we're going to
Okay.
switch this on. Yeah,
Yes,
because
yes.
this is a stiff lesion, I agree with the full thing because it's not a vascular lesion. I think for lymph nodes I would be different, but
Yeah.
this is not a.
Yeah,
this is
yeah.
a stiff lesion, a hard lesion. You can see the excellent visualization.
Very nice movement.
visual of the needle, so we
So
can
this is the
try and
skill
fan
of
it.
William, who's moving from.
So we're trying to see whether we can.
Is a fanning technique, so you can see the several paths the needle has taken. The white path.
Yeah.
The trajectory of the needle has moved from one side. So he's
There's a
sampling
bit of
as much of the
bleeding,
tissue
huh?
as possible. Sorry.
Yeah, there's a bit of bleeding because you can see the bleeding in the path, needle path.
Is it?
Well,
This is secure needle, Olympus.
so do you want to demonstrate the most on the petri dish?
Yeah, we can.
Can you get a petri dish?
With saline.
A petri dish so we can, with saline, we'll flush it out and see. Do you have a petri dish? We don't normally use thing, but we can demonstrate.
Or we can just put on saline and slide and see how is the white core, which looks like.
Okay. The other thing we simply do is we put it into the formalin and,
Yeah,
and
we
look
can.
at the beautiful
Absolutely.
pores that come out from that. So you can see there's a bit of bleeding in the path, huh? See that?
Yeah, maybe, but that's.
What do you think? Even though it's
okay.
see the white, we can see the.
So how many to and fro movements or actuations you would
I've
do?
forgotten because I was talking
Yeah,
to
I
you.
think maybe about
Are you keeping
15 or
count?
20. I can guess it.
Okay.
I think
All
that
right.
should be good enough.
I think that's
We've
probably
taken
good
the whole
enough.
tissue out from the coast, from the center.
Yeah. So let's do if we have the,
So
the
very
petri dish.
intuitively he locked the suction, and that's the right thing to do. Otherwise, if you're pulling back with the suction, you also get some blood and the on the way back.
So that's the first thing you do.
Yeah.
All right.
So
So
that's
that's
the
good. So let's push it
final
out.
level thing.
Have we found something like a petri dish or okay?
Yeah, thank you. I think it's there. Maybe the camera can go to the slide and see.
I think have they gone to the other room? Chris, have they
Okay.
gone to the other room? Have they gone
Otherwise-
to the other room or not? Have they gone to the other room? Oh, okay.
Okay.
Do you want to show the? No. So put it flat. Where's
just
May?
put the
Just wait
stylet
for
in,
May.
put the
Wait
stylet
for May first.
Stylet.
Yeah.
So gently expel the tissue on the stylet with a.
No, we'll come back and show you the tissue, Linda. Yeah, we'll put it out and then we'll show you the tissue.
Thyroidism, who presents with 9 months of epigastric discomfort as well as 15 kilos of weight loss. Her labs are significant for a significantly elevated CA19-9 of 893 and has a CT scan showing a partially necrotic, ill-defined mass in the Uncinate process, measuring 37 by 33 millimeters, encasing the SMA, obstructing the SMV and extending to a portal confluence. With a patent splenic vein and portal vein. The mass is at present a suspected pancreatic adenocarcinoma and planning to proceed with EUS and FMB. Over to text week 4.
Right, can you hear us? Sorry. Yeah, okay.
No.
Right, are we on?
Just 1 second.
You're on. We just can see you in a very small screen. We can hear you.
Okay, that's great. So, just like to thank Nam and the organisers and the nurses in the room for letting us present to you this case. I've got with me Vipul Agarwal from Canberra. We're going to do this case with this pancreatic mass, and we're planning to show you just some of the vascular staging, FNA. We're using a new needle that's new to both of us today, and we'll just hope to show you the core tissue, and then we'll just have some discussion points. So the interesting thing with this lady, so I'm sitting in the bulb. We just went to the bulb.
We're not seeing your
away.
endoscopic image just yet.
Endoscopic, EUS picture.
So no EUS image there?
Okay, we've got it now.
Okay.
Right, so this is the EUS in the bulb. Just you can immediately see there's a mass lesion. The interesting with this lady is that she's not jaundiced, and we can see the bile duct in the top of the image, and trace the bile duct up towards the liver, rotating my scope anti-clockwise, and you can see grossly dilated bile duct. So she's compensating for this with lots of sludge in the gallbladder, and it appears the cystic duct is not involved and joins the bile duct. And expect this lady to become jaundiced in the next couple of weeks probably, so we'll need to watch out. So once we trace the bile duct down, we can see this large hypoechoic, poorly defined mass lesion, solid. We can see some hyperechoic calcification in this lesion, and we can also see some other structures, particularly posteriorly to this lesion. So we might just freeze, and we'll get a measurement for this there to there. So that's 40 millimeters. It's very similar to the CT findings, and again 40 millimeters. Also in the posterior part of this, we'll just use the pointer. You can see there's a vascular structure that appears to be encased. If I rotate left with my scope, you can see the vessel heading towards the aorta. So this is the SMA, and it appears to be completely encased. So major vessel involvement in this mass. And if we go back to the top of the lesion, we're just rotating towards the liver again, and we're picking up the portal vein. We'll just get a vascular, you can see lots of flow in the portal vein. We'll take that off, and then when we rotate down, it appears that the vascular signal disappears, and that's the involvement of the SMV. So splenoportal junction, SMV, is also involved and included. So we've got a 4 centimetre hypoechoic mass, about likely to be a pancreatic adenocarcinoma with those features of the calcifications and major vessel involvement.
Where do you think is the anatomical location here?
So I think, interesting. So I think this is Uncinate process, very posterior, and the involvement of the SMA suggests it's sitting right down onto the retroperitoneum, and that's why she hasn't obstructed her bile duct yet, and it's growing upwards towards the bile duct. We're still sitting in the bulb. You could try and biopsy this from the ampullary version position, but we've got a very stable position here in our favour. It's rotating, so clockwise I'm rotating, and you can see there's more of the mass. You see there's more of the mass, and this is probably the best area for us to biopsy. So Vipul, do you want to just talk a little bit about the needle?
Yeah, we'll talk a bit about the needle. So I'll get up the needle from there. And
so
any questions or comments from the audience or panel? Sorry?
I think we could do contrast. This is so such a high likelihood of...
What about the SMI?
Would you like us to do contrast as well? Okay, so we'll do the contrast. Just help me with the settings of the split screen for the contrast on this machine. Yeah, so SMI, just Okay, so here you can see just...
So while we're agitating the contrast,
Yeah. Okay, Naam, if you can just show us the SMI on this machine, because just... Okay, there we go. Okay, so this is just...
I'll just do that.
This is just looking at, similar to the... and we can see this still got vasculature internally. So more vascular than I would have expected, actually.
I mean, personally, I find it very useful for neuroendocrine tumours. I think for NETs, you almost don't need to use contrast. If you have some eye out there, it lights up beautifully. I guess its utility in PDAC is somewhat more limited in terms of diagnosis.
Still very vascular. Yeah. Yeah.
Correct.
So interesting how vascular that it still is, and we'll see too with the... but the other features are all of pancreatic adenocarcinoma, so that would be the highest likelihood. So we'll take that off. We'll go back to the main screen. So we're going to use a new needle today. So the needle...
I'll just...
Vipul, can we have the needle just as a show while we're setting up the agitation? So we're going to use a Trident needle. This is...
so I don't know if you can get the camera focus out there. So this is a new needle from Microtech. It's called Trident, and it's triple pronged. I'll try and show the needle in a second. All the prongs come out of different lengths, which is an added benefit apparently for tissue acquisition. It's available in all three sizes, 19, 20, and 25. And if I can just grab the needle, both of that. So I think one difference is in terms of there are no rotating screws or bobs out there. It's a push button. Yeah, push that down, locks itself, and the needle comes out. The stylet just requires an anti-clockwise rotation to be pulled out. I'll put that back on. I don't know if I can show the tip of the needle at all. I'm not sure if you can zoom in for that.
It'll be quite small. Those prongs are really small. So let's go on and do the contrast, please. Have you got contrast? So we'll just put the contrast on, and then we need it. So we'll just... Yeah. Okay, we're getting the injection now.
So I'm told this needle is available in the market now. I haven't personally used it, neither has Frank, but I think it's been used here in South Australia.
Okay, so the injection has gone in, and so to 20 to 30 seconds, we know that the portal vein is the most vascular part here, so we'll just rotate up to the portal vein, which we can see the contrast going into the portal vein, and then if we rotate to the tumour, and again it's more vascular than I would have expected, really, to be honest, which is quite interesting. And it will be interesting to match that up with, and there we go, now we can see hypoechoic lesion, some vessel, but not to the extent that a neuroendocrine tumour.
Correct.
We would light that up within 20 to 30 seconds, and we're up to about 50 seconds now, so there we go. That's the obviously some feeding neurovascularization. But
Frank, does that influence you how you approach your FNB, or not really?
Not really. I think we're just using normal. We'll use normal Doppler to get the best view of that. So that's a nice view. It confirms that we think this is a pancreatic adenocarcinoma on those features.
Store that.
Okay. We've got a picture there, so we'll switch back and we'll do the FNA now. Okay, while I put the needle down.
What's your technique for adequate tissue acquisition, Frank?
So technique, as with all of these, teamwork, the nurses will help. I like a slow pull, just to ensure that my needle is going to come across the... There we go. Set it at 1. Okay. And just go for Doppler. Just make sure there's no major vessels. I think we can avoid those by rotating slightly towards here. We'll take that off.
And do you do anything
So
else?
at the top of the needle, so you have, this needle is blunt, so we have to, before we come out, we'll just rotate left, slight pull back, and now we can come through with the needle. So there the needle is hypoechoic, and so I think that's a good position. I've got fairly small hands, so in terms of the depth, I don't set it. I use my length of my hands, and then puncture, just rotating. And
So
as I was told by the Microtech rep, there's a little bubble trapped at the tip, which actually tells you exactly where the tip of the needle is. So we can see nicely.
If I freeze that, actually, if you just bring that back, it's actually quite well demonstrated here. If you see that right at the tip of the needle, you see this very hyper. It's a very echogenic out there, and clearly defines the tip.
Okay, so let's do our. We'll do the slow pull now. So with every slow pull, with every going.
Do you do that
pull.
every time, Frank? Do you use slow pull for all your
Pull.
FNBs?
Yes, I do. Yeah, pull. Very sharp needle, very easy actuation. Try and keep the needle nicely in view with each.
And do you believe in fanning? Do you believe, or you have a number of passes,
I think fanning is good. Obviously, this is a FNB needle. I think a lot of the fanning came out of the FNA data. We'll see with our first. Okay, and stop. That's enough.
I guess
and we'll come
the only
out.
other thing was there was an area of necrosis within that mass. And
yes, there is an area of necrosis. So we'll just get the first pass processed. Any questions from the audience? Anything that's contentious at this moment? Yes, absolutely. Yes. As I showed you in the beginning, so the SMV is gone, but I think most importantly, we'll just use the pointer. Just posterior, right down here, you've got complete encasement of the SMA. You've got tissue on both sides, and if I slightly go anti-clockwise, you can see the vessel disappear, going there towards the aorta. That's the SMA coming in. It's quite posterior, so you can see there's SMA and involved, completely encased. Interestingly, we did scan her before, and she doesn't have any liver involvement, so it's all localized, locally advanced. This is not resectable. She's 79. We also know from the CA99 there's predictor of prognosis. So if there's no other contraindications, she'll go through the MDT and have a discussion.
Yeah, so I guess one of the things is, if you look at the gallbladder full of sludge,
yes,
and I think there's an impending biliary obstruction in this lady. Her bilirubin apparently is normal right now. She's not jaundiced. I guess if she is going to undergo chemo or any other treatment for that, would you at this stage consider any RCP, or would you wait her to get jaundice? I guess in terms of logistics, because
we'll do another pass.
The oncologists don't like interrupting.
We've got a good sample there. Yeah. Okay. So we'll do another. So we'll just look. Victor will show you the sample.
I don't know if the camera is able to show you the sample out here, and it's a pretty good core. White, not always red. A red indicates usually the clot. So you want to see the fibrous white tissue, which I think what it is. And so you should get a good histology sample from the NAM. Will they be able to do that today?
Sorry?
Are we going to be able to see this later today?
No. Tomorrow.
Tomorrow.
Yeah. So it's all core.
Yep.
Yeah.
Yeah.
So we could.
And how many, Frank, how many passes do you do if you get a nice big core, which it looks like you have?
Well, I think we could get diagnostic tissue that this is cancer, but you know, in this age, we really need to look at getting enough tissue for sequencing. If there was any additional chemotherapy that they wanted.
Yeah, that's right. I think
usually I always we have the opportunity to get good tissue, so I think the number of passes to get a diagnosis of cancer may only need to be one.
Yeah.
But I think in this day and age, I think we should do 2 or 3 passes
I agree.
to
I
get
did
sufficient
about 2 or 3
tissue.
too, because they do like to save some for molecular markers.
Yeah, exactly.
But just going back to the needle, looks like a very good sample out there. So n equal to 1, but it looks pretty good.
So we'll do the same with the negative pressure, negative suction. That's great. Okay.
Thank you.
Okay, thank you very much.
Show their cause, otherwise in the interest of time we might move on to the next presentation. Thank you. I think we'll switch back to the presentation.
Okay.
Just for
All right, we're just coming back to the presentation now. So it gives me great pleasure to introduce the next speaker, who is one of my mentors. Dr. Milan Bassin is a consultant gastroenterologist, therapeutic endoscopist, and head of department of endoscopy at Liverpool Hospital. He undertook his general gastroenterology training in New South Wales and then went on to advanced therapeutic endoscopy at Westmead Hospital and St Michael's Hospital in Toronto. And today he'll be talking to us on pancreatic cystic lesions, which one should be further investigated.
Right. Thanks for the introduction, and thanks NAM and AEG for inviting me to give a talk, especially a talk not on GI bleeding. It's a nice change. So I've got no conflicts of interest to disclose, and this is, I guess, a subject that is fairly basic. There's no high-end fanciness, there's no new expensive device or technology, but it is a very bread and butter core area in pancreatico-biliary endoscopy and a big part of our work. So pancreatic cysts are important, firstly because they're common. They're usually incidental findings, maybe 15% of abdominal imaging now, maybe even higher, and as imaging technology gets better, the rate of incidental cystic lesions in the pancreas increases. These lesions are important because some of these cystic lesions at least are going to be precursors for pancreatic ductal adenocarcinoma, and a small proportion of these will have malignant potential even at the time of diagnosis. And that finding these things, nowadays patients have their scan, they get a link to their report, the patients see their report before they've even gone back to see their GP, let alone been referred for specialist care, and they see pancreas cyst, pancreas lesion, and there's this tremendous anxiety that it leads to. And you know, the awareness in the community is increasing because of advocacy groups, but probably also because of celebrities who've had pancreatic malignancy in various forms. Jerry Springer, I think, being my personal favourite. And so it comes down to, you know, what can we do about these patients? So if we couldn't do anything, why would we follow them up? And we have these different pathways, and you head down this observation or the surveillance pathway, and these are the patients, you know, you say, well, these are the ones we follow up. You have the patients where you can intervene, and that is generally surgical resection. I'm not going to go into details about ablation, but that's another sort of potential pathway. And then the lesions that you ignore and you go, well, that's interesting, but move on. And so how do we work out which pathway we're heading down? And you've got to look at factors related to your patient and then factors related to the cystic lesion itself. And the first thing is, with your patient, are they actually fit for intervention? If they have frailty, if they have severe comorbidities, the risks of intervention are unacceptable, then surveying these patients probably isn't of any great benefit. And then the flip side is, do the patients have factors that predispose them to a higher risk of malignancy? And if you have situations of chronic pancreatitis, underlying familial or genetic syndromes that increase the risk, or that sort of small cohort of patients where you don't identify a gene, but they have very strong family histories, you're likely to follow these lesions more aggressively. When we look at factors in the cysts, we're looking for factors that will predict either a high risk, a low risk, or a no risk of malignant transformation to then guide us in our pathway. And that really is that we're trying to establish what type of cyst there is, and then whether there are features of advanced neoplasia already present in the cyst at the time of the initial diagnosis. And so classically, people talk about cystic lesions as mucinous and non-mucinous lesions. By far and away, the most common mucinous lesion is the IPMN, and again, we need to distinguish between the branch duct IPMNs, which are the most common cystic lesion and generally carry a fairly low risk of malignant transformation compared to those involving the main pancreatic duct. Mucinous cystic neoplasms are the other mucinous lesions, and then the non-mucinous lesions, which range from pseudocysts to serous cyst adenomas, solid pseudopapillary tumours, cystic neuroendocrine tumours, and then a variety of other various benign non-mucinous lesions. I think maybe a better way to think about this is the neoplastic and the non-neoplastic lesions, because in non-neoplastic lesions, especially when we're thinking about risk of malignancy, we can already write off, and then it's the IPMN, the mucinous cystic neoplasm, the pseudopapillary lesion, and the cystic neuroendocrine tumour that we're looking at as our key sort of potential high-risk lesions for ongoing surveillance. So how do we distinguish these various cyst types? And the key things are actually the clinical and the radiological features. EUS, this is an endoscopy meeting, but EUS, I think, in the initial workup of the cyst comes in late and doesn't actually play that big a part. The clinical features are key. As with anything, you've got to put it into the context of your patient. Firstly, do they have a history of previous acute pancreatitis? So a large cystic lesion in a patient who's had acute pancreatitis and had a CT for some reason 3 months before and a normal gland before that, it's a pseudocyst. You probably don't need to pursue that much further. Patient demographics play a key because this will help guide us in terms of what the likely diagnosis is, because different lesions do appear in different ages and with a different sex distribution, and then a history of underlying genetic conditions that may give us a clue as to what the underlying lesion could be. The radiology is key. Most of these patients are detected on CT, and usually it's a CT for an unrelated cause. So the patient will have had acute diverticulitis, for example, or renal colic, and so those scans are normally either non-contrast or single-phase studies, so they won't give us the full information we need, and so we move on then to gadolinium enhanced multi-phase MRI, and this is the best diagnostic modality for imaging. It'll help characterize the cyst, communication with the pancreatic duct, the enhancement in the arterial, the portal venous, and the delayed phase to look for these high risk and worrisome radiological features, and I'll talk about those more in a moment. And then when you look at surveillance and you've now got a baseline, the contrast is not so important. And probably up to about 80% of cystic lesions you'll be able to accurately classify and work out a pathway heading forward just on the clinical and radiological features. EUS isn't required for a diagnosis. And so when you look at the characteristics, and this is from a really, really good review article in NEJM from 2024, you have typical characteristics for these lesions based on both the clinical presentation and the radiological finding, and then you can move on to what the potential malignancy risk is with these. So pseudocysts, you've got the typical history, low risk. Serous cyst adenomas, again, extremely low malignant risk, and if you find all these typical findings, then you can reassure your patients and you probably don't need to survey them further. But it has to be said, only about 30% of people will have the pathognomonic calcified central scar and the microcystic appearance. IPMN, it helps us both in sort of determining whether we think this is an IPMN, but also the type, whether it involves the branch duct and the main duct, and these carry very different risks of malignant potential. Mucinous cystic neoplasms are almost all in women in the 4th to 6th decade of life, tend to be in the tail, and again, if you see the eggshell calcification, this is almost pathognomonic, and you'd often be heading straight to surgery. For these, similarly with the solid pseudopapillary tumours, younger women with this very heterogeneous appearance and a mixed solid cystic lesion, again, you're often going to be going straight to surgery, and then the intense arterial enhancement in a cystic neuroendocrine tumour. So I thought we should talk about EUS since this is an EUS meeting. So the role of EUS as a diagnostic modality is really where you've got an equivocal diagnosis on clinical and radiological grounds. You've got a lesion that you're not quite sure what it actually is. If you have a lesion that you think is sitting in an intermediate risk group, then maybe this will help in sort of enhance your risk stratification, or whether you need sampling either to confirm the type of lesion or assess the grade, and whether that is to get your patient over the line because they need more convincing to undergo intervention, or you need to get your surgeon or your MDT over the line because they need convincing and they need more intervention. And unfortunately, I think we do probably too many EUSs to get a diagnosis where it's probably not so necessary. For low-risk cystic lesions, where you've got a clear-cut radiological diagnosis, and if you have unequivocal high-risk features, then I think EUS is not always necessary. It doesn't really add much. It probably won't change your plan of management, and this is where MDT discussion and good working relationships in your MDT are important. So where do we go from here? If you have a non-mucinous lesion, then your next steps very much depend on what you've predicted as your diagnosis. If you think it's a pseudopapillary tumour, a cystic neuroendocrine tumour, then you can look at the EUS. Generally, if there's a solid component, target that for an FNB, but FNA if required for getting fluid, and looking at the alternative of upfront resection. If you have an indeterminate lesion, this is where EUS and FNA and aspiration of fluid from the cyst will be helpful to then distinguish between a mucinous and a non-mucinous lesion, and particularly the setting where you may be dealing with a pseudocyst rather than an IPMN. And then moving on to, I guess, the biggest group, which is the mucinous, and I say presumed mucinous lesions because a lot of these lesions are small. They will never be sampled. They'll be surveyed for years or decades. The patient will die, and they'll never actually have a definite diagnosis that they had a mucinous lesion, but the data, post-mortem studies, that sort of thing suggests that the majority of small cystic lesions in the pancreas are small branch duct IPMNs. So this is the latest sort of consensus guideline on management of IPMNs. There's the Kyoto guidelines published in Pancreatology in 2024, and they look at this concept of high-risk stigmata, and this is based on primarily the MRI. So high-risk stigmata are the sort of highest level features. These are, if you like, the features that suggest you should be looking at upfront surgery. You may have EUS as your adjuvant to help push you into there, but it's the things we worry about. Patients with obstructive jaundice, marked main pancreatic duct dilation, the enhancing mural nodule, and if you look in the text, there was a bit of debate about whether 5 or 10 millimetres should be the cutoff for this, and if you've done cytology and you've found high-grade dysplasia or cytology that's suspicious for malignancy. If you don't have these high-risk features, then they have these kind of second-tier worrisome features, which are both clinical as well as imaging based, and these are the sort of things that really should raise the red flag that you need to look into this further. And in the young healthy patient, especially if they're getting recurrent bouts of pancreatitis because of their cystic lesion, maybe that is going to push you towards heading to an early surgical approach. And these are just some of the sort of radiological type findings. And what we want to try and end up with is this concept of cancer risk, and using our imaging, using our clinical features, things like the CA19-9, glucose or HbA1c, markers of new diabetes, to then stratify our patients into high, intermediate or low risk, to then determine their surveillance pathways. So using a US for these lesions, there is a role, especially if you have a radiological solid area and your patient's not going for upfront resection. So that's what you want to target. So an enhancing nodule or a solid component, if you can get tissue from there, that is going to give you the best information, particularly around the grade of the lesion and the presence of high-grade dysplasia, which is going to be pushing you to surgery if the patient is a candidate. Fluid aspiration, which our traditional sort of testing is helpful to distinguish mucinous versus non-mucinous. And the first thing comes when you put your needle in and you aspirate. And you aspirate and you switch on your suction, and your suction syringe just looks dry and there's nothing there, and you go, hang on, I can clearly see my needle in there. Switch off your suction, come out, push some air through the syringe, and you just get mucus coming out. And that's a mucoid lesion, because often you'll send that for CEA, glucose, whatever testing you want to do, and your lab will say not suitable because the specimen's so viscous. But that is a mucus, it's a mucinous lesion. You've already established that diagnosis. But more importantly, with cytology sometimes, but primarily with molecular techniques, you can then also risk stratify better. And so, we in our unit don't have access to any of these, and I'm not sure how easily accessible anyone has to some of the genetic changes associated with advanced neoplasia. But not only are you looking for things like KRAS and GNAS as markers of a mucinous lesion, but looking for features that suggest an advanced or high-risk finding. So going back to the initial question of pancreatic cysts, who do we follow up? Well, the patients who you can sort of let right off into the sunset, those who are not fit for surgery or intervention, especially if there's low-risk features, because they're unlikely to progress in their lifetime. Probably not even if they have high-risk or worrisome features, but this is where shared decision-making with patients, families, carers is important. Once you've proven a pseudocyst or a serous cyst adenoma, and once the patient's had resection for their mucinous cystic neoplasm, you then have the group that are heading off for resection. So they've got pseudopapillary tumours, mucinous cystic lesions, high-risk IPMN, cystic neuroendocrine tumours, or where your combination of results, it's not quite diagnostic, but the cystic lesion looks like it's a cancer that's just necrosed and you've got cystic degeneration. And so then we're left with this group of patients to survey. And one of the big problems in surveillance is not who to survey, how often to survey them, but when to stop, because there's lots of evidence about progression for advanced lesions, but the natural outcome of small lesions is really not well known and not well understood. And you have various guidelines and various studies with very conflicting results about long-term outcomes. Some studies will say after 5 years, a sub 20 millimetre lesion that hasn't changed will never change, leave it. Others will say 15 millimetre lesions have significant progression risks in the 5, 10, 15 year time frame, and they need to keep getting followed up. And this is why all the guidelines essentially are just expert consensus on particularly stopping surveillance, and also the fact that you don't end up getting a definite diagnosis for most small cysts, so you have to just assume that they're IPMN. The timing of surveillance, and I'd recommend you look at the Kyoto guidelines. It gives you a nice rundown of different sort of timings. Every guideline's different in terms of their timing. But I think the big thing in Kyoto is that MRI is now pushed as the main modality for surveillance, and that CT and EUS are adjuncts to help when there's change. They put this caveat in, I think, to accommodate the people who like to have the alternating MRI EUS. not a fan of that approach. I think we've got so much pressure on endoscopy services, and EUS to me is becoming much more of a point and shoot targeted approach where we want diagnosis. We don't want to be spending our limited ultrasound time or limited endoscopy time sort of having a look at a 12mm cyst and going, well, this looked the same as 2 years ago, back to MRI. So this is the full Kyoto guideline, and I won't go through all of this. It's fairly standard in terms of, you know, size. It's got these high risk and worrisome features, and then timings based on those, and you kind of then can loop back when you develop high risk stigmata. But if you sort of simplify it down, then what you want to do is essentially an approach where you look and go, well, is this patient fit for intervention? And if they're not, then at this point, everything stops. Do you have other factors that then set you at higher risk? And if you do, you're going to tend to be more aggressive and head down this pathway. And then using those factors in mind, try and stratify these cystic lesions as low risk, where if they're suitable for intervention, if they do progress, heading down a surveillance pathway, using EUS as your tool to try and help with intermediate risk lesions to then stratify and determine whether you should push more aggressively and head down an intervention, or whether you head down surveillance, and then finding the high-risk cases and looking at the role of definitive intervention for those. And yeah, so hopefully that's answered the question. Thank you.
Thank you, Millen, for an excellent talk. There's really been such a huge shift over the past decade, where back in the days there used to be confocal microscopy, we're talking about proteomics and all sorts of stuff. It seems like we're becoming less and less concerned and seem to do less and less nowadays than we did before, isn't it?
Yeah, look, I think so, and part of it has been the improvement in radiology. I mean, part of our problem has been caused by the improvement in radiology, because they find these small cysts, but they also find small nodules, they find more high-risk features. And I think all of the confocal, all of this stuff has kind of shown that essentially when you find the nodule, you're already at higher risk anyway. And the genomics and the molecular stuff, I think, will help us better risk stratify and hopefully prevent patients having unnecessary pancreatic resection will be the role of that.
Yes, thank you very much. In the interest of time, we're just going to move on to the next speaker.
I'm actually quite low. I'm actually past.
Yeah. You're quite deep. Low down.
I might show us some group meditation.
I'm going to introduce our next speaker, Jason Huang.
I'm not sure what you gain by pronouncing.
Sorry, we're going to go on to the live.
You've gone in with the view of assessing the pseudocyst or cystic lesion, which is disappeared now.
Can we mute text 3 for a second, please?
Yes, we're just going to introduce the next case. Can we just quieten the room? Thank you.
Thank you. Right. Thank you.
There's a disruption. But the kidney, right kidney.
Yeah, that's PV coming out of that area here.
Has a history of diverticulosis, hypertension, bipolar, depression, dyslipidemia. His main current symptom is persistent central abdominal pain and nausea, which is exacerbated by oral intake, and on imaging has had a significantly enlarging pancreatic head pseudocyst over the period of about 7 months, from 25 to 44 millimeters on MRCP. Which shows a evolving multiloculated pancreatic head and unsnip process pseudocyst with internal sediment and debris, but no solid component, with no biliary obstruction. We are going to move to text suite 3, for a EUS with plan for FNA in consideration of pigtail.
And then we can talk about the pancreatitis.
Are we on? I think we're on.
You're on. We're just getting the EUS images up, please.
You can start from there, I think, yeah.
Are we on? Good morning, everyone. I'd like to thank the organizers for the opportunity to present this case. With me here today is Professor William Tam, Professor Chris Raghunath from Royal Perth Hospital. William Tam is from the Royal Adelaide, everyone knows well. And I'm Jeevanesh from the Queen Elizabeth Hospital. So we've heard the story for this patient. He's 52 years old. He's basically had some history of alcohol excess in the past. 6 months ago, he stopped drinking. And he's had some pancreatitis. It's shown that he's got a pancreatic pseudocyst. And I'll just take everyone through a systematic examination of the pancreas. So we start over here, come through the esophagus, and that's your celiac artery there, taking off from the aorta. And basically what I tend to do is I tend to just trace that celiac artery down to its bifurcation to the splenic artery and hepatic, and that's your pancreas right there. So that's the body of the pancreas, and that's your pancreatic duct. I'm not able to really measure that. We've done measurements on it before. It was around. Excellent. Thanks, Krish. Yep, so it's about 1.4 millimeters, yep. So that's normal. And the parenchyma is a bit hyperechoic, but otherwise normal. I mean, the thing we want to look for here is of the parenchyma from normal versus chronic pancreatitis. And there's a lot of criteria you can use to describe the chronic pancreatitis. That's a Rosemont criteria, which generally looks at ductal features and parenchymal features. I won't go into detail there. That was just the left adrenal that I blitzed through very quickly. So that's the pancreatic body again. I'm just tracing that. Adrenal on my left there, that's seagull appearance. Over here, this organ there. And then I'm going to follow this through to the spleen so that we get a good view of the tail of the pancreas. And to me, these parenchymal features don't look too concerning for chronic pancreatitis. That's the adrenals again. And that's the splenic hilum. Okay, so let's go to the area where we are interested in, which is the uncinate process. And I'll go down to the past the pylorus. So it's a little bit erythematous there. I'll change to endoscopic view quickly. So that wasn't me. That was what it was. It looked like before we came in.
A bit edematous, isn't it?
Yes, a bit edematous, and that's the duodenal bulb. So from the bulb, now we're getting different views of the pancreas. We're looking at the head, and we're looking at it from bottom up. So that's your portal vein, and that's your common bile duct that I'm tracing.
You can nicely see the common bile duct.
That's up top there.
It's not dilated.
It's 4.5 millimeters. So the other important thing to look for here is whether or not there's another cause for his pancreatitis. Are there any cholelithiasis or biliary obstruction that we are missing? MRIs sometimes don't pick up small stones. So that's the CVD. I'm tracing it all the way back to the hilum. This gentleman has had a cholecystectomy before, so you're not going to see the gallbladder very well. You're not going to see it at all because he's had a cholecystectomy. But yeah, so it's going up here, and
you can see that's a portal hilum there.
So that's the cholecystectomy clip up here, and sometimes you can see a bit of a remnant sort of cystic duct, but his is quite close, and that's following through to the common bile duct over there. And you see how it joins that area. So common bile duct here looks normal. Professor Raghunath measured it at 4 millimeters. And what we're seeing at the bottom here is also the pancreatic duct, just there.
Yeah, that's good view. The snake eye sign, yeah.
Yep. And that's 2.3 millimeters. And then we're tracing that all the way down to the ampulla. And this is this sort of disorganized appearance that we are seeing here. So it's not cystic, and we measured it earlier at about 45 millimeters, now it's about 52-ish.
And there is an inflammatory looking node as well next to it.
So that's the view from the bulb. Now, this is the benefit of having EUS, because sometimes on MRIs and CTs it looks solid or liquid, and then when you go in with EUS you get a much better view, and obviously you have the chance to put a needle in it. So we've scanned down here earlier. We're going deep down into D2. What's up here?
Quite a few we have seen, yeah.
Yeah. So they are not particularly enlarged. They are probably all, do you reckon, 12 at most? About 14.
Yeah, I can see another one there, yeah.
So then you have the SMV and SMA that come through soon. And where is our collection and that pancreatic head? Let's come back a bit more.
Towards the right, around 2, 3 o'clock?
Yeah, around 2 o'clock you're getting that pancreas. I'm quite deep because we really wanted to get a good view beyond the uncinate process as well. And that's, yeah, your pancreas uncinate process coming up. And that's that irregular sort of thing that we see. What's happened?
I think it's somewhere around here. You can see I think it's a resolving sort of inflammatory collection.
Yeah.
And in the context of pancreatitis like this, you may have had a groove pancreatitis, and you can see it now. Yeah.
And I guess the important thing was that the PD is not dilated, because the other thing that can cause pancreatitis in, mainly in the over 65, C52, is a pancreatic mass. So that's the other thing to differentiate. So you want to look at the parenchymal features for chronic pancreatitis and exclude a mass. So that's that irregular sort of area we were demonstrating from the bulb again. What do you reckon, Krish, Will? Shall we just stick a needle in
I think it's resolving or resolved. That MRI was 2 months old.
Yeah.
And there is no PD disruption. We have seen the PD right through.
Yeah.
There was edema in the D1 and D2, and a few inflammatory nodes next to it. So I have a feeling he must have had a groove pancreatitis, and that's settling down now.
Yeah.
CBD is fine. There's no stones there. From the pancreatitis point of view, not much of calcifications. That's a node around there.
Yeah.
So I guess conservative management, wait and watch, avoidance of alcohol, and see how he goes would be the way for him. We have confirmed that there's no major fluid. That's a good view. I think it's resolved or resolving. Part of it, it's not become solidified there.
Yeah.
And it is resolved or resolving. So wait and watch and see how he goes. Is probably what I would do. Yeah, see, that's a nice, good node C next to it. And this is the, you can see the edematous wall of the duodenum here, and then the inflammatory area, which is formed almost inflammatory mass in the node. So I think it's all groove pancreatitis, which is resolving. And typically they do get pains and vomiting and things, but we are not seeing any gastric outlet obstruction.
And that's the PD there. It's going right down.
Yeah.
And it looks very, very narrow in caliber. It's not obstructed. Some tributaries there. And
what do you think? CBD is underneath that.
Let's have a look. So I'm still in D2. I'll trace that up. CBD is narrow.
It's not dilated.
Yeah, but I think this is the uncinate view where you're getting CBD and PD. And I've just flipped back
we saw it from D1 nicely.
No biopsy?
No. Okay. There's no need for biopsy. There's no collection needed, draining needed, and just follow up with cross-sectional imaging, I suppose.
Yeah.
Yeah.
Wonderful. Thank you.
Good. Thank you.
who has a history of prostate cancer with previous prostatectomy and lymph node dissection, no follow-up chemotherapy and radiotherapy, as well as a history of previous stroke to on-jaw antiplatelets and umbilical hernia repair. He has presented with a mixed IPMN on follow-up imaging, which has progressively enlarged and has previously been reviewed in a hepatobiliary MDT with recommendation for 2-yearly MRCP. His CA is normal. His CA 19.9 is 14. His LFTs are normal. However, imaging shows that there's a progressive side branch and main branch IPMN with interval progression, as well as new small side branch cysts and progressive dilatation of the main pancreatic duct to approximately 5 millimeters. He is planned to proceed with IPM for his IPMN with PD dilatation to EES, and depending on that, may proceed to FNA. Or depending on the state of the pancreatic duct, may undergo ERCP and pancreatoscopy over to TS4.
Right, thank you. Can you hear us now?
We can. Just the screen up to 1 second.
It's very nice and clear.
Okay, can you see our EUS screen?
No, can we get that up, please?
EUS, please. Right, thanks. I'll just start introducing Nam, who is with us, and I'm just really pleased to work with Nam today. It's a real pleasure.
Thanks, Frank.
So this gentleman, I had a chat before. He's really well in himself, and what we're seeing are changes over time without any increase in symptom. He's not diabetic. So I'm sitting in the bulb again, and you can see the portal vein and bile duct as we start. So the bile duct, which can be traced up to the liver, taking the pressure off. There's the bile duct right up to the bifurcation with anti-clockwise, and then clockwise down towards the bottom again. And we'll just follow the bile duct and all the way until we see 2 ducts, which is what we want to see here. So here, this is the ampullary process near the duodenal wall, and we see 2 ducts. And at this level, the main pancreatic duct does not appear to be dilated. And we'll try and, there isn't any obvious mass lesion in this area. And we're just rotating up towards the liver again, and then I'll rotate down. And there's a couple of cystic structures in this area. I'll just line up the portal vein. I think that's important. Right.
So Frank, just actually follow the PD from the ampulla back to the neck again, if we can. Just actually see if there's any caliber change, because the MRCP actually show increase in main duct caliber from 3 to 5, and this is a concern for our hep bio surgeon. So that's a PD from the ampulla. This is the head. Frank is tracing, and we are
probably a caliber change just here.
Yeah.
Right? And if we're looking at the portal veins, so sometimes we can get
that's
the
portal vein there.
You can see the PD behind the portal vein, which
so
is
this is a
probably
PD here, but sometimes it's actually it will be artifactually bigger than it should be.
Yes.
So if we measure actually the PD here, it could be up to about 5. This is what actually our MRI actually have indicated.
So if I'm following that duct forward, so that's from the body, neck area,
yeah,
following it into the head, and we're seeing a caliber change around here from there.
It's very nice demonstration actually there, Frank, but there's no mass lesion here, right?
That's right.
So,
so this is main duct. Well, we're seeing modest main duct dilatation, not above 6 millimeters, no mass lesion. I'd be really interested to look at the ampulla in this gentleman.
Yeah.
So I'm just pushing my scope down and then right turn, and we'll just change our screen to just endo only. And we'll see if we can visualize the ampullary orifice.
So what are you looking for?
So we'll see. There's the little beard that I always follow up. And what we're looking for is a fish mouth with mucus exuding from the ampulla.
we did actually have the typical fish mouth before, right, Frank?
Yes,
when we first come in,
that's right.
it's
We were
very
going to,
patulous.
Yeah, we were going to cheat, and there was looked beautiful. Yeah, and that's why the fish has gone away. But anyway, so that's what we were looking for, the mucus at the ampulla. I'll switch to EUS now, and we'll just look at this multiloculated cystic area. A small, thin septum area. Just rotating, looking at some other components of this. This is probably a branch of the PD down here and not the main PD, but that's not dilated. We could probably, if we were concerned, you would want to know if you could do contrast and see if there is contrast would be really helpful.
Just actually scan this area here, Frank, because actually, again, we know that actually IPMN is mostly actually a mucosal lesion, and they can be very flat, right? And on ductoscopy, often actually we see this is actually carpeting of the fish egg appearance. And I think for IPMN, we have to be careful to actually to label it as normal or actually not normal, because sometimes you can see this thin layer on actually this. I thought there's a view that actually there's a thin layer of potential carpeting lesions actually there. Now, it's hard, or actually yes. Again, there might be actually a mirror nodule here. So I think contrast actually would be helpful to clarify the cyst, but also actually the duct to see if there's any actually lesions in the main duct.
If I pull back a little bit more, so I'll hold my position, I won't give it up completely because we do want to look at the cyst, but then we'll see the duct is actually more superior to the right, and as we saw on, I'm just holding still here because we do have a little bit of time. We'll just, the contrast should be ready.
Contrast ready?
Yeah, and we'll.
So 1 mil followed by 5 mil flush.
And we'll get that split view again. Thank you very much. And the timer. And you can see that. And we're looking very carefully, knowing the structure before. This is the second component where we were a bit more concerned, but the separations are still nice and thin. Even if that was a mural tissue, very small, very hard to access, and the risk of creating a complication for this man who's really well. And there are no high-risk features, as was mentioned in the previous presentation. We're very happy that those are very small septations. And the ductal structure underneath, probably a branch of the PD, not the main PD, because that's further up. I don't think there's any real value of doing an FNA here. We know it's mucinous. We saw the mucin at the ampulla. We're not looking for CEA. In fact, his tumour markers are normal, both CEA and CA99 on blood. But I don't think there's any additional value, only risk if we look for more. So we'll go back to the normal view, and we'll try and pull back our scope very gently, and you'll see in the top right.
So the papilla will appear up here, and CBD and PD will appear here. So there we are, CBD and PD.
And PD underneath it. And you can see here the PD is a bit more proud. And we'll measure that.
It's about 4.6.
4.6.
But very secular.
He's in his mid-60s, so that is significant and saccular. So I'll just try and follow that PD very gently, pulling my scope back, holding it tight against my chest. We'll just see if we can see a transition point. You can see it there, that's still PD there. And I'll probably fall off at some point. But we'll just try and... In fact, the duct is getting a little smaller there than before, but we're also using a bit of compression, so the compression will be changing that. And then we're just rising into the neck of the pancreas here. So again, a little bit of a cystic structure here. That's all PD. Yeah. I'm actually going to let myself fall back into the stomach at this point. And then we'll just tuck against the stomach and find the splenoportal junction, because I think that's useful to see if we can then trace it forward.
Yeah. So in a skinny person, you effectively can have a very nice trace between the head directly to the proximal body and view to examine the neck of the pancreas.
I think we're too far. There's the kidney.
That's the kidney, yeah.
So we're now just using that as our reference point.
Spleen, liver, kidney. That looks like spleen.
Yeah,
yep.
That's...
I think
I'm too far, right?
You might have to push in a bit.
Yeah, I will do.
So maybe a question to Andy and Milan, if actually Milan's still up there, about Milan's actually down here. So we do know this is actually IPMN, likely to be having mixed up IPMN. Is there any point of actually doing FNA to sample for genomic analysis and actually quantify the risk here, or straight to surgery? If surgery, is it partial or total pancreatectomy?
Okay, here we got our vascular structures now. And there's PD. You measure there.
Sam is our surgeon. Actually, we request actually put a needle in, yeah. Right, okay.
So we would just be going for some fluid analysis?
Yes.
I mean, that's fairly safe. I mean, that would be more concerned if we're doing an FNA and we're going for the wall and then we're actually causing damage to the outside structures.
So the duct here actually doesn't look too bad?
Correct.
Oh, sorry.
Got EOS back?
Sorry. Okay, so this is actually the duct in the neck and proximal body. No particular transitional point here, right, Frank?
No, not at all.
Because we was actually a bit worried about the change in the caliber from the head to the proximal body. So the duct here we measure it's about 3.8 to 4 millimeter. I agree with you that it's probably
and often the tumour occurs away from the actual lesion. And you're focusing on the cystic lesion, so just please make sure we just follow the pancreas right out. There's another cystic component there with some but just have to always make sure we don't finish our examination and not having traced the pancreas all the way back.
I think that's a very important point, Frank. Yeah. I mean, up to 9% exactly of IPMN actually have synchronous cancer. Exactly, I have actually at least 3 patients who've been monitored for IPMN cysts, and actually we found a solid cancer elsewhere apart from the cyst. And I think exactly that's a very important point exactly.
So that's the head, that's the
neck,
neck, head, neck down again as it joins the neck body. So it's mostly a saccular enlargement in the pancreatic head. The actual duct doesn't. Just take an FNA.
So which needle are you using here?
Well, so we just want fluid. It's mucinous, so I probably want to, if I can get a straight aim at it without being in a compromised position, maybe use a 19 gauge because you'll get it easier. The 22 will work, making sure we're actually getting it out of the cyst rather than getting a dry aspirate at that point, which would...
So using a 19 gauge in the second part of the duodenum might be tough, Frank. Which is your preferred 19 gauge?
Well, what I am doing is just seeing if I have a window that is... So we can use a Olympus Easy Shot.
All right. Can we have the 19 gauge Olympus Easy Shot with side hole, without side hole? I don't.
No side hole, just normal.
You don't use side hole, or you use no? Okay, without side hole, please.
So I'll just went back down to the.
There you are.
So in this position.
Okay.
Well, I think here the septum doesn't have any high-risk features, so I think going for the septum will just cause bleeding into the cyst. We want cyst fluid at this point, so I think septum doesn't have any high-risk features, so I think going for the septum will just cause bleeding into the cyst. We want cyst fluid at this point, so I think anything...
What's interesting is when we were doing a lot of confocal and sort of had the needle on the wall, our cytology pickup rates were significantly higher.
Indirectly answer Linda's questions. We did actually an audit of about 170 cysts actually about 5 years ago, and cysts without any non-true or thick wall, the cytology is zero. There's no cell that we can collect it. Even actually when we try to FNA the actual cyst wall. All of the cancer that we saw uniformly have associated mass or a big nodule. So in this case here, I agree with Frank that maybe we just get the fluid to confirm that this is IPMN, and I think based on imaging, the surgeon will need to decide whether they want to do a
style it out. Thank you very much.
The Whipple, or just continue to observe?
So that needle looks like it went down really easily, not too much difficulty getting it down. And another question, do you give prophylactic antibiotics here?
With the syringe?
We did, we did give him antibiotics because we were still considering doing an ERCP on him, but I think for cyst itself, I don't think there's clear indication that we need antibiotics. So we'll just attach the suction.
Wow, it's really quick there. Maybe I'll just release the pressure a little bit, because I think the fluid is not as thick as we thought. It's now sucking against the wall
yes,
now.
Yes, it is, yeah.
So I'll just turn the suctions off, because sometimes with the 20 ml suction syringe, you can have very strong suction. You see that
it disappears
very quickly here.
It still looks mucinous on...
Mm-hmm. Maybe I'll just turn the suctions off again, and then maybe we'll get into one of the lock cue, and then we turn it on. Okay, we just turn it on, and it sucks all of that lock cues away. Now normally I like to have at least 1 ml of fluid. Otherwise, actually, it will be insufficient for our lab actually to do any analysis at all.
You see how quickly that's disappeared, though, right? I think there's still dead space in the needle.
You happy?
I think so. I probably would prefer not to do it. Let me just stay there for a moment. And what we'll do is I'll see if I can get the bigger locule on the side.
There you go.
Come off. Top it off. Hold on. But even this has got smaller, right?
Yeah. Perfect.
And there it just disappeared.
So you can actually assess actually the viscosity of the fluid on how rapidly actually the tissue is decompressing.
Surprising quickly, right? Yeah. So I think we've got enough. Just getting.
But you guys saw fish mouth already, didn't you?
Yes, we did.
So I
we
think
did
that's
when we went down first of all, which is really important. Yeah.
No.
Okay.
All right. So we'll basically to you, Andy, for the next lecture. Thanks.
Thank you for the live demonstration there, and performing so beautifully for us to see. The next speaker is Jason. Jason Huang comes from the Royal Brisbane Hospital in Brisbane. Takes me back to my younger years, where we first trained together. He's renowned for what he's about to speak on. Having trained in the Comprehensive Disease Digestive Center in University of California with Kenneth Chang, he's done a dissertation particularly on this particular topic, on the use of endohepatology and particularly with portal pressure measurements. It takes nerves of steel to actually puncture any vessel. All of us here know that. And Jason's give us a talk on this particular topic. Thanks, Jason.
Thanks, Ken. Thanks for the kind introduction. And thank you, Nam, for the invitation and the organisers and all their hard work. I've been asked to talk about endohepatology. And given the time constraints of 20 minutes, I'll try and cover as much as I can, but apologies, I might have to skip through some of the slide and evidence, but I'm more than happy to discuss in breaks regarding any questions. So just quickly, portal hypertension, as we know, is a complication of liver cirrhosis. It's an important marker in prognosis in terms of decompensation, GI bleeding, encephalopathy, risk of developing HCC, etc. The gold standard method of measuring this pressure is via the transjugular method with our interventional radiology colleagues. And the current therapy remains the same as it has been for many years. Beta blockade, give the patient as much as they can tolerate and hope it works. We don't really know if it works or not, and in studies have shown a significant proportion of patients don't actually respond. However, we don't know this because we don't have an easy protocol or method of measuring their blood pressure, their portal pressures, like how we do when we treat systemic arterial blood pressure. And this is because accessing the transjugular measurement is difficult. It is quite specialised as a niche, and even amongst the radiologists who perform this, the reliability of the results can vary because it is quite a technical procedure. So, why don't we do it through the EUS method? It's seemingly more simple, and more people are trained in EUS than radiologists trained in interventions. So between 2004 to 2016, there were various animal studies, many attempts in trying to reach this holy grail, so to speak, with different catheters, pressure wires, FNA needles. However, most of these have failed. And eventually, towards the later part of 2016, we made a breakthrough with a particular set of equipment, protocols, techniques, which allowed us to demonstrate that the pressure measurement is accurate in conjunction and comparison to the gold standard. Measurements were taken from the same vessel simultaneously at the same time, and as you can see on the graphs to the right, the correlation coefficient is extremely tight. So this is a video of the kit. I'll just fast forward through certain components. So it comprises of a 25 gauge FNA needle, a non-compressible tubing, and a compact digital manometer which polls for pressure 3 times per second and gives you a digital readout of the average, and some fluid for flushing. The targets of interest are the portal vein and the hepatic vein, and generally we would target the hepatic vein first because it is generally a more difficult area to target, and certainly if we're unable to reach the hepatic vein, then there's no point measuring the portal vein, as we need the gradient, not the absolute venous pressure. So the hepatic vein can come in different shapes and sizes, I guess, so when you're doing EUS for the pancreas and pancreatic duct, depending on your orientation. Into the hepatic vein, it's preferred. Our preferred access would be to have as much liver parenchyma as possible between the probe and the target, and that way you're less likely to have a bleed at the level of the liver capsule. Once we access the vessel, we inject or flush a bit of saline to confirm that, to confirm that we are in the vessel. As you'll see a little, you see a little bit of flow there. You can see there a little bit of flow to confirm that you're in the right place and ensure that you're not right up against the vessel wall. If you inject into the liver parenchyma, it becomes very obvious. And then gradually we withdraw the needle under Doppler to ensure that there's no open tract, which there rarely is because this is a 25 gauge needle, so quite small. And our second target's a portal vein, which is readily identified. There is a tough fibrous sheath around there, as you can see, the hypoechoic ring. But with the 25 gauge needle, it does pierce through that quite easily as well. As opposed to portovenous sampling, where you're using 19 gauge, that's much more difficult. So in terms of progression of, I guess, interest and research over time, we then, from the 2016 animal study, we then progressed on to the first human pilot study. Then we published the technique in Video GIE as well, in more detail. And subsequently, more studies had begun to roll out. In particular, correlation between EUS and the gold standard, even same session EUS PBG and liver biopsy, international multi-center studies, and now there's been a flurry of interest. If you do a search on the clinicaltrials.gov, there are a lot of work in the pipeline, and I will go through just some of the highlights. So the first human pilot study had 28 patients, and we used a 25 gauge needle setup as demonstrated in the video previously. Patients were stratified to low risk and high risk probability for liver cirrhosis. And what we shown was that the procedure is very safe. We had no technical failures, no equipment failures, no adverse events. Patients were asymptomatic when they woke up, as you can imagine, because this is just a 25 gauge needle. And in terms of results, it was what we expected. So patients with high probability for cirrhosis had higher and significantly higher portal pressures. So anything above 5 is portal hypertension. Above 10 is clinically significant portal hypertension. And as you can see there, low clinical probability cohort had a normal portal pressure. And likewise, the same pattern can be observed with varices and portal hypertensive gastropathy. In terms of correlation studies, there have been a number, and there's a Chinese study, and European study, and Australian study, which is actually NAM's study, all showing very good correlation coefficients between the EUS method and the current gold standard transjugular HVPG. This is an interesting study where they correlated the EUS PPG levels to intraoperative direct manometry for patients who are undergoing liver transplant who are obviously having a laparotomy. And so the correlation was the EUS PPG prior to the laparotomy and intraoperative obviously is at laparotomy, and the gradient difference was approximately 5 millimeters mercury. Now, if you look at that and you think, well, that didn't actually correlate very well, but if you take into consideration of the normal intra-abdominal pressure, it's approximately 5 millimeters of mercury, so that really does correlate quite well. And they also did some testing with different manometers and setups, and the correlation, as you can see there, the correlation coefficient is 0.96. Then we took the 28 patients further into a larger cohort and up to 83 patients years later, and again, technical success rate remained 100%. We had no complications, really had the same findings when correlating with clinical or radiological endoscopic evidence of portal hypertension and biochemical. And the only thing really changed was the p-value, as you expect, because the cohort has become larger. We then presented the first international multi-center study where 70 patients from US, Hong Kong and Brisbane, and we had high technical success rate. It wasn't 100% this time, but it's 94%. We had one adverse outcome where there was some oozing of blood from the gastric mucosa where the needle puncture site had been, and one clip was deployed, and that was all the treatment that was required. And in terms of findings, it was consistent with all previous findings and previous studies. We then did a local cohort together with Frank's assistance in New Zealand, where we had 29 patients with essentially the same study design, comparing patients with cirrhotic versus non-cirrhotic, their portal pressures, and as expected, the cirrhotic cohort had much higher pressures compared to the non-cirrhotic. In terms of further studies, well, then other groups had taken the number of patients further, and also in terms of acuity of the patients, as you can see in this retrospective Chinese study, where 96% of their patients had confirmed cirrhosis. But not only that, quite a large number of them have had either recent variceal bleed or a history of variceal bleeding. And so in this cohort, much higher risk than any other that's been published prior, had an average PPG of 15.3, which is quite high, which is what you would expect in a higher risk cohort. And they demonstrated that if you had varices, your pressures would be high. If you didn't have varices, your pressures would be much lower. And if you have a history of bleeding, your pressures are even higher, which is, again, what's expected compared to if you had varices but no history. And this is probably one of the largest multi-center publications across the US centers, where majority of the patients, 385 patients were enrolled, and majority of the patients had successful US PPG. And again, the findings were consistent with the prior studies where there is expected elevation in the pressures in patients who have signs of portal hypertension otherwise, and if they didn't, then their pressures were normal. There were 2 minor events of post-procedural pain, and that was it out of the 373 patients. Then taking this a bit further, doing EUS PPG and liver biopsy at the same session, again, just in 64 patients, not a lot, but we did show that it was, again, technically successful, no complications, it was feasible, it's safe. And we also found that patients with PPG of more than 5, which means they have portal hypertension, their histology from the same session biopsy showed a fibrosis score of greater than 3. This study is another first, and this is NAM's study. And I'm not quoting him just because he's a convener of this meeting, but this really is a good study. Where they had 10 patients in the pre-operative setting who are going for abdominal surgery for risk stratification. And another excellent part of the study really is that he did correlation with transjugular venous pressures at the same time. And as you can see, the correlation coefficients are almost 0.9. and so therefore correlating very well. And it did impact on surgical decision for the patients as well. And in addition to that, patient satisfaction via visual analog scale clearly shown that the EOS was preferred, which, as you can appreciate, patients who are sedated obviously are more comfortable than patients who are awake for the transjugular procedure. Then there was, because there's so many different centres doing different things, the 47 clinicians got together and undertook this sort of Delphi consensus to try and standardise certain things in terms of indication, in terms of opinion about safety, and pre-procedural protocols, and essentially it solidified what we had expected already from all the different studies, but this was just bringing it all together as a consensus statement from a group of experts. And so in summary, EUS PBG is safe. It's highly technically successful. It is not technically demanding, not like the transjugular method. It has excellent correlation with the gold standard, correlation with features of portal hypertension, either clinically, endoscopically, or biochemically, and also correlates quite well with histological changes. The clinical application obviously is very wide. It depends on what your unit or your hepatologist interests are or what they need done. But you can use this for ambiguous cases in patients who may have signs of early portal hypertension and you're not sure if they really do have it. You can assess the beta blockade response or whether to discontinue if they've had no response, rather than committing patients to lifelong treatment, which is actually not working, which we don't actually know about unless we measure their pressures. Risk stratifying patients with variceal bleeding perspective, excluding the liver disease as the cause of their radiological evidence of portal hypertension, for example, and also determining whether there's pre-sinusoidal portal hypertension. So previously, causes of pre-sinusoidal portal hypertension are all the rare causes of liver disease, like schistosomiasis, early PBC, sarcoidosis, those rare conditions. But now with fatty liver disease, there is a component of that, and certainly the transjugular method won't be as accurate or won't be able to pick up any pre-sinusoidal portal hypertension. And as mentioned, perioperative risk stratification is important, and obviously this can be used as a research tool depending on your unit's interest. So just moving on to liver biopsies, I just wanted to start off with the definitions of specimen adequacy and diagnostic yield. So the specimen adequacy, there's not a universal definition, but generally you want to have more than between 6 to 11 complete portal tracts and a decent amount of length. Diagnostic yield can be really defined as whether you have enough specimen to make a diagnosis or stage the severity of the disease. And that's what we really want when we take a biopsy. Just quickly about the equipment. So we know that F&B is better than FNA, and the Francine needle tip is better than the other tips with the current evidence. And obviously a bigger needle is better. In terms of the technique, targeting the left lobe will be more straightforward than the right lobe, and it has been proven to be safer, but certainly we can target both lobes, and that's one of the advantages of the EUS method. One thing I think hasn't really been emphasised in the literature is how quickly you insert the needle. I mean, if you think about the days when you had to do the percutaneous biopsies, as a registrar, for example, that needle is a lot more rapid than what we do with the EUS. And also, I think there may be a bit of apprehension, especially if you're first starting, that you're worried about, sticking a needle into the liver multiple times, but it does improve the quality of the liver specimen if you insert the needle rapidly. Not so much on the withdrawal, but on the insertion. In terms of suction, that's less clear as to what you use in terms of advantages, but those are the options up there. In terms of the conduit, it's clearly demonstrated that a primed needle with liquid within the needle is better than a dry needle, and in particular using heparin, which I'll show in a second why we would use that. And in terms of hemostasis, it's I guess just really common sense. Now, once you've taken the specimen handling is obviously very important as well. It's really, really fragile, and depending on the etiology, can be very fragile. So as you can see up in the first picture there, the purple is the liver tissue, the red is the blood clot. If you have too much blood clot, that solidifies, it breaks up the liver tissue, and you can see that it's not very good quality compared to clean liver tissue in the other pictures. So that is why heparin can be helpful, and using flushes as opposed to instruments, floating the fluid to separate things is much better. And obviously, ideally, you do it quick enough before it clots, and then you're just separating liquid from core rather than clot from core. And in terms of core preservation, once you've had that separated, obviously the less handling mechanically, the better. So if you can pick it up with filter paper, or float it through, flush it through from one side to the cassette, or your pathology pot of choice, will be better than picking it up with a forceps or a needle. That tends to break the tissue. In terms of the evidence, so we had just published that 6-year cohort of patients who had the PPG and liver biopsy, really just showing that we didn't have any complications, and because it was spanned across a 6-year period, there were different needles. As different needles came in, we used different needles, and the specimen were deemed adequate by the pathologists, who were happy to make a diagnosis based on what they received. So that was really just showing that the liver biopsy concept is useful. Then there are subsequently more publications, but these are just some of perhaps a slightly larger one. This Canadian retrospective analysis was important because they used 19 gauge Francine for all their patients, had very good diagnostic yield, high median CPTs. The length is good, but length is less important than CPTs, but most importantly, no major adverse events out of the 142 patients. So now we know that EUS liver biopsy can obtain enough tissue, make diagnosis. Then comparison studies became the most obvious next step. And so comparing the EUS with the percutaneous method, the highlighted red cells there are the non-significant differences, and so therefore looking at the CPT and diagnostic yield, which is the most important really out of this cohort of 90 patients, there really wasn't any significant difference. Another study just published this year actually showed essentially the same thing, no significant difference between the two techniques in CPT and diagnostic yield. Then the obvious thing to compare with would be the transjugular method as well. And again, the CPT yields are very similar, but in the transjugular cohort, they actually did 3 passes as opposed to the EUS liver biopsy cohort, 2 passes. And there was a slight difference in terms of the complication, but the complication defined in this study included abdominal pain needing opiate analgesia. So 3 patients had pain needing that level of analgesia, and 1 had a liver capsule hematoma managed conservatively in the EUS arm, and in the transjugular arm, I think there was 1 patient who developed pneumothorax. So even though the number of complications was less in the transjugular, you could almost argue that the EUS still is safer. I'd rather have some abdominal pain than a pneumothorax, for example. Just another study, but in this case, this was done with the FNA needle rather than the FNB needle. So even with the FNA needle, as we know, has lower yield than the FNB needle, the CPT yield was still very similar compared to the transjugular method. So just quickly to summarize, because I'm out of time. So EUS certainly has its advantages over the traditional method. It has comparable results as well. You can integrate that together with another endoscopic procedure that's needed for the patient, for example. You can sample both lobes at the same time for patchy disease, so especially fatty liver disease, for example, which would obviously be an important etiology nowadays. Shorter recovery time and also patient satisfaction, so plenty of advantages there. Tissue yield certainly can vary from case to case depending on your etiology and severity of the liver disease, but in general, fatty liver is easier to biopsy, especially under EUS. And we all are essentially using Francine needle tips at this stage, but certainly we would expect better needles to come out in the future, but at this stage, a Francine tip 90 gauge would be the go-to. Using wet suction and very careful, meticulous specimen handling will optimize your specimen. And one last thing, obviously, your pathologist will have to be happy to report on the specimen that you give them. So it depends on the pathologist. Some of them may still prefer a 16 gauge percutaneous because the specimen is wider, but I guess the more modern pathologists may be open to different methods of obtaining tissue nowadays. So, but really your pathologist needs to have the confidence that they can make a diagnosis on your specimen. Thank you.
Fantastic talk as always. Thank you so much, Jason. So we're running slightly behind. Is there any pressing questions at the moment? No, so in which case we'll throw back to the room, and thank you very much again for introducing the case. We've got no picture at all.
1 second. Sorry. Just a slight change to the program. We've had to swap 2 of our patients. Our EUS portal pressure measurement patient will be playing after morning tea. In the interest of time, I'll quickly introduce our patient from one of the biliary obstruction cases, but there will be morning tea outside, so once we've introduced a case, feel free to go out and grab yourself something or play it during the morning tea time. Our next patient is a 76-year-old gentleman with a history of beta trophic B cirrhosis, as well as heart failure, OSA, hypertension, and gout. He has been diagnosed with cholangiocarcinoma since September 2025, and due to his surgical comorbidities, is thought to be a poor surgical candidate, and has had a previous ERCP with a distal CBD stricture measuring 20 millimeters with upstream dilatation, and is planned for an ERCP, cholangioscopy, and RFA today.
Great. Thanks, Tracy. Can you guys hear me?
We can hear you. 1 second for the screen, please.
All right. So it's my pleasure to do the case with Milan from Liverpool. And as you exactly heard, we
tried to showcase ductoscopy and radiofrequency ablations of biliary cancer with this case. Now, I'll just add a few more to this guy. So his case has actually been well discussed in MDT. This is actually important bits. Due to his comorbidity, he can't actually have chemo, he can't have surgery. And his disease actually started in 2024. So he's been survived with this actually for the last 2 years already. And in the initial 6 months, he's keep actually having recurrent obstruction due to stent dysfunction. And we decided actually to do this in 2025 as a measure to debulk the intraluminal tumor and actually maintain stent patency. And as you know, with cholangiocarcinoma, apart from the cancer, acute sepsis is actually probably the #1 reason why they often die from. So managing these patients with biliary cancer, maintain stent patency or duct patency is the key. So this is probably his 4th or 5th radiofrequency ablation of the distal cholangiocarcinoma. You can see that here, over the last 2 years, the tumor probably have now extended outside. And you can see that it's starting to involve the papilla. It's quite friable as I remove the stent. Now, the other thing I have prepared also is that because it's extended quite close to the papilla, or involve the papilla now, and in view of the burning extending more distally, I have actually insert a pancreatic duct to prevent any possibility of pancreatitis. Okay? So I think actually the next thing I'm going to do is to cannulate and show you the cholangiogram and the stricture. As you can see, that previous sphincterotomy has been done. Screen now, please. So can we have two concurrent screens, the X-ray and the... So we've been using plastic stent. Blow up the balloon.
Yeah, so it's a 10-French straight plastic stent that we just removed at the start of the case. And that's given him patency. We're looking through the images for about 5 or 6 months now with the RFA. But you can see the amount of debris now coming out of the duct. And that's a combination of sludge, but there probably is sort of surface tumour tissue that's coming out as well. So we've given the patient intravenous antibiotics for coverage, because we are going to be doing RFA and manipulating in the duct as well. And so you can see before any contrast, NAM's already just cleaned out the duct, got a lot of that muck out to make sure there's good drainage, so we're not pushing too much contrast in under pressure to increase the risk of infection. And so we'll clean it up a couple of times, try and get the duct clear first.
So do you do that as well, Milan, exactly clean the duct without actually contrast? Because I find that exactly if you start to inject in sort of intervening duct previously, the risk of cholangitis afterwards, actually even the stent inserted, is actually quite high. They get actually this septic shower, rigoring immediately after you finish your ERCP?
Always. Because we're going to irrigate with the cholangioscopy, so we're pushing fluid in, we're manipulating the duct with the RFA. So if you leave all this stuff in there, then you're just guaranteeing yourself sepsis afterwards.
I'm happy with the cleanliness of the trawling now. So I'm going to inject some contrast. Screen, please. All right, blow up the balloon. Okay, inject now. Yeah, I want actually to show you the stricture, that's all, actually the tumor. Actually, now you can see actually in the bottom part, probably actually in the last 2.5 centimeters. Okay, do you see that from the cholangiogram? Stop screening, take a high-res photo for me, please. Yeah. Okay. So that distal stricture there, that's what we're going to apply. So I think you're right, Linda. Deflate. Let's actually cannulate with the cholangiogram now, the cholangioscopy now. Yes, you're right. I mean, actually, in some cases, actually, we can go direct, and actually, I am actually an advocate for minimal contrast injection due to risk of cholangitis. Now, I'm going to use the IMAX 9 French scope. Now, the reason actually I use this is because actually the Microtechs actually have developed a cap for this scope. And if I can actually zoom up. Now, there is actually a very small cap that you can see here. Can you shine actually the line here? So this cap can be actually attached to the tip of the scope. And this actually will, can we actually have the room view, please? Yeah, I know. Can you see now? Okay, so this is actually, can you zoom in actually here? There's actually a little cap here.
You might see it better if we flip it around. There's a little diagram on there.
Yeah, exactly. Maybe actually you can see actually there's actually a diaphragm, very small, and turn off the light so that we can see once actually you attach. No, keep the light on. Can you zoom in directly to the tip of the scope here? Can you see the cap? Linda?
So hopefully you see. Yep.
Okay, all right. So this tapered cap will allow me to do direct cannulation without going through any wire.
So this is giving us the benefit of a tapered tip, almost like using a sphincterotome. And as opposed to a sphincterotome where you can only angle in one direction, you've got the steering of the cholangiscope as well. So with a nice wide open sphincterotomy, freehand cannulation with the aid of this cap will be very straightforward.
In fact, actually, to create less friction for my scope, I'm going to remove actually the guide wire.
And I think the other thing this cap will do is it'll make it easier to advance up the duct as well. Because we know that we've got disease basically in the papilla and all the way up for a couple of centimetres. Having that taper will let the cholangiscope slide up easier.
So I'm going to change the view to the cholangiscopic view now. So you should be able to see the tumor now. Okay, let me go right up directly to the hilum and then pull back. It's often actually better that way. So we know that actually we're not missing anything. Is the irrigations on? Okay. So I think you can still have a very good image with the caps on. And I think I've used this cap a couple of times now. And the benefit of the cap is you can press against the mucosa that you want to interrogate. And it gives you a very good view. Now, I think some of these changes are inflammatory related to the standard weekly we put in. So you can see that this bit here is probably due to the plastic standard weekly we have inside you over the last few months. Now, despite all of the cleaning that I have done, you can see that it's still very dirty here. And that's why I say that we have to be very careful here. These patients uniformly will continue to have oral antibiotic for the next 5 days. Now, you can see here that there's a change in the mucosa. So this is a relatively normal mucosa for trainees. But when you get to the cancer, now you lost that pattern, and the vascularity become very abnormal. Yes. Okay, screen now, please. So that's roughly the top part of the stricture, which we have identified previously on cholangiogram.
Yeah, so you're starting to see very dilated and regular vessels here now. The papillary projections are nowhere near as regular as they were higher up in the duct, but also a lot of mucosal scarring, and I guess this is from your previous RFA interventions.
Correct. Correct. And I think this now this become more abnormal, and as I said, I have noticed that the cancer have extended downward to involve the papilla, and you can see that very nicely. And I'm very close to or about to come out of the papilla. And I would say the additional benefit of this cap is, previously we always have problem of interrogate the distal CBD stricture because of the scope instability. This cap will allow you to hold your scope position relatively well. If I turn on the other thing, you can see that the scope is out of the papilla, but you still can see the inside. So I think this is a good additional toy for those who do routine cholangioscopy.
Yeah. I think it's the best view I've ever seen of the very distal part of the bile duct. So I think it does make a huge difference.
The next thing I'm going to do is I'm going to, can I have the balloon and the wire back? So I need actually to inject a little bit more contrast to outline the stricture, and then actually we'll do actually the radio frequency ablation.
And do you think you're going to get this in one burn zone, or are you going to need to do 2 overlapping burns? So I guess you've got about a 2 centimetre effect window. So
I think exactly it's 2 and 2.5, right?
Yeah.
So actually the space actually of the current Boston RFA probe, the Habib one, is only 2 centimetres or so. So I think we'll probably will do actually overlapping.
Yes,
And
I think so.
Yeah.
And have you thought about your choice of stent afterwards? Are you're going to go back to a plastic one? You're thinking a metal stent, maybe try and give him longer, but you know, he's done very well with this malignancy.
Screen?
Do you worry about if you're putting a metal stent in, whether he starts getting stent ingrowth and then metal stent related issues that may be harder to treat than what we're dealing with now?
Yeah, so we actually have to remove the metal stent for this guy to be able to actually provide effective RFA. So we did actually have the metal stent in before, and what we found is actually the contact of the Habib probe with the cancer is not there, and you can actually will soon see the impedance signal if you actually have the metal stent. So I uniformly use actually a plastic stent to allow actually the whole thing actually to have a good apposition. Of course, actually, you know, you can say actually this is actually unproven. I mean, the controversy actually against actually RFA for biliary cancer is still there. There are actually supporting evidence, but we need more randomized actually control trial data. But I think actually, in theory, apart from the patency and the debulking of the tumor, you can argue actually it's a form of local immunotherapy,
Yes.
right? Because actually you burn, you attract a lot of actually immune response. And again, this guy, no treatment, lasts actually for 2 years. Now you can blame that actually, that's actually because of the good patency or a bit of local immunotherapy.
Yeah.
Uncertain.
Yeah, but I think it's a key point is this patient's not a candidate for other interventions. So, you know, we're offering him a therapy that seems to have given him very good local control. He's had regular surveillance. There's been no evidence of distal disease develop. So this seems to be actually keeping it under control. And if he continues the current trajectory, either his liver disease or his cardiac disease is more likely what he'll succumb to than the biliary cancer.
Any question from the floor? Yes. So probably we changed actually the camera view. Can actually someone actually show me actually the in-room camera view of the those who actually have not used the Habib RFA probe? So it's actually a 7.5 French actually catheter that actually have 2 plates, and they are about 2 centimeters actually in length. So you need actually to understand actually the catheter structure. All right, let's put the thing through.
And so when you burn, you have a bipolar energy field generated between those 2 electrodes, and so that's your burn zone.
Correct.
And so you can see those electrodes fluoroscopically, so when you're ablating introductorily, you can use that as your marker, and then generally you'd start proximal burn. You do need to burn for 90 seconds, and it's an incredible test of patients holding it there for 90 seconds. So we have our diathermy generator set to time out at 90 seconds, so we just keep holding it. Otherwise, the tendency is to let go early, because 90 seconds can feel like an eternity.
So we're actually ready now with the burn. Okay, so I'm going to actually step on the pedal, and we'll watch it for 90 seconds. Can you actually show the room view of the impedance that we created? Okay. Now, the other thing that we often see whether we have effective burn or not is the bubble that will come out the duct. Okay, so it's got actually the automated stoppage. So I'm going to actually move it down a bit more now to involve actually the distal and probably the papilla here as well.
So this is very analogous to Barrett's RFA. You've got a low wattage delivered over a longer period of time, so you're slowly desiccating and essentially just cooking the tissue. You want to avoid higher powers because you don't want to actually burn deeper. You don't want to have any cutting or tissue destruction. And sometimes it is difficult after the sphincterotomy right at the papilla to get the best contact. You can see Nam's just sucking down there, trying to get the tissue to come into contact. I think the other thing is on the cholangioscopy, this wasn't that narrow that you could get a good view, and so we maybe aren't going to get as good contact as he's had before, and this suggests maybe he's getting sort of good local control of his disease. Do you do this on a schedule, Nam, for this guy, or do you just wait till his liver tests get worse, or how do you decide the timing?
Yeah, we schedule actually every 4 to 6 months.
And so I think given this response, maybe this guy will head closer to the 6 months for the next procedure rather than the 4 months, because it seems to have still kept things under control for him.
I'm just actually a bit concerned that actually it's not actually burning well, because I expect actually to see the bubbling, particularly when I have actually the plate actually right at the papilla here.
You on the 7 watt or the 10 watt setting?
This is actually at 7. Go up to 10.
I guess the other thing, if you're worried, is you can always... so across the papilla, usually I'll use 7 watts, and across the hilum, 7 watts as well, because of that worry in some earlier case series about causing pseudoaneurysms at the hilum and causing bleeding. Through a metal stent, if I want to focally ablate ingrowth or anywhere else in the duct, I'll usually use 10 watts. And you can see there's coagulum and tissue on the probe, so I think there has been some burn.
Let's actually put the scope back in and see actually whether there's any effective burn. I'm just concerned that actually this probe actually not working well. So the setting is different between the proximal and the distal stricture, right?
Yeah.
Millen? I think actually you need to actually have less voltage actually in the proximal, as you say, on the proximal stricture, because actually risk of burning through the vasculature. Whereas actually at the bottom, you have more freedom of actually using a higher voltage for the burning.
Exactly. And then just the papilla and the PD stent to some degree will offset the risk. The patient's had rectal indomethacin as well to help sort of reduce the risk of pancreatitis.
Correct.
So if you didn't have a cholangioscope available to check your effect, the other thing you can do is just use your extraction balloon.
While they're just working like this, feel free to do. You can just let it continue to place. Come back in 10 minutes.
You can use your extraction balloon to sweep through the duct as well, and see if you can sweep out coagulums the other way to look for effect. I don't know, that looks burnt to me now. So I think you have had sort of contact and effect, at least in your more proximal part.
Yeah, but I'm seriously not happy with my burn though. There's not a lot of actually burning here. There's still, okay, here. Actually, now we have some burn. So the proximal bit, we didn't go as far as we should. So this distal bit, you can see that the burn tissue, barbecuing it, actually, or what I call it. So you can see the distal is actually burned a bit better. So I think actually that's a concept. I think people should go and actually have some tea now. I'm just going to do a bit more burning, and then we should actually move on to the next session. Thanks, Linda.
Thanks
very
much.
Thanks, everyone.
Thanks. actually don't change, just actually a bit below.
Hello. Welcome to the second session. My name is John Chen. I'm one of the head build surgeon based in Adelaide. My interest is in ERCP as well as liver transplant. I've got two co-chairs with me. Vipul Agarwal is from Canberra, as well as Jeev Naidu from Adelaide as well. So this session consists of 3 talks and 2 cases. It is my pleasure to introduce Linda Zhang. Linda is a staff specialist in therapeutic endoscopies at St. George Hospital. She completed her clinical fellowship in advanced therapeutic endoscopy at Liverpool Hospital, Johns Hopkins Hospital in Baltimore. And her topic of presentation is biliary obstruction. How should it be investigated? Linda.
Thank you, John, and thank you to NAM and the organisers for having me here today. So I thought for the purpose of this talk, I'll just focus on biliary strictures. I won't go into bile duct stones, how to investigate and manage them. I'll run through the diagnostic armamentarium, and then I'll talk a little bit about the future as well in terms of next generation sequencing and artificial intelligence. So I will be referring to guidelines through this, and I thought this was a really good resource. This was published in Endoscopy last year, and this is the ESGE guideline on the diagnostic workup of bile duct strictures. And sorry, I'm losing my voice, you just have to excuse my voice today. So most people in this room will know the main etiologies of biliary strictures. I think when a patient comes through with a bile duct stricture, it is important to remember that up to 80% of these can be malignant. So these patients do need to be worked up in a timely manner. So of course the most common malignant etiologies are pancreatic cancer, cholangiocarcinoma, gallbladder cancer, HCC. Then we've got our benign fibroinflammatory conditions like chronic pancreatitis, PSC, autoimmune pancreatitis, and IgG4-related disease. You've got your iatrogenic strictures, and then less commonly your vascular pathology and AIDS cholangioscopy and Moritz syndrome. So in terms of lab tests, CA19-9 can be helpful in differentiating malignancy, but it is important to remember that it's falsely elevated in the setting of biliary obstruction or cholangitis. So it's more useful following biliary decompression. IgG4 levels are elevated in 90% of patients with IgG4 disease, but it can also be elevated in a small percentage of patients with cholangiocarcinoma, PSC, and pancreatic cancer. So really just the take-home message is don't use it in isolation, always use it in combination with imaging and histopathology. What about cross-sectional imaging? We know that transabdominal ultrasound has very low accuracy in assessing both the etiology and extent of biliary obstruction, so really MRI and CT abdomen are the mainstay of imaging for bile duct strictures. And these are useful in determining the level of the stricture, staging the disease, and assessing resectability, particularly in terms of vascular anatomy. And this is very important to perform before undergoing any endoscopic procedures, and also to be carefully evaluated before we put any scopes down into patients. Just another point that MRI and CT abdomen are often inaccurate in PSC. So how does MRI and CT compare? In head-to-head studies, MRI is superior to CT in determining the level of the stricture and diagnostic accuracy for malignancy. CT still has a very important role. It's probably better for vascular anatomy, but MRI is better at determining the level of the stricture. So this is a flowchart from the ESGE guidelines, and when we confirm a bile duct stricture, we divide the further investigation into perihilar disease and distal disease. And I'll start by talking about perihilar disease. So the first question to ask is the patient jaundiced? Does the patient need drainage, or do they not require drainage? If drainage is not needed, if the patient is resectable, it's always worth presenting at an MDT to decide on the need for tissue acquisition, and if so, which modality to use. And I'll talk a little bit more about ERCP and EUS if drainage is needed. So in terms of ERCP tissue acquisition, we heard a little bit about this morning already, but we've got brush cytology, quite a low sensitivity of 40%. We've also got fluoroscopy-guided biopsy, so we've got options for using the standard biopsy forceps. We can use dedicated devices, so this is a slim tapered tip catheter. This is an angled biopsy forceps. And then this one here is an over-the-wire biopsy forceps, but still the sensitivity is quite low at 52%. Does the type of brush we use impact on the specimen that we get? So this was a multi-center RCT that compared the standard cytology brush with the infinity brush, a so-called aggressive brush. And what it has is it has both soft bristles but also stiff bristles and denser bristles to increase tissue capture. And what the study found was that although the more aggressive brush significantly increased your cellular abundance, this did not actually translate to improved sensitivity for malignancy. And this same result was shown in other prospective studies also. So if we combine the two modalities, if we use biopsy and brush cytology, this results in a 25% incremental yield over either alone. It is important to note that intraductal biopsies are more technically challenging and can carry a risk of adverse events, including bleeding and perforation, when you're trying to advance that biopsy forceps up. So this is not really widely used unless the technical expertise and experience is there. What about the number of biopsies or passes? So studies have shown no difference in sensitivity for less than 4 biopsies versus 4 or more biopsies. However, there is an incremental yield for increasing the number of brush passes. So this study showed if you take 10 brush passes, your sensitivity is 38%, 20 times 47%, and 30 times is 57%. So there does seem to be an increase in sensitivity. What about dilatation prior to biopsy? Really limited studies in this regard. It may increase diagnostic yield without increasing complications, but there's really insufficient data to recommend its routine use. So in my practice, I would only dilate if I needed to get my equipment through, but otherwise I wouldn't dilate for the purpose of biopsy. So take home from that is to aim for at least 3 to 4 biopsies if you're doing intraductal biopsies and at least 10 passes. What about EUS for perihilar strictures? So a single prospective study demonstrated high diagnostic accuracy and sensitivity in patients with perihilar disease who had a negative brush cytology, and that this actually changed the surgical approach in 2/3 of patients. Overall, though, EUS carries quite a low sensitivity in perihilar lesions, especially if the patient has a pre-existing stent. So 56% in perihilar lesions versus 95% in distal lesions. And this is thought to be due to the absence of an overt mass in cholangiocarcinoma and a more diffuse axial kind of growth pattern. Just a point that this study used FNA needles only, and maybe that sensitivity might be a little bit higher with our new needles. So really important with EUS, and I think Chris touched on this morning as well, is the risk of peritoneal seeding when we perform EUS, and that we may actually iatrogenically upstage the patient. It's considered a contraindication to liver transplantation, and so really important if we see a perihilar stricture and resectability status is not known, that we don't just go ahead and biopsy that stricture. So the ESGE guidelines are that EUS tissue acquisition for perihilar strictures can be considered when ERCP-based modalities yield insufficient results, provided that curative resection is not feasible or cross-sectional imaging has shown accessible extraluminal disease. So where it comes in really handy is in picking up a lymph node and being able to target that lymph node. And that won't affect resectability if that lymph node's benign, and if that lymph node comes back metastatic, then that patient's not a resection or transplant candidate anyway. So to summarise, for perihilar strictures, if drainage is needed, then the first step is ERCP and conventional biopsy methods. If this is inconclusive, an EUS guided biopsy can be considered if it's unresectable or there's an accessible mass outside of the stricture. If this is inconclusive, we'll go across to indeterminate biliary strictures, which I'll talk in more detail about later. So moving on to distal disease, and this is a little bit different. So for ERCP tissue acquisition, again, the standard techniques carry an overall very low sensitivity. Brush cytology is 45%, intraductal biopsy is 48%. Again, if you combine them, you get an incremental yield. Now, EUS is very useful in a distal bile duct stricture, so it enables visualization of any bile duct masses, any thickening. It allows you to target your biopsies. It aids in tumour staging, access to lymph nodes, but also if you've got a pancreatic head mass, your EUS biopsy is actually within the resection window. So your risk of peritoneal seeding and upstaging the patient is very low. And you can see this is a nice EUS image here where you've got a dilated bile duct. You can see some wall thickening or tumour extension into the distal common bile duct, and then you've got a mass down here. So how does ERCP compare with EUS for distal bile duct strictures? ERCP carries quite a low diagnostic accuracy, and this is much better with EUS tissue acquisition. If we look at the combined approach, this becomes even higher, so 93 to 98%. And if the patient requires drainage anyway, then the combined approach does not increase the risk of adverse events. So if the patient has a distal bile duct stricture and they need drainage, then it's recommended to undergo a single session EUS and ERCP. So just to summarise, distal disease, if drainage is not needed, then we do just EUS and tissue acquisition. If drainage is needed, we do EUS and ERCP in the same session. If it's inconclusive, we'll go on to the next steps. So an indeterminate biliary stricture characterises up to 20% of biliary strictures. There's no standardised definition, but it's generally considered indeterminate if no diagnosis has been established, despite adequate cross-sectional imaging and ERCP with conventional tissue sampling. So cholangioscopy allows real-time visualisation of the biliary tree, and we now have quite a good idea of what sorts of features we see in a benign fibroinflammatory stricture versus what we see in a malignancy, and we saw that very nicely in the last live case there. So cholangioscopy provides an incremental yield of 27% over standard ERCP and tissue acquisition. How good or how reliable is visual impression at ERCP? So this was a meta-analysis which looked at this, and they found actually visual impression is quite reliable, so sensitivity of 94% and specificity of 95%. These are two papers which very nicely summarise the changes suggestive of malignancy at cholangioscopy. And so we see things like an irregular margin, which Nam pointed out at the previous, in the previous case, mucus, irregular vessels, you see this dark mucosa, and you see papillary projections. And then this study looked at which of these findings has good inter-observer agreement for malignancy. So the features that came out were tortuous and dilated vessels, irregular nodulations, and friability, whereas raised intraductal lesions, irregular surface with or without ulceration, not great. So here's a nice video of a malignant stricture, so you can see a clear demarcation here between relatively normal mucosa versus the tumour, so we're just entering that malignant stricture now, and it's very friable. You see all of that contact bleeding. You can see the dark mucosa, some mucus on top, and then we can of course use biopsy forceps directly through the cholangioscope to provide targeted biopsies. Now at our institution we'll perform the biopsies, and we'll also perform aspiration cytology as well. Okay, so in this patient, the biopsy and the aspiration cytology both came back as showing cholangiocarcinoma. In contrast, this is another stricture that looks very abnormal, but this, you can tell, is very different to the previous one. It doesn't have those kind of raised areas, the papillary projections, and this is a benign stricture in a PSC patient. So how does biliary sampling compare with visual inspection in indeterminate bile duct strictures? So this is the sensitivity specificity for combined biliary sampling, and you can see actually visual impression does really well. What happens though if the patient has PSC? Both biliary sampling and visual impression perform significantly worse. So PSCs really should be considered a special population. This is a study we did at our centre looking at 45 patients with indeterminate bile duct strictures who were found to have atypia at cholangioscopy. And if you're someone that works with ERCPs and strictures, you'll know that atypia is just a very, very frustrating thing to get at biopsy. I think this is an important slide that highlights in non-PSC patients, 84% of those patients went on to be confirmed to have a malignancy, whereas the reverse is true in PSC. So in PSC, 85% of those patients with atypia actually went on to have benign disease. Does the degree of atypia matter? So if patients were called to have highly atypical cells, then in this study, none of those patients ended up being benign, whereas if they were purely called reactive or inflammatory atypia, that was 50-50. So this is another patient of ours who had a malignant, visually malignant appearing stricture. The first ERCP was performed and our biopsies and our brush cytology only showed atypia. We decided to repeat a cholangioscopy a few weeks down the track, and then our aspiration cytology showed cholangiocarcinoma. So what we do at our institution for indeterminate biliary strictures is we perform cholangioscopy. We will do both biopsy and aspiration cytology and form a visual impression. And if this is still non-diagnostic, but there's a high suspicion for malignancy, then we'll repeat the cholangioscopy, or we'll discuss at an MDT whether it's reasonable to proceed straight to surgery in a resectable patient. How else can we improve diagnostic yield for indeterminate biliary strictures? So as I was cutting down my talk, I deleted slides on intraductal ultrasound and FISH because I think we've really moved away from those things, and the new kid on the block is next generation sequencing. So this was the original study in gut in 2020 by this group who looked at a 28 gene NGS panel called BILI-SEQ, and this is derived from genomic alterations in biliary neoplasms. So this is too complex for me, but basically if you look down the bottom, green is patients who ended up having benign disease and red is patients who had malignant disease. So they had 60 or so patients in the training cohort and then about 200 patients in the validation cohort. So there were genomic alterations identified in the malignant cohort, including KRAS, TP53, CDKN2A, and from there they've built this BILI-SEQ. So in terms of using NGS for biliary neoplasia, you can see it carries very high sensitivity and specificity for both non-PSC biliary strictures, but also quite significantly in PSC type strictures, you can see where the sensitivity of cytology and histology dropped to 8%. NGS really retained that sensitivity and specificity, so I think it'd be really useful in this cohort of difficult patients. The other thing to note is that therapeutically relevant genomic alterations were identified in 8% of patients. So that is patients who were identified to have a mutation, were then given targeted therapy and had a measurable response to therapy. So this group then went on, and this paper was just published this year in Gastroenterology. It's a bit of a busy slide, and I actually cut off more than half of the authors to try to fit this on here. But they included 28 institutions, over 2,000 patients, close to biliary specimens, and they looked at how BILI-SEQ compared to standard pathology. They did go on to develop version 3 of BILI-SEQ, so version 2 had 28 genes, version 3 I think has 161 or so genes, so they've included a lot more genes. And what they found was if you just compare NGS with pathology, there is significantly higher sensitivity. Specificity is about the same, but really the important result is that it retains even in PSC. So sensitivity is still 85%, I don't know how to go back, even in PSC. And if you combine NGS with pathology, yes, you get a bit more sensitivity, but really just using NGS alone, you get really impressive results. And just very briefly about AI before I finish. So AI is coming into every part of medicine, it's coming into every part of gastroenterology, and of course it's coming to endoscopy. So this was a study in GIE in 2023, which enrolled about 154 patients, used the majority of them to train this convolutional neural network, and then had a few test cohorts. So still all very early data, and they found a significantly increased accuracy when this AI was used to determine malignancy. This is a good summary paper on how AI is applied in biliary pancreatic disease, both in cross-sectional imaging and in endoscopy. And one of the things they included was this table, which you can see in terms of cholangioscopy, across the board, accuracy is quite good, but it does vary, including this study where accuracy is down at 80%. This AI, as you know, will depend on the level of training, and at the moment there's a lot of devices out on the market, and limited study. So there's promising results from real-time AI models, but we're awaiting validation in large external studies. So in summary, I think hopefully what you've got from this is that multimodality sampling is really helpful in biliary strictures. Cholangioscopy helps to aid stricture differentiation. PSC remains a diagnostic challenge, and that atypia in PSC strictures is actually mostly non-neoplastic. But of course, these patients are high risk, and therefore we do need to keep chasing if our suspicion is high. And that advances in next generation sequencing and AI are promising. Thank you.
Thank you, Linda, for an excellent presentation. We'll move on to the next topic.
It's a slight change in the schedule. We're going to go on to a talk now, and we're running about 20 minutes behind. So sorry, Linda. We'll ask questions maybe during the break. So it gives me great pleasure to introduce our next speaker, who's a good friend of mine, Dr. Sandeep Lakhtakia from AEG Hospitals in Hyderabad. Sandeep's internationally recognized for everything that he does in interventional endoscopy. He's a current director of endoscopy and EUS at AEG. In addition to that, he has a host of other positions that he holds, including being the current treasurer of the Asian EUS group. He's received the Crystal Award for International Service from ASGE. And the topic, we're greatly honored to have you here, Sandeep, and the topic of your talk today is going to be difficult biliary stone, your tips and tricks specifically. Thank you.
Thank you, Vipul. Can I have my slide? Careful. How do we change laptop? Okay. Thank you. So before this comes, I would like to thank everybody, especially Nam and William, for inviting me here. This is my first visit to Australia, and I'm delighted to be here amongst all of you. So I'll be speaking on the difficult common bile duct stones. Should I? Something? Do I connect again? Is it connected? This no, sorry. This is not connected here. Okay, now it come. Okay, now it should come. Let's see. No, it's it.
It's lovely, but not what we need to see.
Okay, now you can. Now you're seeing it. It's there. Will it come now? Yeah, here it comes. So I'm delighted to be here in the Adelaide Pancreatico-biliary Live Symposium, and that's the topic, difficult bile duct stones, my tips and tricks. So when we have stones in the bile duct, we often resort to ERCP, and we use either balloon or basket to remove the standard stones, which are less than a centimeter in size most often. And these stones can be removed in about 90% or so patients. But sometimes the stones can be difficult. And what do we mean by difficult is, I'll just allude to in the next few slides. Sometimes the stones are small and they just can be sucked out after a liberal sphincterotomy. So definition of the difficult biliary stones is when you fail to extract them with conventional ERCP, and they're seen in about 10 to 15% of patients who have these stones. And these include stones which are large in size, 15 millimeters or more, stones which are multiple or impacted, and if they have associated downstream biliary stricture, or if there's a normal tapering bile duct which prevents a stone, even medium-sized stones, to come out, or they have an atypical location like Meredith syndrome or intrahepatic stones. And I've also included patients who have altered surgical anatomy or altered anatomy for any reason where these stones cannot be removed. So some of the examples, this is a large stone here, or a small stone but a stricture just below it, which cannot take it out in one go. Or the stones is relatively bigger, but the stone is, the lower CBD is narrow, or there are stones inside the intrahepatic ducts. Some more examples, you have a medium-sized stone but is faceted and square-shaped, or there are multiple packed stones with a relatively narrow bile duct, and same goes here. But you can have very large CBD stones, which we sometimes see in our practice. Like you see this stone, which is about 5 centimeters long, and this stone, which is about 9 centimeters long, and this stone, which is about 5 centimeters by 3 centimeters. So these are really big ones, and the narrow ones with the distal duct, which is narrow, can also pose challenges. So how do we manage these stones? There are several ways to skin cat, but this is one of the commonest ways that we use for stones which are large in size and the distal bile duct is narrow but not so bad, where you do a small sphincterotomy and pass a large balloon inside. This is a CRE balloon over the same guide wire, and you can inflate up to 12 to 15 millimeters. But this diameter is actually dictated by the lower bile duct diameter. You cannot go all the way to 20 millimeters and the lower bile duct is only 10, then you cause injury. So it's a duct which is 10 mm, you can go to 12 to 15, so that it just stretches the lower bile duct to extract the stone which is bigger above that narrow segment. There are several publications on this front and which have shown that this is quite effective. The most commonest size of the balloon is up to 15 millimeters, and when you inflate this balloon, we keep it inflated for about a minute or so. Small sphincterotomy is always helpful, but if you're not, like some of the conservative endoscopists, then you need to put a plastic stent in the pancreatic duct up front to prevent any kind of pancreatitis. What about the stones which are not amenable to be removed by this EPLBD, or endoscopic papillary large balloon dilatation, is to break the stones inside the bile duct. And there are several methods of breaking these stones. I'm sure some of you must have used it. Cholangioscopy is in fashion now. But before that, there was a mechanical basket where you use a large basket, catch the stone with the basket and break it up with a mechanical lithotripter. I'll touch upon all these techniques, and the last is extracorporeal shockwave lithotripsy. So the ESG guidelines recommend that mechanical lithotripsy is still in fashion and can be used for difficult bile duct stones when you do sphincterotomy along with EPLBD has failed. So how is it done? I'm not sure whether some people have used it. Our requirement for this is come down drastically with the available of cholangioscopy and laser lithotripsy. But if you see, this is a device which is a basket which goes inside, catches the stone inside. Stones up to 25 millimeter or below can be caught by it. If a large stone, then it doesn't get grabbed by the basket. And once the basket grabs it, then you push the metallic sheath in this mechanical lithotripter to reach the tip of the device, and then you crank it up and break these stones. And then the fragments are removed either by the same basket, or you can use a balloon to remove them. The external part of this handle of the mechanical lithotripter has different shapes, and these are generally from Olympus. This is from Boston Scientific, called trapezoid basket, which can catch stones up to 2 centimeters or so. If you look in this, how it actually looks at, this is a basket which has caught the stone, and this is in the stomach. This is ex vivo. It's in vivo, but in the stomach of the patient, and you see the stone being broken. So it has to be nicely grasped from all sides, and then only it breaks well. But the stones which are much bigger, the basket cannot catch and hence cannot break. Or the stones which are impacted, then the basket cannot go around it and catch it. But if somebody has a stent before, then you have enough space to push the assembly of the basket and then grab the stone. So these things help. Where actually it is useful is in emergency situations, where you think the stone is small, you've caught it with a standard basket and trying to pull it out. Now the basket is not coming out to the papilla and you're now stuck. So what do you do in such a situation? You cut the basket, the sheath of the basket, the wire then comes out, and that's attached to the external device of the mechanical lithotripter, and then you roll it up and push the metallic sheath all the way inside, and then you can actually crack it up and take it out. So this is how it looks like, the basket with the grasp stone, which is often at the lower end of the bile duct, where you bring the metallic sheath after removing the scope, and then you can actually see this stone breaking on fluoroscopy. So what are the success of using a mechanical lithotripsy? Stones which are less than 2 centimeters, it's very good. Stones which are bigger in size, since it cannot grasp, the success rate keeps dropping as the size increases. So the most favorable technique to break the large stones is cholangioscopy guided lithotripsy. We saw the nice videos of cholangioscopy in the previous talk, Linda gave it. In this cholangioscopic guided lithotripsy, we pass a laser fiber or a EHL fiber, which goes through the biopsy channel of the cholangioscope, standard cholangioscope. And once we reach close to the stone, then we break these stones. They have to be flushed with saline, and a distance of 1 millimeter between the stone and the tip of the laser is the ideal, although it's difficult to calculate. So if you touch it very closely, it actually drills through its way. But if you're just away from the tip of surface of the stone, then it breaks well. But if you're far away, then it won't break. So you have to be very close and keep it flush, so to have water interface between the stone and the laser fiber tip. Let me show some example of it. This is a laser fiber which is coming close to the stone, which is, you can see through the cholangioscope. You can often see a green light actually coming out of it, which means that the laser fiber is active. And these have to be preloaded sometimes to prevent any technical challenges which can be faced in pushing out this laser fiber out of the cholangioscope. The moment you break these stones, a lot of muck comes out and the vision can get hampered, so you need to be having a good pump to flush it out. And once the stones are broken well, you can actually remove them either with a balloon or a basket subsequently. So the efficacy and safety of per-oral cholangioscopy with intraductal lithotripsy for difficult bile duct stones, this meta-analysis showed that the overall fragmentation rate is more than 90%, and in single session you can do about 76% or so. Sometimes the stones are so big that they may require a fewer subsequent sessions as well. How does it compare with other methods of removing these stones? This is a standard of care versus laser lithotripsy, and the success rate with laser is 93 versus 67. How does it compare with EPLVD, which is a common way of treating this? This study from US Shams group showed that the success is 94% versus 73 with mechanical lithotripsy versus the EPLVD. It also has been compared with mechanical lithotripsy and found to be more effective compared to mechanical when we use a laser lithotripsy. Not only that, but it also reduces the fluoroscopy time. So that's the major advantage, that not only of success, but also reducing the radiation to the room. So primary intraductal therapy of large CBD stones with cholangioscopy is considered when the stones are big, they are unusually located, and they have a distal stricture. What if somebody does not have all these things and has another option of breaking these stones? This is extracorporeal. The previous techniques were intracorporeal. And in our unit, we use it very often to break the pancreatic stones, and we use the same technology to break even the bile duct stones. But since they are not radio opaque, we put a nasobiliary tube up front, opacify at the time of cholangiography, and then give external shock waves, which can be useful in patients who have very large stones. So how do you choose which one over the other? Intraductal therapy is preferred when the stones are very, very big. Mechanical can be used in stones which are about 2 centimeters or so in size, and just sphincterotomy and standard of care can be used for patients who have stones about centimeter or less. Now let's look at stones which are at abnormal location.
This is intrahepatic stone. MRCP shows stones right there. And going deep inside is sometimes challenging, but you can use your cholangioscopes, especially the current cholangioscopes, which are much thinner, almost reaching 7.5 French, compared to the starting ones, which are 10 French. Here, over the wire, you can reach the stone in the left hepatic duct. Segment 3, this is the stones which are impacted there, and you can break it if required, and they're fixed. This is a video borrowed from Haas Neuhaus, and you can see EHL being used to break these stones. Meridzi syndrome is another area where cholangioscopy guided laser lithotripsy has made a huge difference, and these are the stones which are actually inside the cystic duct but compressing into the bile duct. And standard of care was earlier surgery, but with the availability of cholangioscopy guided lithotripsy, we can actually go inside the cystic duct, provided it's wide and easily accessible, and then do laser lithotripsy to break these stones. Especially gratifying in a post-surgical scenario where you don't want another surgery to be done in these patients, or even a pre-surgical scenario where you can avoid a major surgery and restrict it to a more simple cholecystectomy or a non-HA. This study, which was a SEAS study, combined effects from several authors, including us, showed that digital spyglass with Meridzi is effective to break these stones. It is superior in patients who have underlying comorbidities, and is very valuable in downgrading the extent of subsequent surgery by potentially reducing the need for hepatojejunostomy or a conversion to an open surgery. So this is where it makes a difference. So the algorithm which needs to be followed in patients who have difficult or large stones is, if the stone is not impacted, one can try an endoscopic papillary dilatation with large balloon and then try to remove the stones. If it's successful, it's fair, but if not, then you look at the diameter of the lower bile duct compared to the stone. If this ratio is less than 1, which means that the stone is smaller than the lower bile duct, then you can try mechanical lithotripsy. But if it's more, that means the stone is unlikely to come even after dilatation, then you have to break the stone inside the bile duct, where you can use either mechanical or laser lithotripsy. And if nothing works, you can actually place a stent and come back and do these later. A few, if I have time, I can just continue. A few more slides. What are the alternate options if a patient has difficult bile duct stones? For example, if there's a periampular diverticulum and you're not able to enter inside the bile duct. The stone may be small, but you're just not able to enter. So let me show an example. This is a patient who had stones in the bile duct, but the papilla is inside this diverticulum and you cannot see where exactly it is. We did an EUS and found some stones inside. So we used a special technique by EUS. We punctured the bile duct using a steerable axis needle. Here you can see the tip of the FNA needle can actually be bent in different direction using the proximal end. This is called as a beacon needle. And once we go inside, then you can manipulate the wire towards the papillary side so that it comes outside into the duodenum. You fill with a contrast also. So here you see multiple stones are there, and the guide wire is being manipulated down because tendency of this guide wire is to go towards the intrahepatic segment, and you are trying to bring it down. Here it comes to the papilla, and then you can do a roundover procedure by ERCP. Enteroscopy guided ERCP also is effective with patients who have stones, but you just cannot reach the papilla because of surgical altered anatomy. Let me show an example. The patient has post-gastrojejunostomy and gallstones and CBD stones, and a single balloon enteroscopy is being used here. You reach the papilla, cannulate with a forward-looking cannula, and then the guide wire goes in, then you can dilate or make a small sphincterotomy, and then dilate more, just like EPLBD, and take out the stones from the bile duct. So these are stones being dragged through a enteroscope, which is a little more challenging compared to a conventional ERCP. And last but not the least is a percutaneous cholangioscopy. If the stone patient has an altered anatomy and you cannot do ERCP, you can pass a shorter cholangioscope. This is SPY Discovery from Boston Scientific. So through the PTBD, you create a path, then use a cholangioscope to cannulate through the same fistulous opening which you have created, go inside the bile duct, visualize the stone and break it from top down. So this is a cholangioscope inside. You put some contrast, you see a stones inside. And the same technology is now provided percutaneously and not through the ERCP route. In fact, these cholangioscopes are much shorter in length and much more easily maneuverable and controllable. So here the stones are being broken by laser lithotripsy. So in the end, I would like to conclude by saying that most stones in the biliary tract can be removed by ERCP. It's a large CBD stones or difficult stones which require alternate methods of removal. And the commonest preferred is endoscopic papillary balloon dilatation. If not, then you do cholangioscopy guided breaking of the stones within the duct, which can be using either laser or EHL, whichever is available. Mechanical lithotripsy, the use is going down because of its complexity of the device, and alternate options can be considered in patients who have a different kind of anatomy. I would like to introduce my team at AIG. These are the people who work with me and who are guiding each other in a progress. Thank you very much. I would like to also invite you to AIG Live at Hyderabad, India in December 4th and 5th. Kindly note the dates. Vipul, Krish are joining us there. All of you are welcome. Thank you.
Thank you, Sandeep. That was an excellent demonstration and clarified various techniques that can be utilized for these very complex and difficult stones. I think we've been asked that we go straight on to lives for now, so thank you.
Just moving on to our last two live cases before lunchtime. The first one is a patient for US guided portal pressure measurement. She is a 24-year-old Aboriginal lady who has a past medical history of autoimmune disease, including SLE, which she's immunosuppressed for, as well as hypothyroidism and CKD. And she has a history of active alcohol use disorder. She was recently admitted with an upper gastrointestinal bleed, and her gastroscopy found portal hypertensive changes with no varices, and also was noted to have LFT derangements as well as CT findings of portal hypertension, including a recanalized umbilical vein, paraesophageal varices, and splenomegaly suggestive of underlying portal hypertension. So we're proceeding to a EUS-guided portal pressure measurement and simultaneous liver biopsy. Over to Tech Suite 4.
Right. Can you hear me?
We can.
Okay, great. So my task actually is to clarify first actually if they're truly a portal hypertension by directly measured, and second is actually to work out what pancreatical disease actually this lady has. She's quite young, and I think the controversial exactly is one is exactly cirrhosis, second exactly does she have autoimmune hepatitis on top of her alcohol. Sorry. Okay, so I think exactly, can you let them know that the image exactly is not broadcasting?
All right, so once we...
Yeah. So once actually you have the image visible, you have had the endoscopy done before,
There's no esophageal varices or any fundal varices, but actually I'm just trying to show the half view of the EUS on the GOJ here. She has significant reflux changes, but no varices. And then when we...
Yeah. So, I mean, I guess the question with this case is that we have a bit of discordance between our radiology, which is very strongly suggestive of portal hypertension, and our clinical and endoscopic assessment, which doesn't really sort of quite fit with that. And, you know, this patient doesn't have ascites. The redness in the stomach, Nam and me were just sort of discussing, may all be... All right.
Sorry. Scott, can you actually fix the problem, please?
Can you just duck out to the control area and let them know that we can't see the...
Sorry. Every live symposium will have minor glitch and hiccup like this. I'm sorry.
But I think this case, whilst you're waiting for our view, is a really good way of showing endohepatology, because we can look at the portal vein, we can look at the hepatic vein, so we can give direct venous assessment, make sure that there's no evidence of thrombosis. We can look at the liver parenchyma, we can look at the region of the spleen, the splenic hilum for perisplenic varices around the esophagus, so we can do just a visual assessment. And then using the techniques that we've heard Jason talk about, we can then directly measure the portal pressure gradient by accessing a branch of the hepatic vein, by accessing the portal vein, and also then getting direct tissue acquisition. So we can get an EUS-guided core biopsy of the liver, which will give us answers about the degree of fibrosis, about any markers of autoimmune hepatitis, and also whether there is small vessel vascular changes to suggest things like veno-occlusive disease. So I think this really is that one-stop shop concept manifested in a true clinical scenario.
Yeah, I think we promote this endohepatology for the last probably 15 years now. But I don't think it took up that well because the case is quite specific. Yes? Okay, let's go ahead, right?
Yeah.
Okay.
Yes.
Definitely will. Okay, so this is actually the query portal gastropathy that they mentioned about. It's a very non-specific. I'm just going to turn on the ultrasound now to actually show you the liver and the venous system. So this is actually the SMV. I pull back into to the portal here. Oh, yes. Okay. So SMV portal, and I'm going to the liver here. Okay.
Yep.
And then I'll go to the left, and then the right portal vein will be over that side. That's actually the gallbladder. And you can see the liver parenchyma is relatively normal. I don't see any coarse architecture of cirrhosis at all. But we'll have to do a biopsy to look for histology. Now, in terms of screening for cause of portal hypertension, that's not related to the parenchymal disease. So we have to have a good look at the venous system that can cause it. So you can see that the SMV, which is here, is widely patent, normal. And then we come to the portal vein here. If I move a little bit, this will be the splenic vein, and you can follow right to the spleen. Now, there are the few gadgets with the new Aplio. Certainly, we can do the shear wave. This is area shear wave, which I think give you the score, very compatible with, I have to set it first, sorry. So let me show you technically a shear wave pressure here. You can change it into kilopascal, and here you see the score. Now, we don't actually have a normal reference range actually for the area shear wave of spleen or the liver. This is actually work in progress. We are collecting actually data actually that we can establish actually the normal range. We can't actually compare it actually like with the FibroScan. But this is actually a technology that actually allows us actually to assess actually the stiffness of the liver and spleen. Okay. Now let me go back actually to the liver to show you the vascular anatomy. So actually I show you actually the portal veins nicely. If I pull back and counterclockwise, I get the inferior vena cava here. Okay. And if actually I just actually pull and trace that back, you can actually start to see the hepatic vein. So if you clockwise rotate exactly at the junction there, this would be the middle hepatic vein. Okay. In this case, it's very nice and actually dilated. I'll actually turn a little bit more. This is a right hepatic branch, and the left one is actually right down below here. Let me see whether I can actually, there, okay? So actually you see actually three major hepatic branches actually from there. So we're going to actually go ahead with the portal pressure measurement now. So actually we assess actually hepatic pressure first, and uniformly we prefer to do it from the middle hepatic branch. The trick is actually to minimize any risk of bleeding. We will have a cushion of parenchyma. So in this case actually 2.3 centimeter cushion, so that when you actually withdraw your needle, you won't get bleeding. But again, we do this with the EcoTip inside, which is actually a 25 gauge needle. The risk of bleeding is very small, extremely small. I think actually so far all of the trials have not reported any bleeding complication.
Did you want to show the tonometer now?
Oh yes.
Yeah.
So Milan will show you.
So this is our measurement device. If we
can we change to the in room
on the camera. So we've got our fluid seal to give us, and a tonometer that we do need to, when we measure, have at the same level as the patient. But this is what's going to give us our direct pressure reading. So as Nam puts the needle into the vein, sits it there, we're going to look at this reading, record this reading. That'll give us our direct hepatic venous pressure, and then we can do the same sort of thing when we puncture into the portal vein and get a gradient or reading there, and then we can calculate our gradient. And this is a direct gradient. It's not an inferred gradient or a wedge pressure. So
now the trick with this system is you can't have any bubble in the line. Otherwise, actually, it causes artificial high reading. So actually that we take extreme care in flushing actually the needle and the line with HEP saline already. Okay, so I think actually I'm going to get the needle into the, okay, the middle branch. Okay, flush. You can see actually the actual micro bubble come out from the flush. And the other trick is I relieve all of the bridge pressure on the needle. So you don't want actually any pressure, artificial pressure on the needle.
Yeah, it's a very fine needle, and so you want everything to be just sitting very still. So we're just giving it enough time for the whole system to equilibrate.
Normally we read exactly at 45 seconds. Yeah. 45 seconds is very long for me.
I'm surprised you could do the RFA.
11? Okay, let's do the second reading. So again, we flush. And you can see the flush there. Okay. And then we wait. So technically, it's not exactly a demanding procedure. You just need to understand your anatomy and make sure that you have a good cushions of parenchyma when you puncture into these veins, either the hepatic or the portal vein.
Yeah, that's really important to give you the tamponade on the puncture site.
So the good... I pray, I think. There's nothing that you can do.
Yeah.
I mean, actually, I'll go ahead and do the liver biopsy later. There is actually a trick that actually Ken Chen actually proposed actually of doing this stepwise actually withdrawal of the needle after you've done your puncture and actually back and forward flow. By creating this step withdrawal, you can actually, and wait, you can actually minimize the bleeding. But if you have bleeding after you withdraw actually the needle, there's very little that you can do.
Correct, correct.
So, so in fact, actually, if you look at all of the portal pressure study, there's no bleeding complication, except if actually they do concurrent actually liver biopsy.
And it's important to select your patients as well. You're not going to do this in a patient with a platelet count of 10. So.
No. And we did check. So actually this patient had platelet of 200 and INR normal.
And
no, it's a gut feeling. I mean, actually, I think this actually will be classified as high-risk procedure, 11-2. Okay. So we actually have consistent pressure of 11 millimercury, effectively for the hepatic vein. So I'm going to actually pull back. You can actually put actually the flow on here. This is microvascular flow, just actually to make sure. I'm not sure whether it's a good thing to do. It's just raise actually a lot of anxiety here.
But you can see that there's no major leak out the side of the vessel. There's no hyperechoic sort of blush forming on the normal EUS view as to where we've punctured in. So I think you're in good shape there now.
Yeah, well, I mean, actually, you can put actually the flow on there. There's no track actually that leads actually to the bleeding.
So I think with the microflow, otherwise you can see little branches coming off that are about the same size as your needle. I think with your question before, Vipul, probably 50 to maybe 70 for platelets and INR 1.3 to 1.5 would be the sort of cutoff. So I think the trials all kind of arbitrarily picked a number based on this being a anticipated high bleeding risk, and so that's all we've got to guide us.
So now, yeah.
Correct. Yeah. And I think the biggest thing is the location and having that cushion of liver tissue there to help give you the tamponade.
So that's exactly the left portal veins here. Again, I'll try to actually have a good cushion level, and this is at least 2 centimeters. So I'll be good actually to go in and measure this now. I have to say actually that the imaging is excellent. Is that okay? Let's flush and measure the pressure here.
You saw how delicate that puncture was. This isn't like an FNA where you want force and you want cutting and shearing of tissue. It's really important that you're very, very gentle.
No, you remove everything already. The needle already pre-primed with actually hep saline with no bubble. And then you actually have connect the whole system ready to go.
So when the needle goes in, you already have the tonometer connected. There's heparin saline through the whole system. And so you should have just fluid running all the way through, no bubbles, no gas, no dead space.
So in our center, what's the pressure? Not yet? Okay. We actually uniformly do it for preoperative assessment. 20. So the pressure is 9, huh? Okay, the gradient is 9. Okay, let's go for a second reading.
And so every time we're doing a reading, we're just a bit more of that heparinized saline, clearing any blood that's in the line, and then trying to get another reading. And what we want is to try and get consistent readings. And you probably can't see it on the camera, but Nam's taped the tonometer into place. It's on a clipboard, so it's on a rigid, fixed surface. The patient is very well sedated, so there's no movement. And if I bump the bed, Nam would give me a very dirty look because it'll stuff up all the readings. So I'm standing back from the edge of the bed as well.
Correct. I mean, there's actually always discussion about the effect of propofol on the pressure. And I think actually my general response is actually it will affect both of the pressure. So actually the gradient should be actually the same. 20? Good. So actually the second gradient is 9. Let's go for the third. Yeah, I mentioned before that we do portal pressure measurement uniformly for preoperative assessment here for our surgeon, particularly pre-transplant. And we actually do pressure and actually biopsy often actually at the same time. We do actually between 10 to 15 cases a year, not a lot, because these are super specialized actually or specific patients. Vipul, can you actually ask how many centers in Australia do portal pressure measurement by EUS?
21.
21.
Okay.
So last gradient is 10. Okay. So actually at least it is actually performed. All right, again, so we have actually done 3 measurements. It's consistent. It's actually around 9, 9.5. So definitely the pressure is high, reaching clinical significance. So actually if the gradient is actually more than 10, actually we worry, and actually it's up there. So I think actually let's go ahead and do the liver biopsy now. You see that's actually with the microvascular flow. You see that beautiful needle track? Yes.
But that track, I think, was your final withdrawal of the needle.
Yes. Now, I'm not exactly too worried. If you don't actually have with the normal flow, you'll be okay.
Yeah.
Remember, microvascular flow is super sensitive, okay?
And you may be getting blood filling into the tract from the liver parenchyma, not the portal vein, because we're not seeing hyperechoic streaking along that track. We're not seeing microvascular flow in the hyperechoic tissue around the portal vein as well.
I mean, you're not worried about that, but that's a good demonstration of the value of the
Correct.
So now we've gone from a really tiny needle to a really big one. So now you use heparinized saline and wet suction as your approach?
Correct. So my usual practice is actually do a long puncture. It's actually trying to get a long core. Until last year when actually that variable suction paper came out suggesting that's a better technique, and I've tried a couple of times. I'm not sure whether actually it's a lot better than actually the old techniques, but I'll try actually to demonstrate both. I'll probably do actually a few back and forth here, but I'd actually say this is the first time I use a 19-gauge Secuflex. Normally we use actually 19, either the Francine tip acquired or actually clear core. But actually this is the first time we use actually the Secuflex 19. So the same concept as any biopsy. You check for flow. I think exactly for liver biopsy, you want actually a good runway. Now, when I say runway, exactly you need to actually avoid this vascular structure or ductal structure in your puncture path, because actually you ask for trouble if actually you do so. So I have actually to find a window where actually there's not much actually in the path. This is probably be okay. I don't see anything here. So I will actually try actually to get the needle in that path there. Okay.
And the vigor with which you biopsy this, compared to, say, a solid lesion, you're not going to be pushing anywhere near as hard. You want the negative pressure to do most of the work for you.
Correct.
You're not trying to aggressively cut tissue like you would where you've got a sort of desmoplastic, very dense stroma that you're trying to access. So.
Yeah, here I think exactly what you try to do is actually get a good course, actually, and have that minimum required portal track for the pathologist actually to make the diagnosis.
So endohepatology is definitely something for gentle hands.
Okay, so I think actually that is a good area with no significant blood vessels. So now I'm in. So this is where actually I put suctions on with actually the saline in the needle already. Okay, so normally I would actually go straight down, and then I'll turn the suctions off, and hopefully there'll be core in there. I'll do a bit of actually fanning, and then I'll touch suctions on, and then go down. Try not to actually puncture actually that branch actually of probably the portal vein, and then exactly I'll turn the suctions on, fanning, and go for another pass. Okay, I think exactly that's enough pass. Now I'm going to you can see that actually this needle is actually a very big needle, and it does cause actually a lot of signal here, and this is where actually you need to be patient and wait.
So now your needle is still within the liver parenchyma?
Correct. You can't actually withdraw. I think actually if withdraw now, that tract quickly will spurt actually the blood out. Okay, so you probably actually now I'm trying to actually do the what we call the zigzag needle tract. So that's actually that's it. I've moved actually to the next area. So that's actually I've stopped actually that path. Let's see if I stop it. Maybe.
Really?
And allow things actually to coagulate. Okay. You can see actually, because this machine is actually so good that actually you can see the track that we create with the biopsy, you know? You see that?
Yeah.
That's not just the machine. There's a clear track there.
So I think we just actually wait until there's less signal. But I think that's actually the concept of doing the biopsy. Now, maybe actually we ask Jason, given that actually he do quite a bit of this, what's his trick actually of preventing bleeding after a big liver biopsy?
The other thing is you can probably put the probe over where the puncture site on the liver capsule is. So as long as it's not leaking out, it should probably clot within that needle tract. And it may be a little harder to clot with the needle still significantly inserted in the liver parenchyma. So I guess it's a bit of a leap of faith, but you can probably pull the needle back and just put the probe over where the puncture site is.
So using the transducer to try and tamponade the side of the liver?
Yeah. Because that's what you would do if there's a wound on your skin. You know, you'll just put your finger over the puncture hole.
Anything that you would consider injecting into it?
You can't.
You'll lose your
You've got tissue in the needle.
Oh, after, then. You know.
But then you got to make a new hole though.
No. I mean, I think even with the most experienced unit like Ken Chen, they do actually have a serious case of bleeding from the liver biopsy.
I guess the question from
remember
the audience was if there was a serious, if the bleeding you thought was, I mean, this doesn't look like there's going to be severe bleeding, but if there was, as a salvage method, would you consider pushing your sample back into it at the cost of losing the sample and the whole, process is kind of null and void?
No. I mean, the risk of bleeding actually with this technique is the same as percutaneous, 1 in 100,
and that's
right?
The thing,
and most of the time, even if it oozes out a bit, it will actually stop if you actually have normal coagulation. Because patient might have a bit of pain,
most people who
no.
bleed after a perc biopsy have pain and they're admitted for analgesia rather than for embolization or other intervention.
I guess from a practical perspective, when are you comfortable just pulling it out and saying, well, it's not going to fully, the flow is probably not going to go over fully, but when do you think that enough's enough?
Well, about now.
I thought as much.
And you don't have to sacrifice your specimen anyway. You can pull everything out and then just go back down and have a look or keep the probe there. And if there's a bit of a hematoma, you can watch that as well, because the hematoma itself can actually seal that off as well. So it's not necessarily if there's a hematoma, then they're going to continue to bleed out.
But again, this is why you've got to make sure you check the platelets and the INR beforehand.
Correct. All right, so I think exactly it doesn't look too bad there. Definitely it's not actually leaking out anywhere. That's actually a vessel to me. Okay.
Should we retrieve our specimen then and see if we can show our audience the beautiful core tissue that you've achieved?
Let's express actually the specimen. And then I'll show you actually the puncture site, see actually if there's any bleeding here.
So the whole benefit of the heparinized saline is that you're trying to not have the blood clot, so that your specimen comes through and you can essentially dissolve the blood that's there, so you're left with your core of tissue without a lot of blood then expanding the thing. And you can see here there is blood, but you can see the blood is separated. And if we can see the view of the specimen, the blood is separated. And you've got a separate string of tissue there, whereas if you didn't have the heparinized saline, they would all be mixed up together in a solid clot. So we're getting the blood through the needle, and that's not surprising. You put a 19-gauge needle into a liver, you're going to see blood. But if we will just move the needle out of the way so I don't poke myself, but if we can just sort of zoom in on this specimen here, you can see the whitish grey string core, and that's our core of liver tissue. So that's the main thing that we want for our histology, because that's where we're going to get our architecture, our information about fibrosis, the portal tracts. There are some other little bits on the other filter paper.
Nam and Miller,
but this is our
I think we might consider moving to the next room where Linda and team are waiting. I think that was a great demonstration of both portal pressure measurements as well as the liver biopsy.
Do you have another jar? If we put this
so we'll
one
just move to the next
jar.
room. Thanks, guys.
Right. Thanks.
Just that way that you don't have so much blood with this one. You happy now? We'll put the one with the main core in a separate jar.
Yeah, we're not going to actually do any more biopsy.
Oh yeah, we can put that one into that jar as well.
Yeah.
Yes, put that one in there.
Do
Our next patient is a 43-year-old gentleman with a background of intellectual disability, OSA, type 2 diabetes, and previous cholecystectomy, who was recently admitted with ascending cholangitis and septic shock, and had a MRCP showing a small 6mm hypointense intraluminal focus at the confluence between the common hepatic and cystic ducts. He underwent an ERCP, which showed a small filling defect at the lower third of the bile duct, and there was still some pus seen, but the stone remained despite multiple sweeps of the duct. So for this case of a retained cystic duct stone in a post-cholecystectomy patient, we're proceeding to an ERCP with cholangioscopy and EHL. And over the text suite 3.
I think we can hear you, but we can't see you yet. Hopefully soon. Okay, that's a problem.
Can you see the ERCP picture?
No, we can't see anything yet. So there's no cameraman in your room? Is that what you're saying? Yeah. We can see you now, actually. I don't know how.
Can you see the ERCP picture?
Not yet.
Okay. So this is a challenging patient from his body habitus. So he's actually intubated on his back. His BMI is probably 50 plus, maybe closer to 60. And so the ERCP itself was quite challenging. The position itself, in terms of scoping, is different. As you can see, my hands are not upright, as you would normally in the neutral position. I just rotate the scope, and with a wrist action, you can actually stabilize yourself underneath the ampulla, which is not easy in him, but that's usually the way you can maintain your position. And you can see the scope is actually not under a lot of tension. The cannulation was really difficult, so I'm pleased that we're already up in the duct, and we've got the IMAX cholangioscope. I've got Linda here with me, and we're going to share this case together. So we at this point, we'll try and go further up towards the hilum. I've got a guide wire, which I'll give up at this point because it'll improve our maneuverability. You'll see that's the guide wire. Now we can put some...
So the other thing you'll notice is we have the distal cap on here as well, which we saw in the previous live case. It probably is a little bit skewed, and I think that's relating to the very difficult insertion with the patient positioning. But we can still, we still have very nice views.
So very clear mucosal views, and the cap, I guess, should allow us more maneuverability and maybe sweeping the fold, just as we would do in the colonoscopy. And we'll just come down the common channel very, very slowly. So this is common hepatic duct bifurcation, and we'll just come down from there. And the cystic duct will be about the 3 or 5 o'clock position. Patient had a stent in there, so we'll see some changes related to the stent. As you can see here in the 10, 11 o'clock position, we think those are stent changes. And then just opposite, here's the stone. This is the stone coming into view in the cystic duct. And you can see how it's impacted in that cystic duct orifice. Unfortunately, the cap is a little bit tangential, but we're quite happy that we're in the stable position.
Frank, do you think in this case the cap's more in your way than assisting you rather than helping you, or the other way around?
Well, we thought the cap would be really useful, especially if the stone wasn't impacted in the orifice and we'd have to go up the cystic duct itself. It might actually help us enter the cystic duct. At this point, we would want to use EHL. So we're currently using the 9 French IMAX, which has a 1.2mm channel, which is the same channel as the Spyglass from Boston. But there is, to get the EHL probe down, there is actually a snag. The plastic sheath of the EHL probe snags right at the end and the handle of the IMAX. And I'm told that there's a redesign where the channel will be 2 millimetres, which will fix that problem. We could use, so today we are going to switch to the 11 millimetre IMAX, which doesn't have that issue, because we do need to get the stone out. And that probably will demonstrate how difficult the cannulation was. So I've kept...
Frank, would you put your wire through now and do it over wire to help you cannulate, or are you going to do it freehand?
Yeah. So I'm going to put my wire back, so that's why I kept it. I didn't give it up completely. Screen, please. So we'll leave the guide wire up, and we'll just do an exchange. Yeah, we'll come out really slowly. Keep our view. Very precarious position at the ampulla. Screen, please. We've got plenty of wire. Screening. Yeah. There we are. Okay. Yes. Hold on.
Frank, do you have a preference of wire or just a standard 035? 035, what's your preferred wire for these cases?
Hold on, can we switch? Can we switch? I just want to see my position. So I used an angled 0.25 wire, and you'll see that I think we've displaced ourselves, so I think we'll have to start again because we're back in the stomach.
It's been a really tough position with this patient in the supine position, but also just we actually cannulated in the long position initially to get in, and once we were stabilised up at the high limb, shortened the scope to get that short position you saw us in.
So can I have the balloon back? Just a balloon with a guide wire, and then we'll see if we can get back up the duct, because I think people will start appreciating how difficult.
And so often you can cannulate directly with the spyglass, especially with the tapered tip of the cap, but in this patient, due to the angulation, I don't think it'll be possible.
Just quickly took the scope down. I'll just go back. It would be extremely difficult doing any sort of positional changes. We talked about putting him in left lateral or even swimmer's position, but that would be very, very difficult to do anything like that. So we would only do that if we absolutely couldn't complete this. Okay, so we're back down into D2. You can see the ampulla there. We'll try and go a little bit further. And then on right lock, and in this position, I'm pulling my scope towards my hip rather than keeping upright. So the positioning of my hands are different. Okay, we'll have the balloon back. Screen, please, just a touch screen. X-rays. Stop. So we've got a balloon with a wire. This is actually a short wire system with a long wire, because we need a long wire to actually get up with the cholangioscope. Right, okay, let's see if we can get the guide wire back up.
Just while Frank is cannulating, I think this is a perfect case for cholangioscopy directed lithotripsy. It'd be very difficult to get a wire across that obstructed cystic duct to perform any other therapies like balloon trawl or basket lithotripsy, so this is a very good scenario to use.
So I'm just using the long position because we found earlier that that was actually the position we could get in. However, getting the cholangioscope through in the long position was a lot more challenging.
Nam stitched you up on this one, Frank.
Oh, that's good. Okay, x-rays please. Okay, so the wire's gone back up. We'll just get the balloon out.
You can see how angled the duodenoscope is and how tough it's going to be to get the cholangioscope down.
Yes, we managed to use different maneuvers and eventually it just popped up. So the 11mm IMAX does not have a cap, so that's why we started with it. Here we go, just exchange. It'll be interesting to see your space because some of your ERCP scope is 3.7mm working channel, and we know we're now getting slightly bigger with 11 French, so it'll be interesting to see if that slides through okay. So IMAX, come over here. Right, okay, so we not at the moment, thanks. So this person's had a previous sphincterotomy and the fluid was coming out quite easily. I'm just trying to maintain any position. Yep. 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 And this IMAX does definitely look a lot bigger. So definitely a size difference. More tension. More tension, so the wire's coming in. So we're having to apply quite a bit of tension to the wire. And just on a feel side, it feels really tight. I think obviously this has been tested and 11 French does work. This 11 French has a 2mm channel. So it's got a bigger working channel, and so that's meant to be the advantage. I understand there's a smaller French as well, 7.5 French IMAX and that'll obviously make our surgeons happy because they often want us to see very peripheral ducts, which you can't really with these larger caliber cholangioscopes. There are very few cases. You'll see if we can maintain that position. Can I have the lights on for the IMAX? See how close I am to the ampulla. We should see our there we go. Just a bit more tension on the wire here. Help me, just here, yeah. Okay, we're getting onto the. There we are. So we're at the. I'm not showing you the second picture, but I'm just opening my bridge, and I'm trying to stay really close to the ampulla because I want to get the best chance of getting the scope up. So much bulkier, so a very bulky feel to this. We do have the wheels, so we're trying to see if that will help us with positional change. It's like a stent, I guess. Screen, please. Maybe we have too much wire up. Just show me a bit more the intrahepatic ducts, so just show that we just go more towards his head, please. Towards his head. Yeah. Just want to, I suspect I have too much wire in there. Screen, please. Yeah, maybe we'll just take some wire back.
tough position. Frank doesn't have a lot of manoeuvrability. He had the scope pretty much up to the hilt in the patient. He's just trying a short position now. But as you can see, it then gives us a very long, it takes us quite distant to the ampulla.
Do you guys think changing patient position, I know is a difficult patient, help in terms of...
Yeah, this is the only thing we can do.
Yeah.
We're just hoping, that's why we stayed put with the first cannulation, because it was so challenging. And as you can see, that wire's just gone south as well. But maybe that will help us. We'll just have one more. So we will have to then move him. I guess we know that we can see the stone. But I'm finding the 11 French definitely much thicker, no manoeuvrability, even in a very short position like that. I'm trying to get really close. Just hold my scope, just talk left there. Right, just trying to, yeah, you see I'm just trying to line it up like a stent. There we go. Very unstable.
So Frank, the papilla still have room for a bit more cut. Maybe actually once you cut, you probably your direction of the line actually might be a bit higher, and you don't have to bend.
Absolutely, absolutely right. So we'll try and, and with the first cannulation we got up with the 9 French IMAX, and that was fine. And I think. So let's do that. So can we have the balloon, the guide wire, and then we'll do a sphincterotomy. We'll just open that up.
Prefer a sphincterotomy or a sphincteroplasty at this stage?
Well, I think we've got either would be fine, because he's had a previous cut. I think
it does look like there's a
bit
of
sphincteroplasty will just give you more definitive measurement, isn't it, as to how much you've managed to dial it as opposed to a
balloon
second
with
cut.
the wire. Yep. Yeah, we can do that. So we'll go in with a balloon and we'll try and recannulate, and then we'll the duct side will probably, can we get a 10 to 12 CRE? Yeah. And we'll get ourselves a good amount of space that way.
So I don't think we showed you the cholangiogram image before, but the duct is mildly dilated. It's probably in the range of about 10 millimeters or so, and that's how Frank would have chosen his CRE balloon diameter.
Are you going to do freehand, or are you going to put a wire before?
I will go for a wire. I'm just getting that reloaded, and we'll just do exactly what we did before. We'll use you just had a extraction balloon with a guide wire initially. We'll just reuse that. So I think if we had a neutral position, much easier position, I think this would be academic in terms of getting it, your cholangioscope in the duct, but I think this is just a good example that that's not always straightforward to problem solve as you go. Okay, so there's our balloon. Let's see. And screener, please. Screening. Okay, the wire's up. We'll exchange. And we'll go for this sphincter CRE balloon. Yeah. Yeah, 10 to 12, please. We'll just see how that opens. Remember, okay, and exchange. Just a short balloon exchange. Great. There we go. Thank you. I've got the wire. I just remember we did an audit on all the patients that were referred for EHL with large stones, and of course the practice of balloon sphincteroplasty isn't that widely practiced, and some people are really concerned. And about a third of the patients, we actually just did a proper sphincteroplasty and the stones came out. So when you do have a retained stone, make sure that your exit opening is maximised and go to the size of the duct, and then you'll be able to extract a lot of the stones. I wouldn't go, my personal practice, I don't go above 18 millimetres because I start getting nervous about more perforation risk. Just straighten that out for me. Okay.
So Frank, another trick maybe if you can't get into a good position again this time, maybe turn the patient onto the left lateral. Just to allow the stomach to be decompressed and allow your scope to be in a shorter position if you're not success this time.
I'd like you to send me about 3 or 4 strong people to come and help, but we will do that very happily.
We will send Sandip down.
Okay,
so I think to Frank's prior point, we're quite trigger happy with cholangioscopy and EHL or laser lithotripsy now, but like Frank said, a lot of stones can actually come out with balloon sphincteroplasty or with mechanical basket lithotripsy. And the other thing is stones actually get smaller or they break up once they've had the stent sitting in them for a while. So when they're referred for additional therapy, often they come and their stones are smaller.
We'll just go slowly so we can get a little bit of distance.
I guess your problem is that it stones in a cystic gut, and none of that's going to impact this particular stone.
A little bit down, come down again.
I think in this case it's very difficult. You don't have room to use any other auxiliary except for the EHL. You need to fragment the stone, and then there is actually an ductal basket that we can use, but again, if you actually get a more impacted stone, you can't actually use that basket.
Is it 1? 3? So 3 millimetres is 10. We're just trying to get the balloon up. And again, the balloon position, even in this, is not, And 4.5. It's not as close as I would normally work from. Just come down again. Down, all the way down. Yep. That's better. Okay. I just wanted to get the balloon seated better. 3.
Can we have the X-ray image?
X-rays, please. And there we go. 4.5 again. I think that's fine. The duct size is fine, yeah? Okay, come down, all the way down. Right, so we'll so if you can just take that off here and just suck.
What do you think, Frank? Do you think that'll be enough to get your cholangioscope up there?
Yes, we will. I will try and get into a more neutral position. Screen, please, for me. This might have gone up the cystic duct, actually, because that wire doesn't look the same direction.
Maybe you've dislodged the stone.
There we go. I think that previous one was actually potentially in the cystic duct. But you wouldn't get anything else past it, so we're just doing the exchange here, yeah? There we go, one balloon's out. Just while we're changing to the scope, I've still got the scope mounted. I will try and see if I can reduce my scope. Pull back. X-rays, please. You can see this is the best position we can get. It's quite precarious, so but that might straighten it up and have one go. IMAX, yeah. Nice open loop.
So for the fellows in the room, the ideal ERCP position is from below the ampulla, so really you want your ampulla up at the 12 o'clock position. So this is straighter than before, but as you can see, our wire is still approaching from above, which is going to make instrument introduction quite difficult.
So Frank, are there any other tips and tricks for an 11 French thing to go through this duodenoscope, like wetting it? Or
We've got it. Yeah, I think we've got it wet. I mean, it's the first time I've used it. You'd always think 1 French is this very small amount, and maybe that shouldn't be such a big difference, but definitely I was feeling tighter.
Okay, just so check the screen. Just make sure there's no debris on the screen.
On the here, yeah, just clean the tip. Excellent, no fibers. Okay, we'll go down. More tension. Wire still going up. Yeah, it's good to stop. I'm actually using my right hand to just put more tension on the wire because it does feel like it's helping getting the scope down, which isn't. So we're using actually quite a lot of tension from the nursing. Screen, please. I want to see that I haven't got too much wire. X-rays. Just make sure that's... I'm seeing that... Okay, the moment of truth is about to arrive. I'm going to come through the... There we go. And as Linda said, we'll be very hard because we don't even have angulation on the scope either. And we are starting to lose position on that. Very hard. So yes, so we will have to do something differently. Still got a guide wire up. So I think I'm going to try the long position. And then we'll have to move him, I think. Trying to use the wheels on it to see if I can get to any kind of angulation that will help us.
I mean, sometimes with these stiff ones coming from a little bit further away can help, isn't it?
It's only just the pushability from this position. Is the you put any pressure, you can see you're going to get bowing. I'll put a bit of water on the, see if we can irrigate some water, if that's just open.
Wonder if we're just getting a view of the duct on your cholangioscope image there.
Screen please, just want to see the guide wire. Looks too much guide wire, that might, screening, that might prevent us from moving the scope.
Very close.
I think the EHL sounds like the easy bit.
I guess
Screen again.
A couple of things different. One is that, of course, changing the patient position. My second more controversial question would be, would you consider using a 10 French cholangioscope here?
Yes, so we can move to something else, and certainly maybe some of the tip angulation may be different. I've used the Boston spyglass more frequently.
Yeah, that's what I meant, without naming.
And
I think the logistical problem is there's no spy box in this room, so.
Right.
We do have spyglass. It's just in a different room, that's all. So we can actually urgently request actually to shift actually the unit to your room, Frank.
I think you did stitch me up.
None, you're really setting him up. Millen's been standing very quietly behind us. He was doing live cases last week. I'm sure he's very happy he's not doing this one.
No. I mean, the only thing sometimes is trying to adjust the wheels of the cholangioscope to give you that tiny bit of angle change.
Why is Milan smiling so much in the background?
Because I'm not doing this case.
I guess it just proves the point that we just need time, they never rush, different
Do you think
positions.
you've just popped in there? Or?
Lost
some connection issues there.
We might just. Oh, did it come back?
Wrong time for a Microtech ad there.
Okay.
I guess part of the challenge is that we're trying to stay really close to the ampulla, but that would negate the maneuverability of the tip. But it's an issue of just plain pushability. You would think that the guide wire and the sphincteroplasty would have given us enough space.
I guess it's an angle issue, isn't it?
It really is an angle issue. Screen, please. Okay. So that doesn't work, so we have to change something, right? The most difficult bit will be having to move him. I'm trying to do what Milan was saying, just trying to change the angulation, but we know that we have to get higher on this ampulla to actually get in. absolutely no pushability. Just hold my scope here, just left turn. Nope, let go.
So, Frank,
right, okay.
Nam is on his way to see or kind of organise if he can get a spy.
Okay, so what we'll do...
If you want to change the position of the patient...
Yeah, that's right.
Might also break for lunch, and while you're trying to sort out the position and maybe the other cholangioscope, we might, people are welcome to have lunch, and we'll shorten the lunch.
Here we go.
It was a 1 hour thing originally. Maybe we'll make it 40 minutes just to save those 20 minutes for the next session. And then Nam was supposed to do a talk, but he might just defer that to the first talk in the next session. Feel free to have some lunch, and we'll...
Do we have to move him to the other room to do that?
No, I think they can bring the box. They'll just need to disconnect it.
Okay, so let's optimize everything else. So we'll come out and we will get lots of people power to move him. We'll have to we'll have to try and turn him, even if we can get him left lateral. If we can get him left lateral.
Okay, welcome back after lunch. Just want to update you actually the last case. So once we change the positions, actually the scopes actually go right into a short position. It make a big difference. We did use the spyglass to visualize stone, get the introductory basket to grab the stone. But even then, we can't actually get the stones out. The stone's actually about 7 millimeter, but there's a tight stricture that actually we could not actually demonstrate to you prior. And even with a 10 millimeter balloon, there's still waste. So in fact, actually, we can't actually put the stones out, so we have to cut and do the emergency Sahendra crushing. So after that, yes, unfortunately, you miss all of the excitement actually during lunch. So anyway, we run a bit behind. So I suppose actually give a talk on mapping of pancreatico-biliary cancer. What I'm going to do is actually defer that talk actually to tomorrow, so that we can keep on schedule today. So let's go on to session number 3, and I invite Linda. Where's Linda? Oh, yes. Linda and Yu Ling to chair the 3rd session. Thanks.
Just me, I guess. So welcome back from lunch. So to start this session off, we'll have a talk, Sandeep, who requires no introduction. So he'll be talking to us on pancreatic fluid collection and walled-off necrosis, my best approach.
I thought it was NAM's.
Switch to laptop.
Is it? Yeah. Thank you. Good afternoon once again, and welcome back after the lunch. And this time I'll be talking on the pancreatic fluid collection and walled-off necrosis drainage, my best approach. So if you look at all the indications of EUS guided interventions, this is one indication which is taking almost 80 to 90% of all interventions. And that's why we need to learn it and do it. So as we all know that pancreatic fluid collections are classified as pseudocyst and walled-off necrosis based on the type of content they have. If it's pure fluid, it's pseudocyst. If it's fluid and some solid debris, it's called walled-off necrosis. The indications for draining is standard when any collection is infected or causing refractory abdominal pain, or it's critically blocking any of the structures, that is gastric outlet or a biliary obstruction or even esophageal obstructions, and if the patient is just not improving in spite of the best supportive care. So how many of you do it? Let me engage the audience now. Not the faculty. Or how many intend starting it soon? Because this is the first indication I am sure that you have to start off with if you start doing EUS interventions, and you need to learn it. So there are 2 types of drainage methods. One is using a metal stent. These are dedicated metal stents called LAMs or other large caliber metal stents. And then there are plastic stents which are considered in patients who have pure pseudocysts or pseudocysts with very minimal debris. which one to use when is also an area of interest by many. Linda, which one do you use? Always Axios?
I went through my training with LAMS.
Okay. So that's the way which most people are doing now. It's LAMS and LAMS. And the art of using plastic stent is slowly disappearing, but I feel it's very important. It's cost effective and actually clinically equally effective in certain conditions, and that's what we will discuss a little bit on that. So I'll start with plastic stent. That is how the history of pancreatic fluid collection drainage started with, and the method to do is the Seldinger technique. Those who do interventions, biliary interventions or percutaneous intervention or are associated with that would know that you pass a puncture at the duct which is obstructed or the collection which needs to be drained, pass a wire inside, and over the wire you dilate the path and then place the tube, drainage tube. So this Seldinger technique is the same method we also use by EUS guidance to place plastic stents. For metal stents, it can be a Seldinger or non-Seldinger technique, but before we consider any collection to be drained, these are few important caveats to be remembered. The collection should have a mature wall, which generally takes about 4 weeks, but sometimes it can mature early or even later. So it can be 3 weeks or it can be actually 6 weeks to take a mature collection to form. The content can be seen on EUS. You can also get this information by cross-sectional imaging. MRI is superior to CT. Then we need to know the dimensions, the wall thickness, and your endoscope position. Just like we saw the ERCP where it's long position, short position, because accessories take more difficulty in exiting from the scope in a long position. Obviously, EUS helps us in avoiding any blood vessels, interposing blood vessels to puncture. We saw it during liver biopsy that the blood vessel was there and there was some ooze in the tract, which is minor, but nevertheless, if we can avoid that major vessel to enter the cavity, then you avoid a major complication. And obviously, you can choose your best point of entry. So thinnest wall is the best, where the needle will come like this. So first thing is first, in the Seldinger technique, you puncture the collection with a needle. A 19 gauge needle is preferred. Then you aspirate some content which is going for analysis, and then you pass a guide wire inside, which has to be coiled well. And once it's coiled well, then you can dilate this path over the wire, which is the next step. Any of the 19 gauge needle can be used, and the guide wire is generally a long guide wire. An angle tip guide wire is preferred. And then the next step is dilating this path or creating a fistula between the stomach and the collection, which stomach is the usual route of entry. Occasionally duodenum or esophagus can be used depending on the location of the collection, and these can be dilated with the mechanical dilators, which can be your tapered cannula if the wall is very thin, or a bougie, stiffer bougies can be used, or even balloons. But more often we use electrocautery, which is a 6 French cystotome, which goes over the guide wire in the same path. And then we dilate this path with a balloon to allow the next accessory to come in. So there are several steps to it. The first step is puncture, aspirate, and guide wire. Second is creating this fistula. And the third is, this is a cystotome which is going inside, a cautery enhanced thing. And then the third step is to dilate this with a bigger balloon, which is, if the intent is to place plastic stents, 10, 12, or 15 millimeters, you can actually see the balloon on the EUS as well. And once you have the balloon inside and dilated well, then you pass the plastic stents. So if you are going through the stomach, then you use about 10 to 15 millimeter diameter balloons. But if you're going by esophagus, which one should be aware, then it should not dilate this much, you have to dilate it much lesser, otherwise you will cause mediastinitis and air in the mediastinum. And If the collection is large, then we often place multiple plastic stents, which requires multiple guide wires to be placed, and this has to be placed upfront before you start placing a plastic stent. So there are several devices which can take in more wires. You can choose whichever is available with you. And the last step is placing plastic stents, and these have to be a double pigtail plastic stent and not straight stent. The idea is that if you put a straight stent, it can sometimes be accidentally going inside the collection, which is then difficult to retrieve. These double pigtail stents have to be short, and the aim is to place in such a way that half the stent is inside the collection and half is in the stomach. So in this video, I'll just show that all the steps are combined together. This is a large collection, only a pseudocyst, see, punctured, wire passed, fistula is being created, balloon is to dilate. I'll just make it a little forward, and you have a big opening now, and then you place a large catheter so that it can take 2 wires. This is a 10 French catheter which goes over the first wire, and now you see 2 guide wires on the right side, and then the 2 stents are going one after the other into the collection. And that's the final position that you have of the 2 stents. So these are efficient for and very economic patients who deserve a plastic stent for a pseudocyst. Now the large caliber metal stents have been a game changer. There are 2 categories. These are LAMPs, or lumen opposing metal stent. As the name suggests, the 2 lumens are closely opposed to each other. But there are also another type of stents which are large caliber, but these are biflange metal stents, which are partially lumen opposing, but they don't adhere the 2 structures very close to each other. Among the most popular lamps is the hot Axios now, which has an inbuilt system. The same operator can do the entire thing, and you don't need an extra help in the room. It's a cautery enhanced system, so you burn your way in, and then by a stepwise method, there are 4 steps inbuilt in the system where you deploy the lamps. First the distal flange, then you pull back, lock the catheter, and then deploy the proximal flange, which can be delivered in the scope channel itself, or you can actually see endoscopically and deliver it. This is quite a user-friendly device after you learn the initial tricks of the trade. So let me show an example of this. This is a patient with large infected collection. He had sepsis symptoms, and you can see some debris below. Quite a significant amount of this is a solid debris. The top one is a fluid which is very echogenic, suggesting it is either infected collection or a very thick fluid. After avoiding the vessel, then we puncture using the cautery enhanced method. You see the tip is just peeping out, and we're finding that right window of opportunity by burning our way in. And once it goes deep inside, you have a good landing spot. Then you pull back your sheath using the second step and deploy the distal flange. Once it gets deployed well, then you again pull back the sheath more and deform the distal flange. Now it's deformed well, which means it is now anchored to the stomach now. And it looks like this on the X-ray if you want to see that. And then deploy the gastric end of the flange. You see the black mark which was just before. This is the black mark. The moment you see that, that's a time for deploying the proximal flange, and you can deploy either under endoscopic vision or directly inside the channel of the scope and push it out. And you see copious amount of pus coming out. This is how a stent would look like. And if you want to irrigate and do any more interventions, you can actually do it same session. This is the other type of stent, just for the exposure that there are several types of stents available. This is a Nagy stent. It's a biflange stent which has both cautery enhanced and non-cautery enhanced system. So they can be hot system, hot Spaxes, hot Nagy, and some other variants are available now. This is a cold one which has actually been placed, and we dilated a little bit of the balloon, the path, so that the assembly, which is 10.5 French, can then go in easily and then deploy. But here we need an assistant because he is deploying like a biliary metal stent. These stents are short, 2 centimeters to 3 centimeters long, And once they're placed well, the position looks like this. Endoscopically, you'll see a flower in the stomach, flower-like appearance. On X-ray, you can see that it's again a dumbbell-shaped. The thinnest point of this stent would be where the wall is, and sometimes you can also see a bow tie appearance on the EUS video. So unlike the lamps, the plastic stents require multiple sequential steps, that is puncture, fistula creation, tract dilation, and then placing more than guide wires. So it needs a synchronized team effort, and sometimes there's a risk of wire getting withdrawn, which can be disastrous, then you have to start all over again. During the placement of these stents, whichever we choose, there are several steps, as I mentioned, and you need endoscopy, fluoroscopy, and EUS vision at different time points. For example, in inspection, we only use EUS. For puncturing, we use EUS. For guide wire, we use both EUS and fluoroscopy. Cystotome, again, EUS is good enough. Balloon, you need fluoroscopy and endoscopy at times. And then finally, at the time of stent placement, we need definitely endoscopy and fluoroscopy, and often EUS as well. But whichever stent we place, whether it's LAMS or biflange other stents, or even a plastic, if it's pure fluid, they will all collapse, and within few days to few weeks, they will actually become disappeared, and just the stent would remain inside if they have purely fluid content. But if they have solid content, sometimes they take longer time to resolve, and that's why we need to do extra interventions. Occasionally, the collections are very big or more in number, and they may require multiple gateway drainage. Here, as you see, this is one area plastics, and another area, a large collection is still there. And after placing, you'll see one set here, one set here, and one set here. So this patient had a multiple gateway drainage, and also an additional tube for feeding purpose. That's a nasojejunal tube. And this would look endoscopically like this, if you see it later on at the time of removal. Another way of draining a collection which has multiple routes is called as combined drainage. The previous one was all endoscopically. Here we have used a percutaneous drainage. This patient had a large collection extending into the paracolic gutter where endoscopes can't reach. So first we place a percutaneous catheter under intervention radiology guidance. Once it is placed well, we keep it clamped, get the patient shifted to endoscopy room, and do an EUS guided drainage and put a metal stent there. And once that is placed successfully, then we open both the gates and allow the collection to drain from both sides. They may be communicating with each other also. And later you can do necrosectomy if you want. So when do we do necrosectomy is another question, and how do we do it? So direct endoscopic necrosectomy, as the name suggests, you take a forward viewing endoscope through these large caliber metal stents, go inside the cyst cavity, and try to remove the debris which may be infected using several instruments, which can be snare, Roth baskets, forceps, and so on and so forth. We conventionally practice a step-up approach, which is learned from our surgical colleagues, of index training, and then a few days or few weeks later, if this patient is symptomatic or continues to have new symptoms, or develops new symptoms, then we take an endoscope inside these stents, which have now expanded well, to take our instrument inside and do it. We reported a long time back using step-up approach using a Nagy stent, and we found that as we go from one step to the other, we find incremental benefit at each step. So the first step is generally these stents can get clogged with a loose debris, which is bigger than the size of the lumen of the stent, and these can be teased out or broken using a snare, and allows the stent lumen to get opened up. At the same session, if you want, you can peep inside the into the cavity and remove any more debris. Sometimes the debris is very adherent and not amenable for removal with endoscopy also. So we can place a nasocystic tube which goes inside the cyst cavity, and we can then irrigate externally using saline or saline with hydrogen peroxide. The third step, which can be done at any point of time, is necrosectomy, where we catch these debris. This is a stent clogged by a large chunk of tissue, of dead tissue, which has been removed. It was so large that it actually dragged out the stent out of its position. It's in the stomach now, which we can remove it at the same session, and then go inside the cyst cavity through the large opening which is there, peep inside and inspect it well and clean up whatever is left behind. So advantage of these large caliber metal stents, including LAMs, is that they are very easy to deploy and hence provide a high technical success. They are large diameter, so provide a very efficient drainage. They are fully covered, so prevent any leak and perforation. Since they are self-expandable, they prevent any bleed from the entry site. And the design is saddle or biflange shape, which prevents any migration. And also we can re-intervene whenever we need to do that through the stent, like direct necrosectomy. But sometimes they have also disadvantages. There can be malposition of the stent, which they're expensive stents, and then you have to either do it all over again, but by the time you have intervened, some of the fluid would go away, and that may also pose a challenge in the next session of drainage. Bleeding has been reported to occur from the inside the cyst cavity, and that's mainly because some of the LAMs have a very firm inner edge which can hit on the back wall of the cyst, and as the cyst collapses over the stent edge, it can cause bleeding. Larger vessels like splenic artery and vein are just behind on the posterior wall of the cyst cavity. Spontaneous migration has also been reported, especially with biflange stent. LAMs often don't migrate spontaneously, but yes, they can. And they can also be a hindrance to necrosectomy. For example, if the collection is reduced in size, but the debris is still there, and it can be all around the inner flange, and there you can't reach because the cyst cavity is reduced in size. So sometimes you have to pull out the LAMs and then do necrosectomy. There are some new instruments which have been available now to break thick, hard debris, and this is an endorotor, which is like a rotor which is used by the vascular surgeons to, like an atheroma. This burns, this kind of scrapes the surface. It's like a motor running around. The only caution is that you should not go very deep in, because there can be big vessels below, and that can also get scraped off, and massive bleedings have been reported. So just scrape the surface and keep looking intermittently to the deeper aspect. Another device is called as excavator from Ovesco, which is a cap-like device loaded at the tip of the forward wing endoscope, which can be controlled externally by opening and closing it. I'll skip this video and go to the next one. This is a loaded endoscope with the excavator at the tip, which is transparent hood. And since it is a little conical, just like we saw the conical spicholangioscope part today, that this hood can take you inside the cavity, and then you can open it like a big flange and then grasp the loose debris and keep pulling them out into the stomach. So they are only useful when the stent has fully expanded. They can't go through an unexpanded stent, because the natural expansion takes 2 to 3 days in most of these stents that we use. So that's where the role of direct necrosectomy at the index drainage is now coming up. And the recent trials have compared primary endoscopic necrosectomy versus step-up approach. In primary, since the stent is not expanded, you have to dilate the stent with a balloon at the index drainage. We were part of this first trial of upfront necrosectomy versus step-up approach. This was mainly US centers and one center from India, that was ours. And this showed that it is possible to do in fully encapsulated collections. It reduces the number of necrosectomy required and reduces the hospital stay, which gives the economic benefit overall. How is it done? This is the lamps being placed that we just saw in a similar case before. It has to be a 15 or a 20 millimeter lamps. The lamps is cannulated with a guide wire, and then over the guide wire you pass a CRE balloon to dilate it to its size. We often use a 12 to 15 millimeter balloon so that the regular endoscope can then go through it. The idea is to take a regular endoscope, forward wing endoscope, into it. So this is a balloon which is dilating the catheter, dilating the lamps. And then this is a primary endoscopic necrosectomy being done. You see a debris inside, you can peep in, go deep inside the cyst cavity, irrigate. So it should have a water pump facility available with it. But since it is a freshly placed lamp, sometimes the areas can be more raw and bleeding can occur, unlike a step-up approach where you do it later, where most of the loose debris would spontaneously flow out. If not, you can always remove it. There have been recent publications on this front, and there are 4 trials, randomized controlled trial on primary endoscopic necrosectomy versus step-up approach, and 3 of these ones, the Destin trial, the Wonder trial from Japan, and Accelerate trial from the European Center, showed that primary DEN is superior and better. Another RCT which came in recent CGH showed that there is no superiority of immediate DEN versus a step-up approach. So the jury is still out, and we will probably know as with passage of time which are the ones to be considered for primary endoscopic necrosectomy at time of drainage of the stent. Sometimes there can be unplanned events which can occur at the time of drainage. Let me show you a few examples. This was a patient who underwent an Nagy stent placement, which is a biflange, and during that process we saw a gush of blood going inside the cyst cavity. There was a bleed from the surface vessel into the cyst cavity. So the original plan was to put a plastic stent, but the moment we saw this, we immediately changed our plan and placed a metal stent, which by the force of its expansion caused the tamponade of the bleeding vessel from the surface. So you can change your plan. Either a Axios or any kind of a stent which is self-expandable would have helped in this situation. There's also a situation where you can have a candy sign where you place the stent, but the stent is inside the cyst cavity, and also if you see it here, this is how the stent looked like, which it should not be. There should be waste in the center and not at the 2 edges. And this tells us that the stent is malpositioned. This is the pancreatic fluid collection, and that's the stomach wall. So we have a potential space in which part of the length of the stent is opened up. And this creates a risk of migration either internally or externally into the cyst cavity or externally into the stomach. And that can be prevented by putting a double pigtail plastic stent for that, which can just anchor it for a while. And if it goes inside, then also you can retrieve it. But if it's detected at the time of index procedure, your guide wire would be a lifeline, and you can place a plastic or a second metal stent and come out and retrieve the internally migrated stent later on. We can also salvage these stents if they have migrated later on by going through the fistulous opening in the stomach, dilate that path. In this case, there was a metal stent which had gone inside. So here we have dilated the fistulous opening, and as soon as we dilate, we can see with the forward wing endoscope the internal metal stent, which is now grasped with the forceps, and if you're lucky enough, you can actually reposition it back where you want it to be. Very rarely, if the collection is huge, the stent can actually go almost to the pelvis. This happened in this case, where it was a huge collection, so we immediately realized that the stent had gone in, and we placed another metal stent at this point. So there was one in the stomach and the cyst, and the one which had migrated inside. Few days later, when the patient became better, we took a forward wing endoscope through the first stent, going deep down towards the pelvis, grasped one, and then pulled it out. So you can use various permutations and combination and select which one works best for the patient. So these are the example of the same patient where you can, but I will just stop it here and just sum it up by saying that draining pancreatic fluid collection by EUS is now the standard of care, and metal stents are generally preferred for patients who have walled-off necrosis with significant debris. Plastic stents are still preferred, at least in some areas, and we do it often in patients who have pure pseudocysts or pseudocysts with minimal debris, keeping cost in mind. All the metal stents, whenever they're placed, have to be removed in a finite period, less than 4 weeks. They should not be left permanently or should never be forgotten, unlike plastic stent, which can sometimes be forgotten and can be intentionally left lifelong. Reintervention, like necrosectomy, is based generally on the symptoms of the patient. For example, if the patient develops fever or new onset pain and all so on and so forth, or non-resolving collection, in that case we can do a direct endoscopic necrosectomy. Thank you very much for your kind attention.
Thanks so much, Sundeep. An excellent talk again, as always. So there's been a slight change to the schedule, so we will go to another talk, but we've just swapped the order of the talks a little bit. So we've got Frank now, who is working very hard in the morning and through lunch while everyone was eating. So Frank is the Associate Professor at the New Zealand Graduate School of Medicine, University of Waikato, Hamilton, gastroenterologist at Waikato Hospital and the clinical lead for endoscopy. And he's here this afternoon to talk to us about pancreatitis without alcohol and gallstones. What should I do now?
Seems to be logged off. Who's putting up the slides? Oh, did you have a house? Okay.
So while we get this set up, does anyone have any questions for Sundeep?
Thank you. Sorry. That's all good. My patient's is getting a liver transplant though. That's exciting. Is yours USB or on here?
That one. Second. And click advance to click.
Click to advance, or you can click these. Okay. Yeah. Okay, thank you.
In that case, you want to loosen it up. It also works like a disinfectant agent also. So we use 3% hydrogen peroxide, and that's a small amount of volume is used, not very large volume. And we only use in patients who have a persistent infection and very thick debris. Not in all cases. If it's a loose debris, then we just irrigate with saline and it will come out.
Right, good. Thank you to Naam and the organisers for letting me do some talks as well, and the patient as well, the last patient, all went well. In fact, the patient actually had a distal stricture, and that was all the problem. So once we did a balloon, we actually did a balloon to try and open it up to get the stone out, and there was more drama. Anyway, I'm going to talk about non-alcohol, non-biliary acute pancreatitis, previously called idiopathic pancreatitis. But most patients with pancreatitis do have an identifiable cause, and so that terminology is maybe outdated. Most of it is still alcohol, smoking, and gallstones. So most of the cases are actually quite easy to identify. Of those patients with non-alcohol, non-biliary acute pancreatitis, that's about 30 or 40% of cases. And I'll touch on post-ERCP, autoimmune pancreatitis, hereditary pancreatitis, and some infections and vaccines, because those are sort of more topical. Some of the most rarer cases we won't go in more detail. It's important for these patients that come back more than once usually to have a very structured way to work through your history and examination, and then work through your cross-sectional imaging before we get into anything like EOS or genetic testing. So the management for these patients, alcohol biliary disease is still the most common cause for idiopathic pancreatitis, not to be forgotten. And a cholecystectomy in these patients does reduce the recurrence. So even in those with normal appearing gallbladders, you need to treat 5 patients to prevent one attack,
and that's why the surgeons are still very keen to take out gallbladders even if they look normal, because the recurrence rate is only 10% after cholecystectomy compared to 40% without surgery. Genetic testing we can touch later, but if a patient has multiple family members, you start thinking laterally of what's going on, and of course if they turn up really soon, early in life. So post-ERCP pancreatitis is what we fear. It's a sort of very common and serious complication. It occurs in about 4 to 5% in total. More frequent of first-time patients. Most cases are mild, but we all have memory of patients that have become really, really unwell, and severe pancreatitis is a severe illness and can result in pancreatic necrosis, as we saw in the previous talk, organ failure and death, and we mustn't forget that particularly when we're asked to do unnecessary procedures, we have to remind ourselves of these facts. There are some procedural risk factors for these patients, those that are younger, especially those that are under 40, prior acute pancreatitis, prior post-ERCP pancreatitis, and those patients with SOD, female gender. And importantly, actually, not to be underestimated, it's actually a patient with asymptomatic common bile stones, especially the elderly, they do have an increased risk, and sometimes we actually don't have to do procedures, and we need to be mindful that our procedures can cause as much harm as they could do good for these patients. Procedurally related, anything touching the pancreas, so any first native papilla, any dilatation, any guide wire, any injection with contrast, all of those things immediately increase your risk. So in other words, if you do an ERCP, the risk is increased, so the nature of the procedure increases it. And then there's those patients that have difficult cannulations or sphincterotomies, and the risk for pre-cut is said to be increased, but in fact, if you look at the overall risk, if you do a pre-cut really early, actually the risk isn't that high. It's really prolonged cannulation that is the issue. So how do we prevent it? Rectal NSAIDs are really standard of care. In our unit, everybody gets rectal NSAIDs unless they opt out, unless they have a specific contraindication such as anaphylaxis or reduced EGFR below 30. The risk is reduced by at least 50%. And you should have some sort of system to that these patients get this treatment, because it is helpful. In systematic reviews, though, only 1/3 of patients actually are administered. Sometimes there's a concern of further complications because of this NSAIDs, but if you look at the early studies from the New England Journal, actually GI bleeding and renal failure is actually less in those patients that have rectal NSAIDs. I like periprocedural hydration, and we use Ringer's lactate or Hartmann's or CSL. We use 3 milliliters per kilogram per hour. For 4 to 6 hours, we do an amylase at that point. The patient hasn't got any pain, then you can stop. But if they do have pain, then you can prolong your infusions. But aggressive post-ERCP hydration may not give additional benefit to rectal NSAIDs, so I think it's an important adjunct. I use both in my own practice. Pancreatic duct stenting, it is recommended for those high-risk patients, and it does reduce the post-ERCP pancreatitis, and that's why it's a good practice to do this. And patients that I would consider high risk are sphincter artery dysfunction, ampulectomy, difficult cannulation. When you use double wire, you now have a wire in the pancreas, as pancreatic sphincterotomy or endotherapy. So those patients, I think it's almost mandatory. But stent placement isn't always technically feasible, so I wouldn't pursue it just to get a pancreatic stent in. I think if you get first time into the biliary tree and you have an otherwise clean, quick procedure, it may actually give you more risk by pursuing just a pancreatic stent. And then the last point on this slide is just let's avoid ERCP if we can. Let's use EOS. I use that very frequently in stone disease to try and avoid ERCP, to see if the stone is passed and you can avoid a procedure. And as I mentioned before, in the elderly population with asymptomatic stones, they don't necessarily need an ERCP. Autoimmune pancreatitis is another topical disease. The more we look for it, the more we see it. Those patients present with obstructive jaundice and they have an excellent response to steroids. But there are actually two demographic subtypes. The type 1 is the more common one. It's the IgG4 disease that we all look for. It's the more common form in older people with elevated IgG4 and extrapancreatic manifestations. We don't always get histology, but when we do, you look for this lymphoplastic sclerosing pancreatitis that's pathognomonic for these. Unfortunately, these patients have a higher relapse rate and they often require maintenance therapy. And they're different to the type 2 autoimmune pancreatitis, which is unrelated to IgG4. It's a younger cohort, it's sort of in the 30s and 40s, has a different histology, has excellent response and very low relapse rate on steroids, so often only need one course, and they have quite a strong association with IBD, and so and ulcerative colitis more than Crohn's disease, but that's a different. So we tend to see the type 1s, but the type 2s are different and they're just slightly different demographics. The sort of diagnostic approach to these patients, you use imaging, serology, histology, your clinical presentation. So you use all of those. You don't necessarily you're not necessarily committed to doing a biopsy because that carries risk as well. So if you have reasonable certainty on other features, then I think it's reasonable to treat these patients with steroids. But you can do EUS-guided biopsies and to get tissue for these patients, and there's some issues with that. But as it stands, be systematic. And this is actually really helpful for patients to know that they have this disease rather than something else. Sort of initial management for the type 1s. Corticosteroids are first-line treatment, 40 milligrams for a week, and then a taper. And you should see a dramatic response, and we usually image the patients about 4 weeks. It's fair to say that if they're asymptomatic and they don't have any other organ involvement, you might actually want to monitor them and not necessarily commit them to lifelong treatment. But these patients do have a higher relapse rate, and therefore maintenance is often required. And therefore, your options would be low-dose steroids or immunomodulators such as azathioprine, 6-mercaptopurine, mycophenolate. And I've been using rituximab increasingly as infusions. And you can use those for patients that can't tolerate the steroids or that have multiple relapses. So for older adults, which is the type 1s really, I haven't actually done this very much, so try to just do steroids because they're older, but in fact the literature tends to recommend that if we should think about using immunomodulators earlier in the piece. If they have their first relapse, try and use an immunomodulator. Remember, these patients have a good long-term survival, so they'll be around a long time. So you have to take a long-term view with their treatment. There is an increased risk of malignancies, but it's not as much as previously thought. Having said that, if you look at the imaging for autoimmune pancreatitis, it can look like anything. It can look like a mass, it can look like a sausage pancreas, it can look like a calcified pancreas. So on imaging, you don't always get the answer, and that's why histology does become important, especially if there's a focal lesion. It does have other autoimmune conditions associated with it, such as rheumatoid arthritis and Sjogren's, and of course other IgG4-related organ involvement. There's limited data on genetic susceptibility, except in the Japanese population, so there's more work to be done in this space. For those patients with hereditary pancreatitis, there's really two sort of groupings: the ion channel genes that produce ductal cells, and the digestive enzyme genes that produce the acinar cells. And so you have the CFTR, the genes, and then you've got PRSS1 and SFNC genes. Those are your main sort of inherited groupings. Why do we carry? So the autosome, the hereditary pattern is autosomal for the PRSS1 mutations, but you do have some heterozygous variants. And for the SFNC1 and the cystic fibrosis gene, it's autosomal recessive, so you need 2 genes to get full expression. And I've picked up quite a few of the cystic fibrosis ones in patients that nobody's looked before. So if somebody comes to you, even if they're older, because it does matter for the next generation. So why do we care? And the reason why we care is that the cancer risk is increased, specifically in this PRSS1 mutation, where it's 50 to 70-fold increased cancer risk, 7% by age of 70. And that sort of meets the threshold for screening. So a lot of these patients that have these genetic mutations confirmed will come into some sort of screening program. The risk is amplified by the usual risk factors of smoking, alcohol, and diabetes, and so these patients do need to avoid use of those other substances. And they do get pancreatic cancer at an earlier stage. So if you do screening, you have to start earlier. Unfortunately, they also get pain, and 70% of these patients do experience pain, and their different patterns is either intermittent severe, persistent, or chronic severe, and they have multiple pathways that signal, and these patients are often very difficult to manage, and unfortunately often require narcotic analgesics. Remember, they also get other abnormalities. They get pseudocysts, biliary strictures, duodenal strictures, and vascular thromboses. So they can be quite challenging. And when they're young, you have them for a long time. Some of these patients will get exocrine insufficiency, and you have to look for it. They don't thrive, and so you have to chase down these patients that tend to be chronic management issues. They're also, a quarter of them end up becoming diabetic by mid-adulthood. And again, I just wanted to loop back to the substances, alcohol and tobacco. Smoking doubles the risk. Smoking and alcohol makes the risk 8-fold, and smoking doubles that pancreatic cancer risk. So these patients have to be counselled very carefully. They often, start turning up in our clinic in adolescence, and it's quite hard to counsel these patients when they want to do the things their friends do. Just a little bit on drug-induced pancreatitis. It's only less than 5% of the total. Lots of different medications have been sort of linked and implicated. The most common ones, though, are actually in our IBD colleagues use this, azathioprine, 6-mercaptopurine, and mesalazine. So those are some of the ones that we do see. Lots of other drugs that have been associated. So if somebody does go down the pathway of having this recurrent acute pancreatitis and you can't find something else, don't forget to look at medications. Just 2 more slides, so a couple more slides on infectious causes, mostly viral. It's actually quite rare, but mostly viral hepatitis accounts for at least 1/3 of those, and then there's a smidgen of sort of a whole lot of different viruses. Unfortunately, viral pancreatitis does have a higher mortality, so if they do get this, and especially if they're immunocompromised, they can get quite sick and they can have a poor outcome. It's quite rare, but if that does occur, just be mindful. There's not much we can do other than supportive care, and because they're rare, there's really no systematic advice. What's more common is infective necrosis, which we saw in the previous talk, and how to deal with that, and it's a very severe disease that needs multidisciplinary input. And last but not least, COVID vaccine. So we have had a couple of cases which we've written up after the vaccine. These patients have, sorry, I'll go back. Maybe it's telling me to stop. So the spike protein may bind to the receptors, and the other vaccines have different mechanisms such as replication of the actual virus or molecular mimicry. So again, quite rare causes, individual sort of case series, but they do occur. And these patients are grateful that you take them seriously when it does occur. So that's me. This is Waikato Hospital where I work, and be happy to host anybody that wants to come and visit. Thank you.
Thanks very much for that talk, Frank. So it looks like they're ready for us in the next room for the next live case. We'll just get the case presentation first. Thank you.
Our next case is a 38-year-old lady with a history of recurrent alcohol-induced pancreatitis, previously complicated by a pseudocyst requiring EUS drainage. She's had a cholecystectomy for cholecystitis, and she is an active smoker with ongoing alcohol use. She presented after the recent birth of her 7th child, and had a CTPA that found a large pancreatic lesion that was increasing in size. She was relatively asymptomatic from this. Her lipase was normal, her CRP was 4, her CA19-9 was 22, and her CEA was normal. And the MR abdomen showed a quite large complex cystic mass in the pancreatic tail, measuring about 14 centimetres, with internal enhancing septations, typical of a standard pancreatic pseudocyst, but of a mucinous cystadenoma. So she'll progress now to EUS and FNA with consideration of a LAMS over to text week 4.
Can you hear us?
Yep, can we get the EUS screen bigger?
So who's actually...
Can you see the EUS screen now? That's on big for us.
We can.
Yeah, fantastic.
So we got Linda chairing, is that right?
Yeah.
Linda and
I'm
Yuling?
here and Yuling is here.
Okay. So it's a really unusual case because this is a lady with a significant alcohol history with a previous pseudocyst. So by the way, I'm here with Andy, and has a big collection that has been discussed at our MDT with the conclusion that this may be an MCM, which is the reason why we're having a look. It was actually challenging to have a look at the pancreas, and I think I've sort of shown you these very heterogeneous areas. What do you think, Andy?
Yeah,
we were having a look at this
absolutely.
area.
I think one of the reasons it's challenging is it's probably quite atrophic, so the anatomy wasn't all in the right spaces. But if we're coming back to, and I know it was mentioned earlier today in one of the talks about Rosemont criteria, it's not a normal-looking pancreas, is it?
Yeah, it's got hyperechoic areas.
Yeah, so we've got non-shadowing hyperechoic foci, and we've got some cystic spaces that we've seen. Duct itself, not too bad, and there's a whole lot of lymph nodes around as well.
There's some inflammatory lymph nodes. So there are these, if I put the arrow here, so there are these areas here which I think are small cysts. What do you think, Andy?
I agree. So we were worried about varices as well. Because just when you first looked at it, it just felt like it was that.
William and Andy, it's really nice to see you, but could we remove the room image so we can see the pancreatic cyst?
Oh, yeah. You don't want to look at us anymore?
I get the message.
We've just done our hair and everything.
Can I ask a little bit more? It's a bit unusual that such a large mucinous lesion would have developed in someone who's had a previous pancreatic pseudocyst. So when was the last...
abdominal.
I think that's
we
the
agree with that,
discussion.
and that's what Will and I have just been talking about. So, one, the lady's a drinker. Two, she's got an abnormal-looking pancreas. Three, she's had a previous pseudocyst before. So this was going to be a discussion around MCM versus pseudocyst, and we'll still talk about that. But the ability of an MCN to get to 14 centimetres and not be malignant, I think is very, very small. And, I mean, you can actually see the ecotexture of this lesion now, and it really does have most of the features that we would think about for a pseudocyst. I mean...
So these are the
If we're going back to the original cyst talk from Milan, yes, she's a woman, yes, she's middle-aged, yes, it's in the tail, but anything over 4 centimetres in size with a mucinous cystadenoma,
Yuling, do you agree with that statement? Yuling?
Yes, certainly. In an MCM this big, we didn't really have a good look at the whole series of the MR, but the shot that we got looks like a really big
Let's have a look at
cystic lesion.
Yeah, have a look at the wall of this cyst over here, which has got lots of little cystic areas.
But if you look at the ecotexture, I mean, that's really pseudocyst-like, isn't it? There's echogenics
here.
Yeah, I would agree that, I mean, based on what information we have, it's most likely a pseudocyst rather than such
But
a large
look at all these
MCM.
cysts.
Yeah.
But
we
look at all
will
these
still
cystic
have that
areas.
discussion. I think it is probably worth, just given that it's been raised before, and we don't want to stick a stent in a mucinous lesion, even though we think it's very low probability. We were talking about how to differentiate that before we do it, and one good way of doing it is putting a needle in. One, looking at the viscosity, so is it mucinous versus serous, but really now in this day and age, if I'm ever worried, is actually just getting fluid glucose. And we've got a glucometer around, so if there is any concern from pre-test probability that this is a mucinous lesion that we wouldn't want to stent, well then we can just do a glucose on it. If it's less than 2.8, we would have to really think about things. But everything that we're looking at in terms of history and EUS features really looks more pseudocyst-like. Wouldn't you agree?
Yep, I agree. So can we, do we have a glucometer?
So we'll get an FNA needle, but we'll get a glucometer as well.
Can
so
I have
like
the
a BSL machine?
So we're using the Easy Shot Disc 19. What do you think about all these areas there? This is, with the side hole. What do you think of all these areas here?
Yeah, so the first thought when we just rushed over it was, could there be varices here? But actually that's sort of, it's echoes within the main capsule of the cystic lesion. So it's sort of a loculated pseudocyst, isn't it? So
does it worry you?
No, I don't necessarily think so. I mean, we've got a lady with a probable chronic pancreatitis based on Rosemont criteria, ongoing drinking, and a 14 centimetre lesion. I think the likelihood of this being anything other than the pseudocyst is low, but let's check the glucose. So the MDM said mucinous. We'll check it. Yeah, so the pancreas is abnormal. Echogenic foci, lobularity, non-honeycomb, and cystic spaces. And quite atrophic, which is why we had a little bit of trouble finding it. You can actually see the bulge. Did you guys see the stomach before we started?
I'll show you the stomach here. So she's a short lady. Even with my scope at 40, we're actually in the body of the stomach.
And this lady's intubated, which is the only time I'm really happy for patients to be intubated in endoscopy.
Did you say that you were concerned about varices earlier?
Yes, we were, but I think you can see on the Doppler, I'll give you back this, there's no...
Yeah, and when we ran over it, it did have that feel, didn't it, where you sort of...
Yes, it does. All right, so I think what we might do is just see whether we can just get a bit of fluid. Full suction.
It is odd looking.
Wait. Not punctured yet.
That's a nice approach there. So we're at 40 centimetres, but the lady's quite short, so we are right in the body.
Okay, take it up and we'll...
Yeah, so we'll grab a syringe and run full suction. And we've got the BSL machine.
Full suction,
So the two things we can look for without waiting for cytology, the viscosity or the string sign, as well as the BSL.
So, actually, it's brown, but it's actually quite viscous.
I think this is pseudocyst already, isn't it?
I think the colour, can you zoom in on the colour here? So the colour is actually consistent. I think this is a pseudocyst.
Yeah, agreed. But just to make us all happy, we've got a glucometer at the ready.
We've got a glucometer.
So can you just explain what level of glucose you'll be worried about?
So anything less than 2.8, which is 50, so 2.8 millimoles per litre. And it's supposedly more accurate than the old less than 5 and greater than 198 of the CEA. And the other nice thing is it's cheap and we can do it right now.
Okay, you can just
so, I mean, can you guys see the colour of the fluid?
Yes, it does look quite brown.
I think this is consistent. So if we're happy, we'll put an Axios. Any thoughts on the panel?
Are you thinking of putting in here?
So we were previously, for this, there's not much necrosum in this. It looks predominantly fluid-like. And after that fantastic talk before, we were wondering, should this be one that we do double pigtail or should this be Axios stent? The evidence is still not strong outside of, there's equivalence outside of cost. My own feeling, based on not really much evidence, is that I usually now for everything just put in an Axios and then put a double pigtail inside it, and if there's disconnected duct or I want to leave it in, you can just pull the Axios over the top and leave the plastic stent in. There's a little bit of a move back towards plastic stents from a cost perspective, but when you've got 8 cases on your list, I find that it's more straightforward.
Patient padded?
I think this one looks like it contains quite a lot of infected material. Even if it's not solid material, I'd be more inclined to put a LAMS. I don't know I'm getting lots of nods, so agree with LAMS.
No, we're all happy with the LAMS as well. So we've just got a sugar on this for now. It was quite serous, did you think, Nam? Yeah.
You're not worried about the rest of the cysts and throughout the pancreas? You think it's all just part of this one lesion?
Sorry, miss, did you hear that?
Say that again, Linda.
So Vipul's just asking if you're worried about the smaller cysts and the rest of the pancreas.
I am actually. I am worried about the smaller cysts. That is something that it's not a clean rim around the cyst. I am worried about those cysts. What do you think? I've found an area where there's relatively few cysts in this area as opposed to the other areas where you can see them. So what do you think here? So if we go through here, we might be able to get an area that is relatively free of those little cysts. Come around.
We're also, it's such a large lesion, we're unable to see the lesion in its entirety, are we?
So we can see the lesion there, but we have been sort of looking for ideal areas to put the... Looks.
Okay. So what was the feeling on the panel about these cystic spaces and almost daughter cysts?
So were you able to hear the comments by Sundeep and Vipul at all?
Barely, actually.
Yeah.
So Sundeep was just saying if you put a metal stent into it, you could go in a few days and inspect the cyst from the inside.
Yes, certainly.
And Vipul was saying, would you consider separately biopsying one of the cystic lesions?
I don't feel strongly about biopsying the cystic lesions because I think they're likely to be small pseudocysts. If we're thinking this is a large pseudocyst, Although I agree with you, the fluid inside those cystic areas are a little bit different, aren't they?
It's sort of loculated in a way, isn't it? Or
They are very unusual.
I like the idea of going into this again. I mean, normally you wouldn't because there's not a lot of solid necrosum.
Yeah.
But I think that's a good idea. It's an odd-looking thing. But when you think about the case, it's a lady with recurrent alcoholic pancreatitis, previous pseudocyst, chronic changes. I think we're pretty confident now with the way this looks, and the sugar, the BSL soon, the glucose still to come soon.
Yeah.
I think where you are now, it really just looks like a loculation as opposed to a separate cystic structure. So I'd be happy to puncture where you are now.
Yes, yeah. The reason we're waiting is we're waiting for the glucose reading. Not working, so we can just go ahead and do it. Yeah. We'll go ahead. Can I have the?
We should have prepared one earlier.
Can I please have the Axios? 10. Happy with a settle length of 10. Andy, do you want to talk about the settle length? I'm pretty happy that 10 settle length will be all right for this.
Yes. And then you got what size, what diameter Axios you're thinking about as well, Will? Particularly if we may go into it.
Looking, I think a 10 would be sufficient. 10.
And Frank made the interesting. Yeah, look, I would agree. I would actually think 15 as well. There's a question about it looks just the way it looks, and the fact that we may need to go in, proper scope in the next few weeks. Yeah, I think. Is there? Have you got a 15? Have you got a 10 and 15? Yeah, perfect. So Frank made the interesting point as well that often if there's a bleed, that the blood can just loculate in corners of the cyst. But I think if it doesn't look completely normal, does it, Frank? So I think the idea of inspecting it's not a bad one. So we're going to select a 10-15.
Just to interrupt, can you guys hear us from the panel?
Yes.
Can you hear me?
Yes.
Oh, okay. So we've had a request from Krish to check around for any pseudoaneurysms, and then a question from the audience to ask if you're sending your specimen off for formal testing.
So pseudoaneurysm is a very good thought. And we have already got a sample, yes.
Do you want me to have a look around before?
No. I'm pretty happy we've inspected.
Yeah. Okay.
Why did you choose the 15 saddle length? Sorry, I might have missed your measurement.
So I think I'll get you to talk while I do this.
No. This is a 10-15, isn't it? It's a 10-15.
Can you hold that scope there? Yeah, that's a good area. Hold it, one. Just trying to lock it in. Good. Just making sure one last time that.
So we're in a good position in the stomach. We've got a good access if we need. You could almost drive straight into it if we needed to use a gastroscope in the future. Stable position. A lot of checking for vasculature, given we thought there may have been varices, so we're happy.
There's one particular vessel here. I've unlocked it. Hold it like that. Are we connected? Connected. We haven't connected, so I think there's a couple of steps that we always need to check when we're doing this, isn't it? So make sure it's connected, make sure it's in a good position.
And you're on the hot Axios setting.
We're on the hot Axios. Are we on the hot Axios setting? Okay. So if everyone's happy, and that is unlocked. So we're in.
Are you in?
And your view might be a bit better if you take the Doppler off.
Yeah.
Yeah, it's such a big...
Yeah, so where's the end of your... Just push now. Is that the end of your...
Yeah.
There.
Just hold it there for me.
Yeah, that's better.
Okay. So I think it's a good... It's a big...
It's a big cyst. You've got
It's
no
a
problem
big
with
cyst.
space here. Yeah.
I just take that off. So we can take the setting off too. Yeah. Oh, sorry. You can take this off. Thank you. Yep.
Okay.
So happy that that is sort of opposed. So this is an important step, isn't it?
I
Andy?
almost
To try
like
and
to tense it up a little bit more.
William and
Because you
Andy,
really want to make sure.
Do you ever do this with a guide wire in?
Yeah, I guess that's a good point because we're going to put in there, so we can actually put in the guide wire in. So should we do that? Can I have a 035 Jaguar?
So you can see that's tented up now.
I think that's a good point because I actually just cannulate, but if we're not sure, and I'm not really sure why we're not seeing this side of the screen at the moment.
So I usually, maybe because I'm quite risk averse, I usually like to pass the guide wire halfway down the catheter. And
Yeah, before you puncture.
9 times out of
For every
10,
Axios?
I don't end up using it, but then it just helps me if I can't quite work out my views. It does look like you're in, but it almost looks like it's
0.35.
tenting on something.
Are you happy we're deeply in there?
Do you,
It's just this area that.
are you happy the flange opened fully before we're drawing?
Well, that's what we're just talking about now.
Can unlock it.
Do you want to push it back on and just have a...
Because for some reason we're not seeing this area. For some reason we're not seeing that area very
You
well.
often do end up losing views once you've deployed one part of it, some of it from that metal artifact, and you're probably also getting some CO2 within the collection now that you've punctured it.
I think we will.
Yeah, look.
But I think
it
it looks like
reasonably
you're
confident.
Yeah,
I think
I think so.
I'm pretty confident I'm in.
Okay.
You can give the wire. Now this is a bit fiddly. You have to going through this little hole.
Look, I actually don't always put a wire in. If I'm going to put a double pigtail in the middle of it afterwards, which I always
You'll
do now,
cannulate,
I
yeah.
just
So I think we have a
freehand it
much
in,
better view
actually.
here. I think we have a much better view here. So don't worry if it's too difficult. Let's do it afterwards. So the next step is to so we're all locked. Then we deploy the second one, and nothing happens sort of this part. And then we can. This fourth step is the important that where we sort of.
Pull back in advance. Yeah.
So we have to do a
You got the
3-point
endoscopic view?
endoscopic view.
Can we move? Oh, that's you, isn't it?
Yeah.
So you can see the stent nicely there.
Yes.
Beautiful, you're seeing that fluid.
You're getting that fluid coming up.
Yeah, that looks lovely.
So this is the reason why the patient's intubated, isn't it?
Correct. We're very happy with the decision. But yeah, you can see that fluid pouring up beautifully now. Now, should we pop a pigtail in there?
Yeah. Can I have a balloon, please, with a guide wire? Yeah. Yeah. No, I think we'll just. We should be able to just go in with without dilating it. Guide wire. It's just a jag wire through there. Do you have a choice of technique for?
No, I just freehand it.
You're free-handed, yeah?
Yeah, put the wire through, grab a pusher or a balloon if I've used a balloon.
Five. Yeah.
So I think there's no doubt it's a ceasus now, is there?
So what about how do you follow her progress from here? When do you repeat imaging? When do you bring her back to
I think
remove
the
this?
suggestion, somebody suggested that we have a look fairly early on just to see the inside. I don't think that's really mandatory here because I think the diagnosis is pretty clear-cut.
She's got 7 kids. She may not stop drinking.
I hope you're not speaking from experience, Andrew.
So, William,
We're just waiting for the pigtail. Go ahead. I can hear you. Yuling?
when will you plan to remove this axios? Do you do a scan prior
I think
to
we heard from.
removing it
I think
to
we
make
heard.
sure that the pseudocyst has resolved?
So I think I'll scan. I'll scan in a couple of weeks, and we heard from Sandeep's excellent talk that you shouldn't really leave this more than 3 or 4 weeks.
I mean, the issue as well is if this is a recurrence, whether there's a disconnected duct, because she's had a previous axios.
She's had a previous axios.
So I guess
actually, no, it's actually quite a while ago.
Oh, okay.
So you can see I've got this thing, and I'm just going to freehand this. No, I'm going to get the balloon, so the balloon goes in. Yeah.
And can you explain why you are
So then I know that
placing
I'm not
a stent?
going through the wire. So go through the wire through the balloon. No, I need a balloon catheter. Balloon catheter. Yeah, just to go through there, just to make sure I'm in the right. Yeah.
Can you please
No.
explain to
You
the
said
audience
it's
why
under
you're
push?
placing a stent through the axios?
So I think it's common. Andy, do you want to, most people put in a double pigtail stent, right?
I missed the question.
So can you hear? So Yuling is asking why we need to put the double pigtail
Yeah, look,
stent.
I'm doing it relatively
Regularly.
frequently now, just so
Standard.
it doesn't block up. I've had a number of cases, mainly when there's more necrosum, where it blocks and they become febrile and you go in and there's necrosum sitting there. So I've just erred on the side of doing it more frequently than I used to.
And
the
the
other thing
other-
is the disconnected duct, and are we going to leave a pigtail in at the end? We'll probably end up looking back at the imaging, the MR. Because if this is the second time she's had a cyst in the same spot.
The
I
other
guess we need to
reason
think
is
about
if
that.
it compresses too quickly, it can cause abrasion against the sharper areas of the flange and cause bleeding.
May we get an EUS view?
Yep.
So I'm doing everything sort of endoscopically at the moment, Linda. So I'm going to try and sort of see if I can. There's a lot of fluid, so it makes visibility relatively challenging. So what I normally do is I get this balloon in, and through this wire, I'll put a 7 French compass stent. Okay. So, Andy, so this is where somebody, Linda, I think if you had this, so this is actually in the, and you can confirm that on EUS as well, but if you can get the, if you get the balloon in, you're not going to, okay, so, but if you can get the wire in here, then you can replace it with the, so now we're going to
With the stent?
leave the wire and then
Stents.
can you do the exchange? Yeah.
Yeah, so I
So I've got the wire through here. So this is where if Linda push this in. So if Linda had put this, so there's the wire. So now over this wire, I'll put down the. I've got it locked down.
Yeah, so I routinely put a double pigtail stent through all
Yeah.
of my lambs, and so it is good having that wire in because then you're just ready to go with the stent straight away. But I do that with the wire for anything, EUS, GJs, biliary
Yes,
drainage
and you
just
put the
for
wire
my
beforehand,
backup
yeah?
access.
Yeah, and you put that during, you do that through the lamps, right? Okay, now we have the compass stent. Yeah, compass stent.
Now, do we know if this lady has exocrine insufficiency? We found very little pancreas, didn't we?
Tracy or Pat, do you know the answer? I'm not sure.
So the pancreas didn't extend far beyond the kidney when we were looking for this.
Okay, can we push with the balloon? Hold the wire, please. Can I have the... You can push. Yeah. Yeah, you can do that.
So usually for something like this, which looks like it has decompressed really quickly, I would do a CT in about 2 weeks' time, and then bring
2
them
weeks,
back
yeah.
at
2
about
weeks.
4 weeks.
And
Would you do
probably,
something similar? Or?
yeah, I would scan in 2 weeks, and maybe remove the stent a week after if that was all good. So hold the wire, please. Watch the screen. Hold the wire. Watch the screen. Hold the wire. Watch the screen. Yeah, no. Just keep it steady. Keep it steady. Pull the wire, please. Yeah, that's it. Yeah, it's just to prevent the wire going. It's going in, so you need to pull on the wire. Yeah, that's it. We've got too much wire. Yeah, we want to put the stent, right? So pull the wire back. Yeah, there you go. Yeah, that's it. Pull on the wire, please. Pull on the wire. Keep going. That's right. So what we're doing now is we're just deploying. Pull on the wire, please, so it doesn't move. Yeah, match my movement. Pull. Thank you. Keep going. Yeah, keep going. Yeah. Okay. Stop pulling. Stop pulling. So this is the first. Second.
Was that a 5 centimetre stent, a 7 French 5?
5 centimeter compass. Yeah, 5 centimeter. Okay, pull out complete.
Just pull it. Yeah, pull it.
Pull it. There you go. So that will secure. That will take a photo of this.
And you wanted to see the US image again, is that right?
Krish really wants to see how it has collapsed.
Yep.
Yeah, sure. What I so there's the cyst is still there, Chris.
Not seeing your EUS image.
Yeah.
We're only
you're
seeing
not seeing the
endoscopy.
EUS image? It has actually
It
become
shrunk quite
smaller.
significantly.
It has actually become. Can you show the EUS image, please?
Yeah, just PNP. We haven't
Oh,
got PNP.
sorry.
So that'll be on the stack. won't
Sorry.
it? Yeah.
So it's still there, but noting this is a 15 millimeter cyst. So
Wait, they're not seeing that, are they?
are you seeing this yet?
Can you see the PNP?
Yeah, now we are. Thank you.
Okay.
Yeah.
So it has marginally. So there's the cyst on here.
Do you use fluoroscopy?
And there's the cyst. No, we don't. Does anyone use fluoroscopy? I don't think you need to, do you?
Do you, Krish? Oh, did you ask that question?
I routinely don't use.
I've stopped using fluoroscopy.
Yeah, I don't. I've not used fluoroscopy for these cases. Does anyone use fluoroscopy? I think that's all we'll demonstrate here today. Is there anything else we want us to check?
No, that looks perfect. Thank you.
Okay, thank you.
Thanks very much. I think we're going to go to our next talk.
Thanks, guys.
I'd like to introduce Professor Vipul Agarwal, who's the Director of Gastroenterology and Hepatology at the Canberra Hospital. He's the chairman and an executive committee member of the endoscopy faculty within GISA. He also is very actively involved in teaching and training of gastroenterology advanced trainees and advanced endoscopy fellows at the Canberra Hospital. Thanks, Professor Agarwal, for your talk on pancreatic duct stricture and stone. How should I investigate and manage?
Well, thanks for that kind introduction. Some of those titles I've given up, but I guess that was sent a while ago. So I don't know if I picked the short end of the straw, but the topic that I've got is pancreatic duct strictures and stone, and how should I investigate and manage this. So we are on the almost close to end of day's play, so thank you for everyone who's hung around still. I don't have anything to declare in terms of conflicts of interest, but I just want to say that the data for this particular topic is very limited. There are very few randomized controlled trials. Data is mainly from retrospective studies with small numbers and meta-analyses. But there are a few guidelines. The ESG guidelines is in 2018, and then the ESG guidelines in 2020, and then there's an AGA best practice paper. All are based, as they accept, on low quality evidence. But they are very similar, and what I'll try to do is just incorporate them into the talk without specifically addressing each one of them, because they are quite similar. So when it comes to pancreatic duct strictures in particular, the first thing I want to do is make... Ooh, okay. It's very, very red, isn't it? I just realized that. It doesn't look that red on my screen, but this is okay. Sorry about that, in case it's blinding anyone else. Next time I'll provide glasses, and maybe laser glasses. So first thing I want to rule out is to exclude malignancy as an etiology. So there is malignancy, autoimmune causes, and then benign strictures. So certainly for the purpose of this talk, I'll focus on benign. But the initial workup, not surprisingly, involves history and physical examination, blood tests, and more importantly, the cross-sectional imaging. In terms of malignant strictures, we should always have an high index of suspicion, particularly in patients of 40 years of age with acute pancreatitis or exochronic pancreatic insufficiency. And this new diagnosis of chronic pancreatitis, a small proportion of them may have underlying pancreatic malignancy. So it's always good to be wary of those and make sure that we've done our due diligence to exclude malignancy. Frank's just given a great talk on autoimmune pancreatitis, and so I won't focus on that, but just important to point out, because investigation and treatment is quite different, therefore it is important to exclude these as a cause for your pancreatic ductal abnormalities before moving forward. But like I said, for the purpose of the talk today, is mainly on benign pancreatic ductal strictures. And the most common cause for these is chronic pancreatitis. Other causes may include trauma or iatrogenic causes such as placement of pancreatic ductal stents, instrumentation, or surgery. The main pathophysiology of these and the relevance around the dominant pancreatic duct obstruction resulting in symptoms or episodes of acute and chronic pancreatitis. It's important, I guess, that pancreatic duct strictures and stones are not completely different conditions, and they go hand in hand. There's quite a lot of overlap. One can cause the other. So part of the talk is sort of, we'll mix up between the two, because PD stones themselves can cause, strictures and further perpetuate the damage to the ducts. So chronic pancreatitis, again, I think there's a talk on chronic pancreatitis, but as far as strictures and stones are concerned, 50 to 80% of patients with chronic pancreatitis eventually develop pancreatic stones or strictures over a decade or so. And what's important is this ductal hypertension theory, which results in majority of the symptoms secondary to these strictures and stone, where they cause upstream pressure elevation leading to parenchymal ischemia, neurosensitization, and then intractable pain. The primary goal, therefore, of these is for ductal decompression for pain relief. The other potential benefit, which is somewhat controversial and not clearly demonstrated in prospective studies, is the so-called slowing of the functional decline in terms of preserving the exocrine as well as endocrine function with intervention with pancreatic duct obstruction, either from strictures or stones. So before we do anything else, I think it's important to, to localize the stricture in terms of its anatomy, which can impact how and which duct you're going to cannulate, and also what strategy that you might utilize for managing or treating these stones and strictures. As we know that there are certain anatomical locations such as the tail, which are going to be much more challenging to manage. So preempting that will help us decide how best we're going to approach this. So I guess the first step in that is the diagnostic mapping or using imaging. And once again, I don't think there's any imaging modality. I think they're mutually exclusive, but are complementary to each other. And if you're going to do a pancreatic endotherapy, then I like to have as much information as I can. CT, as per most of the guidelines, is the initial choice of cross-sectional imaging, is the gold standard, particularly for calcification and stones, but also for parenchymal masses, if there are masses. On the other hand, MRCP is probably the best test for delineating the ductal anatomy and abnormalities of strictures, dilatation, and certainly provides you the best roadmap for planning your endotherapy. As a keen endosonographer, I think US parts forms an important part of any investigation, diagnostic investigation, but certainly is very useful in these situations, particularly for radiolucent stones, but also other parenchymal change of chronic pancreatitis, and allows for tissue sampling if required. ERCP or pancreatoscopy, essentially not really that, they're primarily therapeutic modalities. I don't think you would use them for diagnosis. Very occasionally, maybe the pancreatoscopy for indeterminate pancreatic ductal strictures for biopsy, but generally speaking, they're more therapeutic. So do all pancreatic strictures and stones require treatment, or well, no? And I think it's important because we do, as interventional endoscopists, get a lot of referrals from either other gastros or other physicians where there may be an incidental finding of a pancreatic ductal stone. A typical referral is with that, with some parenchymal atrophy, and what are you going to do with those? So I guess at least I would only intervene in patients that are carefully selected and are symptomatic, and the benefits clearly outweigh any potential risks. And as mentioned before, like a good quality multiple imaging, and the majority of these, if you're going to do pancreatic endotherapy, again, should be in an MDT multidisciplinary team setting to get the best outcome for the patient. Management approaches would include medical therapy, endoscopic and surgical options. The medical therapy is primarily based on cessation of risk factors such as alcohol and smoking to prevent further damage. There's some data around pancreatic enzyme replacement, but it is limited, as is low-fat diet. Some role of pharmacological agents, primarily again for managing pain, but does not have any impact on the disease course. With regards to interventions, ERCP still remains a mainstay for pancreatic endotherapy. And the initial approach to any pancreatic ductal strictures would be guide wire cannulation with either sphincteroplasty or sphincterotomy, and then passage of a guide wire across the stricture, which I think is the trickiest and the rate-limiting step. It's not easy to get a guide wire across either a stone or a stricture. But once you've achieved that, then there's dilatation of the stricture, balloon more commonly, but you can use bougie and other modalities, but it's mandatory. If you dilate a pancreatic ductal stricture, it is imperative to put in a pancreatic ductal stent. It's highly unlikely that dilatation alone is going to provide you with any meaningful clinical benefit. There's a talk about the dominant stricture, and just to mention it, that that's the main cause of symptom. It's defined with an upstream duct dilatation of greater than 6 millimeters, the stricture length of greater than 4 millimeter, and generally occurs in the pancreatic head. Couple of videos, some of the videos are courtesy of Craig, which you all know. So here again, this is a stone and a stricture within the pancreatic duct, and as you can see, passing a wire is not easy. I usually start with a sort of stiff shaft hydrophilic sort of 0.025 wire, but there are various other wires that you can use if that doesn't work, including a 0.018 wire. If a wire cannulation by itself is ineffective, you can use other instruments to help this. In this case, this is a rigid sort of a 5 French diagnostic catheter which is utilized. Once you've got the wire through, then that's balloon dilatation. Usually I go to 4 millimeters, but sometimes you might need to go greater to about 6. With regards to next step, which is stenting, almost all guidelines recommend using plastic stents in the first instance, and a single large caliber stent is preferred over multiple smaller caliber stents in the first instance. The stent should be at least as large as the pancreatic duct diameter and should be long enough to traverse the stricture, but not too much further beyond that. The plastic stents do require changes. You can either schedule them electively every 2 to 3 months or on return of symptoms, but no later than 6 months. As I said before, larger, like 10 French stents, there's evidence that suggests they result in fewer hospitalizations. If after replacing the single stents at about 12 months, if the stricture persists, what you call a resistant or a stricture, at that point you would probably put in multiple plastic stents. Generally, I would use different lengths and different caliber or different French, but it is not easy to push through a 5, a 7, and a 10 French together across those stents. But there is no clear head-to-head comparison favoring one schedule over the other for these, so I would usually start with a single, if possible, 10 French or anything, the biggest stent I'll go through. The long-term efficacy of pancreaductal stenting for relief of pain ranges from 50 to 90%, and there are some predictors for a good clinical outcome, which includes obstruction located in the head, and that might be to do with easier access and tender treatment, short disease duration, and low frequency of pain attacks prior to the intervention. There's been some interest in fully covered self-expanding metal stents in this area. There are not many studies and old meta-analyses, systematic review, which compared plastic stents with fully covered metal stents. And although in terms of technical success, stent migration rates and pain relief rates were similar, the metal stents did have a significantly higher complication rate. And there is also some emerging data to say that metal stents themselves can cause recurrent of strictures, but also new strictures related to the metal stent itself. So I personally don't use metal stents for pancreatic endotherapy and prefer to use plastic stents. There are some other specific cases such as anastomotic strictures which provide a completely different challenge in terms of cannulating, primarily because of the difficulty in intubating the afferent limb, but then also both the identification and cannulating the pancreatico-biliary anastomosis. And similarly, if there is a failed transpapillary cannulation, and in these, the next step could potentially be EUS for EUS-guided pancreatic drainage for these pancreatic ductal strictures. So particularly in failed ERCPs, altered anatomy, and disconnected pancreatic duct syndrome. Once there is wire access, you can either go ahead with a rendezvous technique that you would do with biliary, EUS-guided biliary drainage, or a transmural stent. Keeping in mind that this is a technically extremely difficult and challenging procedure, and it should only be done in high volume centers. And there is some data to say that you should have done at least 50 or so EUS-guided biliary drainage before you embark on pancreatic ductal drainage. So just something to keep in mind. It's just not something that you would do as a first step. Moving on to pancreatic ductal stones, like I said, there's a bit of an overlap, and once again, they do occur in a large proportion of patients with chronic pancreatitis. They are more difficult than biliary stones due to their shape and morphology. They're harder stones, and you're dealing with a smaller caliber Is that I'm supposed to stop? A smaller caliber duct, which is more tortuous, and so it is a more difficult procedure. The first conventional ERCP still is really the first step with either sphincterotomy or sphincteroplasty, an extraction of the stones using either balloon or baskets. I have a fear of God when it comes to basket, particularly in the pancreatic duct, and almost always will use a balloon in the first instance. Certainly, the stone size does matter. Yeah, conventional ERCP is much more successful in stones that are less than 5 millimeters, and you would try and avoid using them in bigger stones. It's trickier when the stone is distal to a stricture or in the tail. Overall, it does have a 60 to 70% success rate in stones that are less than 5 millimeters. The stones are bigger. We've got Sandeep sitting out here, and they are the true powerhouse when it comes to the, we talked about the ESWL. It is very effective, however, at least I can say in the Australian context, it's not available. I know at least in ACT New South Wales that there is no ESWL available. I don't know if there's, what about South Australia? Is anyone else has ESWL available in their institute? No, so we are limited in that. So I know that you guys probably have the largest, more than the entire world put together for doing this, but we don't have that. It is useful and significant 70 to 90% fragmentation rates in large stones. It requires multiple sessions, 2 or 3 sessions, and if they are fragmented to quite a small size, they may or may not need a subsequent ERCP. But generally speaking, after 2 or 3 sessions, you would do an ERCP and balloon trawl to extract all the small fragments from the pancreatic duct. A few limitations, again, are in the tail and of the pancreas, and contraindications include coagulopathy or pregnancy, not obviously. From our perspective, and in Australia, I guess the emerging technology in some ways is the single operator pancreascopy, similar to the which we initially used a cholangioscope for biliary strictures or biliary cannulation. Once again, it is a challenging thing, and we saw a very good case, although it was in the bile duct, but you can see how difficult cholangioscopy, doesn't matter whether you're going in the biliary tree or getting into the pancreatic duct, can be an extremely difficult and challenging procedure. But once you're in, it is quite effective. And Nam was supposed to do a talk, so I'd remove all my slides on talking about the actual technique. But there's a few things. The PD must be dilated at least 4 to 6 millimeters in width to get your probe in. Otherwise, if it's not, you will dilate it further. You need to have a relatively non-tortuous course, which is not in your hands, but generally makes it very difficult if it's a very tortuous pancreatic duct. The probe should always be initially advanced over a long guide wire. Pancreatic sphincterotomy often is required to facilitate being able to put in the cholangioscope in there. Stones which are downstream in the stricture may need to be managed first, and strictures may require dilatation to pass the probe across them. It does have its complication rates, including increased risk of post-ERCP pancreatitis, and I'll talk about some of these others. So this is a video of managing a stone using a pancreatoscopy, and this is laser lithotripsy. Essentially, you've got 2 modalities. You can either use EHL or you would use laser, which I'll talk a little bit about. So most of these cases will also require a couple of sessions, usually 2 to 3 sessions, and a stent, pancreatic ductal stent in the intervening period. Let's see. This is another sort of a case out there where you'll see a stone distal to or proximal to the stricture, if you like, depending on how you're looking at it. And once the stone has been disintegrated using either EHL or laser lithotripsy, it allows you to better visualize and characterize the stricture, and if required, you can take biopsies for histological purposes. Once the stone has been fragmented, then standard ERCP technique with balloon may be used to extract the stones from the duct. This is there in the literature, and as you know, ESG guidelines do suggest using ESWL as the standard of care for stones which are larger than 5 millimeters, but doesn't matter what the data shows, we don't have the availability of that, so we'll probably go straight to pancreatoscopy if it is clinically indicated and the patient is symptomatic. I mentioned the two modalities in terms of lithotripsy. One is the EHL and other is the laser lithotripsy, either holmium or thulium. The current data supports that the laser lithotripsy is superior to EHL, but once again, I think it's about availability. For the laser lithotripsy, we're reliant on our urology colleagues to provide with all of that. Does require special room which is laser proof and all the rest of it. So there is much greater or wider availability of EHL. And the difference between the two is somewhat subtle. I think it might take you an extra session or two, and they are a bit harder to break with traditional EHL probes. The thing might change if we use 9 French or 7 French scopes as they become available, because the laser catheter is a little bit finer and smaller than the EHL. So in terms of treatment for PNE stones, I think the first step for stones which are less than 5 millimeters is conventional ERCP with balloon or basket extraction. For larger impacted stones, I would say they require now pancreatoscopy and lithotripsy with any one of the modalities. Salvage options would include EUS-guided pancreatic gastroscopy or surgical drainage. Talked about this already, getting time. So long-term success, there is recurrence of pain is real and can occur in at least a third of the patients at about a 2-year follow-up, generally from stricture reformation. Does regular surveillance, both clinical as well as radiological, is required, and the general recommendation is imaging every 6 to 12 months for the first 2 years post-intervention, and then as there is evidence to say that early re-intervention is important to improve the outcomes as compared to delayed intervention. Just one slide on the role of surgery. As physicians sometimes forget about this aspect, but it is important, and actually the AEG practice guidelines say this is the preferred option, and even if you don't use this as a first primary modality, every patient should be informed about the potential benefits in terms of outcomes of surgery as opposed to endoscopic treatment. So there should be clear education of the patient before embarking on any endoscopic. Surgical procedures can either be resection or drainage. I'm not a surgeon, I won't talk much about that. I thought there was but we'll see. Good luck reading that. But so I think if there is a sort of an algorithm, so I think from my perspective, what I would do in these situations is assess with multimodality imaging, CT for stones, MRCP for strictures, and EUS for everything. It is important to characterize the type of stones, the location of the stones, and strictures that helps you to plan. For simple stones which are less than 5 millimeters with no strictures, conventional ERCP with the first line of treatment with a high success rate. For complex stones, personally, I would use introductal lithotripsy with pancreatoscopy. Dominant strictures, sequential dilatation, initially with single plastic stents and then multiple plastic stents if there are resistance to that. At this point, I personally do not recommend or use fully covered self-expanding metal stents in this situation. For failed ERCP or refractory cases, EUS-guided pancreatic drainage is an option. However, as mentioned before, only in high volume central and expert hands. So in conclusion, I think endoscopic therapy can be the first-line treatment for symptomatic pancreatic stones or strictures. It's safe, effective, but requires careful patient selection like everything else. Management of strictures are primarily with dilatation and large single plastic stents in the first instance. Repeat stenting, including multiple stents, may be required. The key evolution is moving towards visual guided lithotripsy or pancreatoscopy, both for inspection, diagnosis, but mainly for therapeutics. Success requires multidisciplinary team collaborations, and early surgical consultation does prevent futile endoscopic attempts. Thank you. Very good. Comprehensive, thank you.
I think we're going to invite John Thompson up for his talk before we go to the next endoscopic case. John Thompson is a HPV surgeon as well as a liver transplant surgeon in Adelaide, working at the Royal Adelaide Hospital and Flinders Medical Centre. He's trained in South Africa and has had further training with fellowships both in Amsterdam and Leeds prior to settling in Adelaide. Welcome, John, and we look forward to your talk on chronic pancreatitis and its complications, endoscopic or surgical management. Thank you.
Thanks, Elaine. Hello, everybody. So I'm acutely aware it's the end of the day. I'm also a surgeon speaking to a largely endoscopic or gastro community. And interestingly enough, that may have been why my talk was only 10 minutes and everybody else's 20. Having said that, I'll try to talk as quickly as I can and not ramble too much. Yeah, time's gone out of the window, I can see. But that's okay. So I was tasked with talking about chronic pancreatitis and the complications thereof, surgery versus endoscopic management. And just by way of introduction, chronic pancreatitis is a progressive fibroinflammatory disease of the pancreas that's characterized by irreversible glandular destruction, resulting in often persistent pain and progressive exocrine and endocrine dysfunction. Now, with regards to what these complications specifically are, they're vast, but pain is probably the most prominent that we have to deal with both as gastroenterologists and surgeons. Pain is multifactorial. It's primarily from ductal hypertension and potentially an inflammatory mass within the head of the pancreas, which is believed to be the pacemaker that drives everything. But there's certainly a neurological component to it as well, where we have sensitization of the local nodes as well as neural remodeling. These patients often also have central sensitization, and another aspect to the pain is the fact that they may have pancreatic ischemia as a result of the fibrosis. Pain goes hand in hand with the main pancreatic duct disruption. The other complications that we see are pseudocysts and significant ductal ruptures which go with this, biliary strictures which may present as jaundice or cholangitis, duodenal obstruction as a result of significant head disease and inflammation, and then an array of vascular things that can happen both arterially and venous. The most common arterial are aneurysms. The most common venous are probably thrombosis of various vessels. Parenchymal failure, as I've previously alluded to, and then obviously the feared malignant transformation that can occur. So what do we have in our toolbox? Well, this is not mine, but yours, and correct me if I'm wrong. You have a number of modalities that you can use to your disposal in treating chronic pancreatitis. ERCP, obviously, and ESWL that you previously alluded to, pancreatoscopy that you've just showed us some nice images, and then EUS and biliary stenting. The AEG guidelines that were published not that long ago is really starting to allude to surgery being more useful more early, and I'll show you some evidence with regards to that as well as we go through this talk. I think the important thing, which I could probably add to every single slide, is, and you alluded to this in your previous talk, is these patients need to be counseled appropriately, but I think more than that, before these patients embark down a treatment modality, they should probably all be discussed in an MDT setting with both endoscopists and surgeons, because we both bring various different skill sets, and it's only the union of those skill sets that we can really determine the right outcome for our patients. As surgeons, we have an array of procedures that we can do. This is certainly only a few of them, but I suppose we can divide it up into two main groups, being resectional and non-resectional procedures. And as that states, resectional, you're actually losing parenchyma, whereas non-resectional, you're trying to preserve parenchyma and just decompress the duct. The first two are non-resectional, whereas the last three are all resectional. Total pancreatectomy is something we're very fortunate to be able to offer in this hospital with auto-islet transplantation, and we've had very good outcomes, and I know there's a talk on that tomorrow by Toby. Surgery is certainly not the last resort and should be discussed earlier than later. So if we delve a little bit into these complications specifically and try and have a look whether there's an endoscopic or surgical role. Pain, there's certainly an endoscopic role, but I'm going to challenge the longevity of that with the evidence in the next few slides. Pseudocysts, I would agree that EUS drainage is really first-line management these days, and surgery should only be implored if the anatomy is not suitable or there's failure thereof or recurrence. Biliary obstruction, definitely ERCP up front, surgery only as a last resort. Duodenal obstruction, however, is probably more biased towards surgery. Pancreatic duct rupture is an interesting one because I think it depends entirely on the location of the rupture. If you have more proximal or nearer to the ampulla, I should say, injuries, stenting may have a role. But as I'll show you in a case presentation a little bit later, the more distal it is, the more difficult it is to stent. The other thing with stenting, you're now taking a sterile environment and introducing gut microbes into it, and you can potentially take a sterile field and make it infected quite easily. Endocrine, exocrine dysfunction, there's probably limited role for endoscopic management, but surgeries such as total pancreatectomy and auto-islet transplantation is certainly feasible. And malignancy concerns, I think it's a combination of both of them to make the diagnosis and get the best outcome for the patient. So this randomized controlled trial by Kane was done a number of years ago, and yes, it's not the biggest trial. There were only 39 patients in it, 19 in the endoscopic arm and 20 in the surgery arm. They had a mean follow-up of 24 months, but this was stopped prematurely as a result of the interim analysis showing a significant benefit in surgery. And you can see the Izibiki pain scores are significantly better in the surgery group. And the conclusion of this trial really was that surgery provides earlier, longer, and more durable pain relief in patients that have got a dilated duct and pain. The Dutch, who are really the pancreatic randomized controlled trial kings, went on to do the ESCAPE trial, which was comparing the effects of early surgery versus endoscopic first approach on pain in patients with chronic pancreatitis. Again, not a very big trial, 88 patients, 44 in each arm, but there was a clear benefit to early surgery. Early surgery significantly reduced pain when compared to endoscopic management, and surgery had a longer, surgery was far less procedures when compared to endoscopic management. They then republished their data in 2025, which was their long-term data of this trial, and that demonstrated that there was clearly still a benefit a number of years later in the surgical arm. Patients that ended up crossing over from the endoscopic arm to the surgical arm in their long-term data did worse, again favoring early surgery. So just shooting up a couple of international guidelines, what's quite interesting is if you look at painful obstructive chronic pancreatitis in patients that have got, in painful chronic obstructive chronic pancreatitis, endoscopic management is preferred in most of those guidelines, despite there being clear surgical benefit. I suppose as a surgeon looking at endoscopic guidelines, one has to wonder who's writing the guidelines and whether there's any bias to that. Fortunately, if we look at the end, there is a little bit of introduction of early surgical consideration, and probably the Australian guidelines are the ones that are encouraging an MDT approach and potentially surgical management early. So, with regards to complications, there's nothing more interesting than a few cases. These are all from Royal Adelaide, and Yling probably recognises a few of them. Case 1 is very interesting because if you have a look at this MRI, you might initially think that that's the biliary tree. But this is a case of a pancreatico-portal fistula where this patient had chronic pancreatitis and the pancreatic duct ruptured into the portal vein, thrombosed the portal vein, and there was pancreatic juice within the portal system. So if you compare the top and the sort of bottom right image, that's actually the bile duct down there. You can see the rupture over here. And this patient complicated with a number of vascular issues. Bleeding was significant. You can see angiocoils here. We ended up coiling this patient a few times. Developed biliary obstruction as a result of the inflammation. And Yuling had many, many sleepless nights over this patient. And ultimately ended up with a subtotal pancreatectomy just to get control of the situation. So this really highlights both an endoscopic, surgical, and interventional radiology approach to a patient with a single complication. The second of which I alluded to earlier, this is a recurrent alcoholic pancreatitic who presented with pancreatic ascites as a result of a ductal rupture. We measured this at our MDT meeting prior to embarking down an endoscopic route, and I think this was in the region of about 11 or 13 centimeters from the ampulla, and Nam and William just felt that it wouldn't be worth trying to stent this. We put in some endoscopic drains, IR-guided drains for this gentleman. His pancreatic ascites has improved. He's had a number of collections and septic episodes, but at this point in time, we have managed him conservatively, although I think he's probably heading down the route of a distal pancreatectomy because he's not entirely settling down. Case 3 is one of my patients, and And this was a youngish lady, I think in her 40s, that had significant exocrine and endocrine dysfunction with significantly calcified pancreas due to alcoholic pancreatitis. We attempted endoscopic stenting in this lady, but as you can see, her head of pancreas was massively calcified with large, both intraductal and parenchymal stones, and nobody could actually get a guide wire past. We ended up offering this lady a total pancreatectomy based on the fact that she had both endocrine and exocrine dysfunction that was fairly significant. She was an insulin diabetic already. And post-surgery, she was off all her opiates and her pain was completely resolved. The last case was an interesting one. Another young gentleman, 40 odd years old, previous significant alcohol misuse, presented to the respiratory ward with a massive pleural effusion. And it took them a number of days to figure out what was going on. Eventually, some bright individual did a lipase, which was significantly raised. This gent had developed a pancreatico-pleural fistula with very little fluid inside the belly. He had a pleural drain, and we thought everything settled down. However, after recurrent episodes, we tried to stent his pancreas. As you can see, the guide wire just wouldn't go anywhere. Stent failed, and he reaccumulated, I think, 2 or 3 times in his chest. We ended up doing a distal pancreatectomy for him, and he's 4 or 5 years out now, and we haven't seen him again. So, take-home messages. Endoscopic management is excellent in decompressing the duct, but repeated procedures is the Achilles heel, and surgery should really be offered earlier than later in feasible patients. The evidence also favors early surgery. Robust early MDT discussions are recommended. Endoscopic drainage of complications such as pseudocysts often offers a very durable solution, and I feel a holistic management of chronic pancreatitis requires both endoscopic, interventional radiology, and surgeons. Thank you.
Thanks very much, John. Do we have any comments or opinions from the gastroenterologist? Thanks.
Practical aspects of it are the patient choice when you offer them a total pancreatectomy or a partial pancreatectomy versus a potential endoscopic procedure. And secondly, at least in certain settings, is the enthusiasm that a surgeon has for some of these surgeries as compared to if it's a pancreatic cancer thing. What is your take on that?
I agree with you. But having said that, I think the counselling of the patient is very important, but the patient needs to be counselled from both aspects. So from an endoscopic aspect, yes, it's very attractive, single day in hospital, not too much pain, if any pain at all, no time off work, that type of thing. But the problem is it's not guaranteed, it's not going to take your pain away completely, and we're going to be doing this regularly. And we don't know when the end point is. Whereas surgery, yes, you're going to be off work, yes, it's going to be painful, yes, it carries complications, etc., but we could probably offer you a durable solution. And I think if you present it in that sort of manner and you have a robust discussion, patients with this chronic pain really just want their pain gone. So they'll probably take the better, longer, durable solution.
I think you're right, and again, for the sake of discussion, I think in my experience what happens is the patient hears what they want to hear, and unless they're back for the 3rd or the 4th or the 5th time to have the endoscopic procedure, they haven't heard that surgery might fix it at the first go because they're going to lose a proportion of the pancreas. And I think from a practical perspective, that is the more challenging thing, I think, in terms of which direction they head.
Yeah. Sorry, your second question, I don't remember.
Yeah, I think robust MDT discussions the way to go, and we do have an interventional radiology talk later on, but I think we are going to a live case next. Is that right? Thanks very much, John.
Thanks.
Just moving on to the penultimate of our live cases for today. This is a 70-year-old gentleman who has a history of metastatic pancreatic cancer with SMA encasement, locally advanced with invasion to the stomach, and the lesser curvature, and metastatic to liver, left adrenal, and lymph nodes. He's previously had gem-Abraxane for chemotherapy. Presented to Queen Elizabeth Hospital with nausea, vomiting, and inability to tolerate oral intake, and had an NG tube with large volume outputs and gastric distension, has been requiring oral intake, and he has a CT scan showing a pancreatic heterogeneous hypodense lesion encasing the stomach, compressing on the portal vein, but with multiple locally dilated collateral vessels, likely secondary to portal vein obstruction from the mass. So he has a lot of complex vasculature. At present, diagnosed with obstruction secondary to his pancreatic ductal adenocarcinoma, and is planned for an EUS-guided gastrojejunostomy plus minus Axios, with a backup plan to proceed to duodenal stenting, depending on what we find today. Over to Tech Suite 4.
Can you hear us?
We can hear you. 1 second for the camera.
Because we've got direct gastric invasion rather than the more typical sort of duodenal obstruction from pancreatic malignancy. Have you got the endoscopic view on at the moment?
We don't have the screen yet. Just give me a second.
Okay. So once you're pulling that up, so the issue we've had here is where the obstruction is almost in the mid to lower gastric body rather than more distal. And so Sandeep, who's here with us, Nam, and we've got moral support from Andrew and William as well, are all a little bit concerned about sort of being able to put an Axios stent through there without directly puncturing into the tumour. So we've all sort of pored over the imaging. There does look like there may be a small bowel loop near the upper gastric body, but it looks quite far down in the jejunum. And so
if you can actually rotate your camera and actually just actually show the CT scan, and then I'll show you the endoscopic image of the stomach. Okay, so can you see actually the CT image? There is a yeah, it does look horrible. So this is mid-stomach, basically nowhere near the duodenum or the pylorus or pre-pylorus. So right in the middle, basically, of the stomach. And you can see that it's actually a posterior wall invaded anteriorly, cause constriction here. Now, the constriction is actually not tight enough, and I just actually, even if we consider enteric stent, just wonder if it's tight enough to hold the stent. If anything, actually a colonic stent may actually stay, but I'm a bit concerned that actually even enteric stent might not stay in this position. And you can see that actually I'm just traversing the stricture showing the antrum and pre-pylorus, and the duodenum is completely normal. Okay. Now I think we maximize our chance of a possible EUS-GJ connecting this pouch, this part of the greater curvature.
You've got the endoscopy view?
Sorry?
I think
all and yeah, perfect. We
yeah,
got it.
okay.
Yeah. I think technically it's going to be difficult and it's going to be a bit risky as well. You can see that cancer have invaded anteriorly here, so you expect that there's a lot of tumor here. If anything, it might be just here to the loop of bow that I showed you before. So what I did, I went to DJ Fletcher, insufflate a lot of water, and now I'm going to pull out and have a look with, huh?
Trying to put the nasopilary tube down whilst we're here.
Yeah, I guess we can do that preemptively. Can I have the nasopilary tube now, please?
So we'll just leave this as an orojejunal tube, I guess, at the moment. Just in case we do find that loop that we saw on the CT. I think the worry is it's a long way down the small bowel, and so I'm not sure that we'll actually be able to leave our tube at that point and then be able to see it on the EUS and access it.
So this is we've been pushing so hard with EUS GJ and say, this is better than or equivalent to surgery, but I guess in a case like this, we do have limitation, and I guess surgery is also not a possibility here because the stomach is quite diseased. So regardless of what it is, I think this man might just have a simple feeding tube put in, but let's have a look and see if it's possible to create any gastrojejunostomy. Maybe we should ask opinion from Yuling and John Thompson, who's the Hep B surgeon in the room, and see what's their thought in this setting. Okay, can I have the tube now, please? No, the nasopilary tube.
Sorry, Nam, I had to leave for a little bit. So, how extensive is the disease?
So it's a metastatic disease. The patient's had chemo. So we can, the obstructions in the mid-gastric body. And it's direct invasion and infiltration.
Can you put a guy in?
And you're in the duodenum now?
We are. So we're in distal duodenum, probably close to the DJ flexure.
I'm probably in the DJ, about to cross into the proximal jejunum. So I think this is not a problem here. The problem is where we're going to place the stent in the stomach.
The gastric end is the question.
Yeah.
The jejunum is fine. With avoiding the tumor, is that the aim?
Correct.
I think this guy's prognosis is going to be extremely poor if this is pancreatic cancer and he has such extensive invasion. I think the benefit for an EUS GJ is really in patients who have an expected survival of more than 3 months, and it's sounding like we're not really anticipating that here. So I think
I agree with you, Linda. That's what I wasn't prepared to put any nasopilary tube in for the whole thing. But for the purpose of the workshop, I'm just quickly put this down, irrigate, so to see if we can see it. But I think we'll have trouble of visualize the loop, or even if we visualize it, we have to punch it through the gastric portion that have the cancer invasion. And that is not ideal, and it probably doesn't work that well.
I suspect a lot of his symptoms, Nam, are also from gastroparesis rather than complete obstruction, because as you showed, you can get through really easily.
Back.
Yeah, but that's why a stent's not going to help. Like the therapeutic gastroscope got through without any trouble, so I didn't think an enteral stent is going to hold. Which was our initial thought, was that an enteral stent would be a nice way. It's low risk, simple. We could get his stomach open, and radiologically it looked like maybe it was obstructed a bit more distally than what it is on the endoscopic view. So I think stenting isn't really an option here, and I think all we can otherwise offer him is a nasojejunal feeding tube, which in the short term is okay, but for this patient to be thinking about getting out of hospital, I don't think is likely to be feasible. So.
Well, certainly we can use this actually as a feeding tube if we needed to. So it served the two purpose, yeah?
So what NAM has done is put a oroenteric tube deep inside the proximal jejunum so that when we fill this up with pump and contrast and some coloring agent and see if that is close to the stomach, which is not involved by the tumor, then that can become an entry point. The rest everything is not going to help him.
Yeah.
So he has very limited options. I think this may be the best option if the mechanical obstruction is preventing the food from going from proximal stomach to the distal stomach.
Yeah.
If not, then we always have an option of a nasojejunal tube for a long time till the patient survives.
Yeah. All right, let's exchange for the EUS.
Well, I think we'd have to look on fluoroscopy and see how close we are to the tube tip and maybe advancing a wire down.
Having said that, the patients who have malignant gastric outlet obstruction, the cancer of pancreas in the head region are the best candidates. Gastric cancer is not a very ideal candidate for the, as we see in this case, where the tumor is actually invaded the stomach. It's more like a gastric cancer behavior rather than a CA of the stomach, of the pancreas.
Correct.
It's just infiltrating from the outside instead of the inside, but it's acting the same as a linitis stomach, so.
Yeah, I think exactly the actual pancreatic cancer is quite extensive, and the whole posterior wall of the stomach, the mid part exactly is been. Can you pull the scope? Sorry, clear machine next to me. Let's undo this.
Sometimes an oral contrast study is useful when we do a cross-section study. If you go oral contrast, if that stays in the stomach and trickles down that narrowing, that may be a hint that
let's have a
may
look
still
at this
work.
first. I'll be very doubtful, but anyway. I think
Okay, let's see what the EUS shows.
First.
So NAM is putting a linear EUS, Aplio supported Olympus scope.
Okay. Can I have suction, please? Nothing is connected. Okay, that's fine.
So as the audience, they should understand that not every case who has malignant gastric outlet obstruction can be palliated by GJ.
Correct.
When not to do is equally important, and this may be a 50-50 chance where we may succeed. Or maybe 75-25? 75 for failure and 25 for...
90%, or I
90,
think so.
okay.
No, I think
Ma'am is even more pessimistic.
Yeah, I'm not very optimistic
Okay,
when I look at
yes.
this.
Safety first, I think that's another important lesson that we should all learn. Do no harm, and then do good.
Nam, could we get your EUS view, please?
Yeah, EUS image.
We haven't got a EUS picture just yet, so.
What's wrong with
he's
the
getting it right.
EUS imaging?
Yes.
There is something connected, but exactly, did we put a balloon in? What's actually happening here? I can't see.
Quality is,
there's no balloon insufflation.
Can you make it brighter?
Yeah, no, this is not the usual thing.
What's happening there?
What's wrong with the scope? Did we put a balloon on? I can't see any balloon insufflate here.
The stomach wall looks very thick.
Even the normal stomach doesn't quite look normal.
Yeah, it's very abnormal.
That's
the tumor is infiltrated.
The whole thing is infiltrated from the posterior wall. Unfortunately, for
so
some
Nam is
reason,
looking for that small window of opportunity where he can.
What's wrong with this?
Air is not coming.
Okay,
he just pulled out the scope for a few seconds to see if the
balloons are.
Okay, now the image quality is better. Something was there inside. Yeah, certainly it's become better.
There was a balloon there.
Okay, which was had air.
It wouldn't actually
It was not.
insufflate.
Now we got a better image quality. Yeah. So this stomach is
why is it
very thick stomach
terrible
wall
here? Which machine?
Yeah, very thick stomach wall.
Now it's actually
All
better.
tumor.
Let's actually minimize it. Okay, let's change
Now
the
we
view.
can just pump
Okay.
and see if some. It's all collateral. These are big collaterals.
Yes.
Wow.
Yeah, a lot
So
of
we are-
collateral because of the.
They're all landmines.
Correct. Correct.
Yeah, big collaterals. Here, portal vein invasion.
Yeah, there was vascular invasion on the imaging, and when we were scrolling through the pictures, there's a lot of collaterals evident on the CT as well. So there's a lot of factors that are working against this poor man.
Nothing is in favor, except us.
Yes.
Correct. I think exactly even though it's actually the CT show the potential window of the sort of greater curvature to the loop, I'm actually pressing again that's actually greater curvature almost actually at the mid pit here, and I don't think I can actually see any convincing loop about.
Do you want us to put the water in?
Yeah, we can, but actually I think this is actually.
Going to be low. If you want.
Can I actually take the wire out and then actually connect and see if we can see any of the flow through the nasobiliary tube?
Would you put some contrast down the nasobiliary and see fluoroscopically where that is?
Yes, we can actually do that too. But I mean, I think we again. So we need to actually connect the. So for those actually using the nasal biliary tube actually for insufflation, be cautious when actually you undo actually the bumper. There's a little black ring that's actually you must keep, otherwise actually you can't fix actually the tube. You got it? Oh no. So this is what I mean by actually the black ring here. When it's displaced actually, then you can't actually insufflate it properly. Okay. You need that black ring. Okay, let's connect quickly to the water. I mean, even trying particularly to do EUS evaluation itself, I have problem of figuring out what is what here. So actually that's actually the liver. We have huge amount of abnormal tissue here.
There's no window
and I think
anywhere.
exactly this is all obstructed,
this is a very tough, yeah.
obstructed cysts and
Does
fibrons,
it have
particularly from the
contrast also in
cancer,
that? No.
and possibly,
Okay, at the moment, no.
yeah, and possibly some of the blood vessel as well. So this is actually look less and less promising. Are we?
So what's that area there on the left?
I agree with you, Millen. Looks like there might be some bowel coming in on the left there, but I think this is probably all academic.
I agree. I agree. I think give me 1 minute. If I can't find any.
I think down there now, straight under your transducer, that might be a small bowel loop, but
yeah,
but it's you can't see the tube in there. I think there we're seeing
This is colon, I think. This is colon.
You're not sure though. Actually, normally when I irrigate, I should see flow.
You're seeing a tube there? Yeah, you're seeing a tube also.
Yeah. Yes, I think that's your.
But no flow.
No flow. That's a bit odd. Normally I like exactly a lot of flow, and this loop of bowel is not actually distended that well. and certainly it's only 1.3.
No.
And certainly if we create any complication in this man, he will not exactly recover from whatever we've done.
Do you think it's worth putting our fluoro on here now to just see whether we're anywhere near the end of the tube?
We can.
So I think if we're nowhere near the tube, then we probably should
All right.
abandon
Well,
this.
quickly we inject some contrast.
I'm covered, yeah.
You're covered? Okay.
Yeah.
Let's come in. Let's raise the bed, and then the X-rays, please come in.
We'll just do an X-ray and see how close we are to the tube. But this looks like
So I think the most realistic option for this man would be a nasal jejunal feeding tube, which I will put in. But just simply, let's spend one more minute simply to do the contrast and see how we go. Okay.
Is there a tube inside? Some tram track is seen. I'm not sure. I'm just overreading things.
It's hard.
It's hard
everything's
to know.
so abnormal.
It's hard to know.
There's no normal structures or
Suspiciously like
landmarks.
colon.
Yeah,
it could be colon too, you see. The unusual thing is actually if there's no flow on my water pump irrigation,
and you've put a good amount of fluid through
then
there, so.
I would say actually that is not actually the correct loop. And remember, actually, up here, the transverse colon will be very close to the stomach too.
Correct.
So, all right, can you, move down a bit more? Okay, screen now. Are you magnify or actually? Okay. Where did we have? Okay, let me pull back. So, move down more. I can see some of the, okay. Go backward a bit, back toward you. Okay, inject some contrast and then we'll see. Stop screening. You might have to move down a bit more, please. Yeah. Yeah, just keep injecting. Screen now.
Try and find the end of that.
Yeah.
Yeah, you have to pull it back, I think. Pull the tube back. Yeah, the tube is very deep.
I think that we're so far away from where your scope tip
I know.
that I don't think we...
Would you like to pull it back, ma'am?
Yeah,
This tube a little bit, say a few centimeters back and see, and then we fill the intervening segment, more proximal segment. You should have seen something by now.
Okay, let's try that one. It pointed at the right direction there. Probably this is exactly the... Okay, let's see if I can come a bit closer to that one. Keep injecting. Flash screen. Move toward me a bit more. No, this is exactly the lever, so I'm pointing at the wrong direction. Let's try actually this way here.
Not looking good, is it now?
No. Screen now. Now, move toward me a bit more. You can see that the loop actually is going that way. Move toward me a bit more. Flash screen. Where is my tip? My tip is so far away.
So far, yeah.
So far away.
You can see the contrast on the left there on the X-ray view, and that's sort of downstream of where you're...
That's the furthest that actually I can get close to anything.
Yeah.
I'm actually at 50. I can't go any further. So I think actually for the interest of time, I think we can all agree that this is not a case for EUSGJ. And a nasal enteric feeding tube to palliate him is actually the best outcome for this guy.
Yes, agree, 100%.
Perfect. All right.
Any objections from the panel? Anyone think that they saw something that we've all missed?
Objections at all.
Perfect.
Very happy with the
Okay.
plan.
We should move to next door to see Frank do an embolectomy then.
Okay. For our last case, we have a 67-year-old gentleman with HIV with good viral suppression. and a complex medical history including COPD, CCF, cognitive impairment, AF, and a vascular path history. He was investigated for cholestatic LFTs and found to have a dilated CBD and main pancreatic duct, as well as a possible ampullary lesion that was found on MRCP and confirmed on EUS, where biopsies showed a tubular villus adenoma. On MRCP, there was pancreatic duct dilatation up to 8 millimeters at pancreatic head and tapering at the distal CBD. And there was a EUS sonographic appearance of the main pancreatic duct, confirming that as well, and a double duct sign with a 12 millimeter main bile duct. These are some of the images from the previous EUS. So for his ampullary adenoma, we are proceeding to a ERCP with papillectomy and biliary and pancreatic duct stenting over to tech suite 3. Yep, we can.
Okay, and what picture can you see?
We've got the endoscopic.
Endoscopic picture. So, last case, so let's do this really nice case. So you have heard the story, and thanks Milan for joining. So this is in the second part of the duodenum, and you can see there is an ampullary lesion. Initially the ampulla itself, if you look at that, it just obviously looks adenomatous, but on more careful you've also got a sort of a non-granular component that's more laterally spreading, and if you look underneath, it's still affecting down below it. Always like
shows that extension distally nicely.
So again, I just like using the freeze button so you can get a good idea of the size. We sort of want to, when we take this off, we want to make sure we can seat the snare right above it, and we can get a good perch on the top. Nice extension underneath there.
Do you think you're going to get this in one bit, or are we going to inject underneath?
Well, I think most of it you
can.
can. Some of it, this bottom one, can you just EMR it if there's something left. I'll see. I've chosen a 20 millimeter snare. We'll see if we can get it all, and we'll see if we need to upsize the snare.
Frank, are there any features on it that make you worried about invasive malignancy?
Not endoscopically. I guess he's got a dilated duct. I'm just trusting that the imaging in EUS doesn't show any intraductal extension. Size-wise, it's less than 4 centimeters. It doesn't have any ulceration, overt ulceration. And we've got a biopsy that shows low grade, I think. So no high-grade dysplasia in that. Is that correct? I think that's what's going on.
So Frank, if you had a large laterally spreading component, would you remove that first before you did the ampulectomy if you don't think you're going to get it all at one go? What's your sequence if you had a larger laterally spreading component to it?
I think there's value for doing it either way, but you can lift the peripheral component over here and EMR that off, and then take the rest en bloc. I think we'll probably, if we look from the top down, we'll get 90% of it. A little bit suspicious we might leave a little bit on the bottom side where we can use a smaller snare just to remove that. We could lift and remove. So I've got a braided snare.
Yeah, so I would take the lateral spreading first if it was a bigger area.
Yeah, if it was
I think
bigger.
it also gives you a nice ridge for your snare to then catch on when you take the actual ampullary mechanism.
So the idea is to start from the caudal, from the proximal side. We'll just open the snare just a smidge, just a little tip out. Yeah, a little bit open. Yeah, that's it. And now we want to see if we can perch it right over the top. And then we'll just open it really slow, open. And we'll try and swing the snare across and down. Open more. And open more.
So I may have missed it, and Millen, maybe you can answer this while Frank is working. What snare is he using?
So this is an Olympus 20mm serrated snare.
Yeah.
So I think the feeling was the 15 snare wasn't going to be big enough to catch this lesion.
I agree.
So
I just think I'll go a little bit more medial.
And then I guess the downside is the snare wire is stiffer, so it's a little bit harder to get it to hold in place and not sort of
and open more.
Traumatize the mucosa.
Yeah.
A more floppy snare will tend to pop open a bit
this
wider.
is not popping open as I would like it open now. This open more all the way.
Have any of his patients had a sphincterotomy before?
No.
Okay, good. I mean, it's an important thing if you find an ampullary adenoma. Resist the temptation to go and do a sphincterotomy because it makes it much more difficult for subsequent ampulotomy.
More.
It almost looks like a lanatus of the ampulla. No, the ampulla. If there's a term for that, I think we can spreading all over.
You can see.
Yeah, nice grasp.
We got it over the top.
Yeah.
We slipped
You
off
got
the
most
top
of it.
right? Okay.
So are you happy with that, Frank, or you want to
Well, I still haven't
the top
got
part is left.
enough of the over the top, right?
So do you think it's worth changing to a smaller snare and just trying to catch that ampullary mechanism first and then just EMRing the rest?
We'll have to EMR the rest. Yeah. I'll just try one more time, see if it will sit up at the top. And slowly advancing the scope, and then see if we can open the snare. Stop there. And open more. And more. Really wanted to get around all of that.
That left edge is not really catching nicely, is it?
Yeah, now it's better.
And, the idea is to take your time, reposition.
Very nice.
All the way
I think this looks very good.
He's really patiently working the snare there. It's not a rush, concentrating on the position, very fine scope movements to get into the axis here and get right underneath. And it's always difficult with the duodenoscope because of the angles that the snare's coming out at, but you see this looks like a much better catch than the initial one. So
tight. Okay, just keep holding it. I'm much happier with that. Okay.
Look there, you can see the top of the lesion's blanching now as well, where it's been grasped. So
you got it on in the cut, and I'll try and take it a little bit further down as well with the tighter.
So the diathermy setting is a polyp EMR setting, not a ERCP sphincterotomy step.
You want an ERCP. Here we go to ERCP, endocut, ERCP cut. It's still like quite a, yeah. So we'll just, it's nicely blanched, and I've got the control of the handle.
Frank, did I hear you go to the ERCP sphincterotomy setting?
Yeah, I want to go back to the polypectomy, sorry. You want to get,
so if you remember the cue when you're looking at endocut, looks like a snare, the eye looks like a needle knife.
2. Have we got electricity on? That's a lot of more energy than I would like.
You've got to remember, it will always take a bit longer with an ampulectomy than a colonic polyp because you've got to cut through the intraduodenal part of the bile duct and the pancreatic duct. So.
Just hold it really tight. Yeah.
Do you think this snare's just stalling now, Frank, because of the angle?
Yeah. Not sure why we're not getting. I'm really
That's a
happy
thick
with.
pedicle. That's the reason it's taking time. You've got a good chunk of tissue. Yeah, broad base now. Yeah.
It's just much more and longer. I would like to have it off in 3 or 4.
Usually an ampulla, it takes a bit longer, but not so long. Any benefit to just jiggling the snare back and forward, see if that helps you sort of go whilst you're holding down the yellow pedal to see if it will allow the snare to drive through.
I can see some bubbles inside, so I can see where we're getting energy, but...
And can we just screen left, just flash it? Just find the end of the scope. The other thing, just to have a look and make sure that we haven't gone into a long position accidentally, because that will make it harder to cut through, but we've got a nice short position there, so...
So everything is working. We've got nice blanching, but we've got a lot of... So I'm not sure if we're getting the energy going through there that we think we're getting through.
And are you happy with those settings, the 326, or do you want to reduce the cut interval?
Yeah.
Change it to 323.
Yeah. We're just going to change the settings.
Can you tell on the fluoroscopy image, Millen, how much is left of the snare to close?
Yes. It looks like a reasonable amount still open.
Yeah, yeah.
But
we've got the snare fully closed in our hand.
So I've just gone to 323. So we've reduced the cut interval, try and deliver more. And you can hear the beep is more quick. If you hold it, just try and keep it straight. So if you hold it closed, but keep it that way and keep that straighter.
It's always scary, but you'll cut through. Just press on it.
It's always more scary when it's in someone else's unit than your own. So.
Yep, now, that's it. I think you're through, right, Frank? It's a big lump. Okay, well, good, excellent. You just pull the whole thing out. Good.
Might have dropped it.
Now you have it.
Open?
Yeah.
Yes, that's much.
So huge.
You can actually feel the tissues heated up from all the diathermy.
So how big would that be, Millen? That's about 2 centimeters?
What's that?
That's about 2 centimeters?
That's about 2 centimeters,
Yeah.
and I think when we go down, we'll find there's still
A
residual
bit of interior
adenoma there.
extension of the tumor, right? Yeah.
So I think sometimes when you see taking this long, it's because rather than cutting necessarily right through at the base, it's maybe the snare slipped up a little bit, and so you've got to cut through a lot more tissue because you're cutting through the adenoma rather than necessarily under. And you'll often see this when the snare stalls, it'll beep, beep, beep for a while, and then it'll start going, and this is where you finally manage to get the energy from closing the handle really tight to start transmitting through the end of the snare, and keeping the snare catheter straight, trying to keep your scope straight, and then a little bit of backwards and forwards jiggling will be very helpful to keep that moving. As you can see here, that, you know, whilst it took a long time, there's no sign of any deep
Beautiful,
injury.
Now we can see the orifices.
So do you...
I just want to wash off a little bit because we've still got a little bit of tissue on this.
Are you going to take the rest of that now, or are you going to think about stenting your pancreatic duct first?
I think we should stent anyway, but I don't think there's a rush. Can that...
I think you should cannulate the PD first, secure that first,
All
and
right.
then you can trim, because those trimming is easy, right?
Okay. So we've got, actually got two orifices, one at sort of
That's
11
biliary,
o'clock
and the one actually at the bottom,
and
yeah?
bottom at 5 o'clock we've got the PD. Okay, so we'll go for the cannula, and we've got an 025.
So we'll just flash for a sec there, make sure we're in the right position. Good, can you just save that?
A lot more energy than I would really feel very comfortable for, but...
and what are your thoughts on a routine biliary sphincterotomy?
I do, actually, because you can get stricturing, and that's not difficult. So the PD is down here.
And what's your choice of biliary stent, or are you happy with just a sphincterotomy?
Yeah, I don't need routinely. Okay, can we have so that's the PD. Guide wire, please. Just advance. Oh, you've got short wire. You want to bring it to me? Just advance the wire. Screen, please. Oh, you're bringing it down to me. Okay.
And from the MRI, we know this patient doesn't have pancreas divisum, right?
I don't think it's a pancreas divisum.
Yeah. And it is one of the frustrations sometimes if you don't check, if you sweat and sweat trying to get the pancreatic stent in, and then finally realise they've got divisum.
Screen, please. Yeah, we're just trying. My position is good.
Is it worth putting a bit of contrast into?
Yeah, we've got a little bit of has that got contrast?
Maybe a bit of contrast.
A little bit of contrast. I was hoping not to.
There you are.
There you
Yeah.
go. So
Yeah.
definitely not a
That's the duct
divisum.
Good.
And it's amazing how that little bit of contrast
All right, no
helps
more
the wire
contrast.
find it.
That side.
Did you give Frank a angle wire?
Yes.
Okay. Then he can steer, yeah?
Frames. What's the frame rate?
Take my glove off,
We go
please.
a bit higher.
Screen again.
Yep. Good. Excellent.
Going, and
Got
you can
it.
see that nice knuckle on the wire, and that'll help us follow up the pancreatic duct.
Probably a 4 centimeters, Frank?
Yeah, 5 or something like that. You want to
5 centimeters, that's fine. Okay.
Have you
5
got a
frames, 5
single,
centimeters.
with a single pigtail?
You're the boss.
And you routinely leave your flange on?
I routinely
Okay.
give a flange on because,
Okay.
I think for pancreatitis prevention, but also when they bleed
So
tomorrow, then
we can
you've
exchange.
got something to help kind of localize you as well.
Screen, please. Nice orifice there. At least that's easy to cannulate.
Just wire slipping back a bit.
Screen again.
the duct's actually very big, huh?
Yeah, it's a big PD. Big orifice. We'll see what the bile duct looks like when we cannulate it.
Screen it, please. Yeah, do you want to just pull the cannula back? Not
This
yet.
is a little bit deep cut.
The tumor is big actually. There's still some edges left.
Nice and slow towards the end.
And I think going back to Bipul's question about dealing with lateral spreading areas first, if you've got a big lateral spreading area and you take the ampulla and then you put in your pancreatic stent, then you end up potentially with the tail of the pancreatic stent sitting on the area that you're going to resect. So this is always a planned procedure. You can't do an ampulectomy by just sort of going, oh, she'll be right, we'll take the ampulla and then hope for the best afterwards. You've got to consider and plan your procedure really carefully.
Is everything okay? What's wrong?
I guess there are just a few more spectators at this time of the day. So would you routinely do this biliary sphincterotomy and stent it?
I normally do a biliary sphincterotomy and I will stent them as well. Because I want the pancreatic stent to stay in for a few weeks. So I think putting a biliary stent in isn't going to be an additional procedure. They can just come at 4 weeks and have both stents out.
You need a hand?
Naam. Do you want a biliary stent as well? Huh? Do you want a biliary stent as well, or just pancreatic?
Biliary stent.
Okay, we'll do both.
Fully covered or plastic?
Plastic.
Plastic, yeah.
Oh, 10-5 be fine. Yeah.
So in the audience, what do people normally do? Biliary stents or not? And plastic
because actually the cut is deep. And there's a lot of thermal. You burn for 1 minute. I'm pretty sure actually these all actually end up having actually ampullary stenosis, and the duct will blow if you don't put the stents in.
Yeah, I tend to stent. I don't think there's a downside. I like plastic stents.
Yeah,
I know some of my colleagues will use an 8mm covered stent.
So 5 French
generally
so
not a
Frank and Milan,
stents.
what's your surveillance or follow-up strategy out here? When are you going to bring this patient back? Even if you didn't have the laterally spreading component, what would you do?
Well, I'll do a talk on this tomorrow, but essentially the longer, because at least 40% of the recurrences occur after 2 years. So you do have to commit yourself to monitoring them long term, but you would do maybe your first surveillance scope, depending on how pleased you are, and if there's no high grade, 6 months, and then you have to decide if you're going to have any recurrence or residual that still needs to be taken care of endoscopically.
Okay, good, that's it. Yeah. And then you can fix the wine.
Okay, bring it all the way down to me. Sorry, I'm just a little bit twisted.
Yeah. Tear all the way
just
down.
This, come this down.
Tear all the way down for Frank.
Thank you.
Yeah.
Now we'll just put the PD stent.
The machine causes interference to the thing, so when I stay so close, it's gone.
Almost getting to the bottom. There comes the PD stent. And X-rays, please. Too much wire. A little bit more X-ray. Thank you. There's the marker. We'll just want to drop it out.
Yep.
And there's the remove our guide wire at this point.
You can see there as you deployed the stent, the deliberate push down towards D3, so that as the pigtail form, it will curve down and you don't have the chance then of that stent pulling up and losing it up the pancreatic duct, because that's a real pain when you lose a stent up the...
You want to come upstairs? Have a rest now. Take off the...
Add screen, please. Okay, we'll do a sphincterotomy.
And put a bit of contrast in, just show the audience the bile
and we
duct
don't
as
want,
well.
and we don't want to see that there's no intraductal extension. Contrast, please. Yep. Screening, please. See, quite significantly dilated still, but
But we can't see any more residual tissue here.
No.
So a full shot there. We'll let the guide wire in. And 10.5.
Just get a high resolution image.
High resolution, yeah, full shot.
Perfect. But you can see there on the high-res image that the duct tapers quite nicely actually down to the bottom. So
screen, please. I don't want to lose my wire. There we go. Do you want to just pull that back for me? Or just
stop the screen.
We're a bit confused by a fluoroscopic image. What position is the patient in?
The patient's left lateral. I think we're a little bit rotated.
Yeah, we are rotated.
And so if you imagine the picture rotating about 30 degrees to the left, can you just rotate it a bit?
And that's what I thought initially
So
when we putting the PD, coming in with a PD, I was looking for it to cross
as in just
over on the other side.
This, yeah.
Can you pinch and slide? 6 change. Hold on. Okay. Do that now.
All right. Does that unconfuse you, Linda?
And then flip left, right.
Well, I think that's the Adelaide way. But I would normally have the left, right the other way around.
Yeah.
All right. Thank you very much, Frank. That was an excellent demonstration. That looks really nice. So I'm assuming you'll then just go ahead and remove the borders?
Yes, I'm particularly looking at the distal border. We'll look carefully at the proximal end because I think there's some more polyp on this side.
Perfect. Thank you so much for that. So in the interest of time, we'll move on to the last talk of today.
All right, thank you.
So we have the pleasure of having Dr. Pallavi Birapu, who is the lead of interventional radiology and consultant interventional radiologist at the Royal Adelaide Hospital. She has a special interest in hepatopancreatico-biliary interventions, complex biliary drainage portal interventions, and embolotherapy. And today she will discuss the evolving role of interventional radiology in pancreatico-biliary disease. Thank you.
Thank you. Thank you for this opportunity. I'm Dr. Pallavi Birapu. I'm one of the consultant interventional radiologists in this hospital. I want to showcase IR as a multidisciplinary input into pancreatico-biliary disease. It's not just something like a drainage or embolization that is the first thing that comes to mind when you think of IR. So coming through disclosures for the local crowd, this is our group. Please give us a call if you need anything. And I have a 10-year-old daughter who speaks my mother tongue as second language, and each time she does it, I rethink it, rephrase it in my brain, and then answer. So it's going to be the same for you guys. English is my 5th language, so thank you in advance for your patience. No other conflict of interest. So learning objectives. I want to talk about evolving role of IR in hepatobiliary interventions and a special note on complex biliary interventions, especially the bismuth-4 cholangiocarcinoma and decision making. I'm going to showcase a couple of combined cases that we have done in this hospital in the last few years where a collaborative approach has resulted in good patient outcomes. And I'll talk briefly about pancreatic complications and IR management. Coming to the management of pancreatico-biliary diseases, as you all know, MDT approach is the best way to bring out good patient outcomes. And for the last 6 years, I've been fortunate enough to be part of hepatobiliary MDT, and I do look forward to that meeting every Monday afternoon. So what it essentially does is it gives you an accurate diagnosis and a second look at your imaging comprehensively. And you do often tend to pick up minor things during the MDT that would change your management. And especially for the biliary cases, the optimal way of drainage, whether it's percutaneous, endoscopic, or whether surgical, would all be discussed at your MDTs. And it helps better manage complications in a closed loop. And it also gives you early access to systemic therapy when needed and definitive treatment planning, which improves long-term treatment outcomes. So spectrum of IR, what all we can do. I'm sure you all know drainages, complex collections, CT-guided drainage, ultrasound-guided. Example would be this one here. It's a case of acute calculus cholecystitis. Takes about 10 minutes to put a drain into it and rescue them for the acute sepsis. This is 3 weeks down the line. When you do a cholangiogram, you see this patent CBD, duodenum, and a few calculi, and within the CBD with reduced inflammation. This man ended up having a cholecystectomy 6 months down the line. And biopsies, whether it's transhepatic, percutaneous, trans-PTC, CT-guided, pancreatic, liver, or any other metastatic tissue. And coming to other things that we can offer, biliary stenting, recurrence, so post-surgical complex anatomy where it's very hard to access endoscopically. A percutaneous stenting would be an ideal way to go ahead. And I'll also discuss a bit more about complex biliary multi-segment reconstruction with one of our cases to showcase, and more about a bit about pancreatic embolization. So this is one of those collaborative cases where it's a failed ERCP. I'm sure you all know why it was. There's a large hiatal hernia in here, and I'll slowly screen. Okay, so as you see through, she's an 85-year-old lady with a dilated CBD and a soft sludge calculus lodged in there with a down-pointing edematous ampulla. And this is a coronal portal venous face CT showing a large hiatal hernia and the GB there, and a CBD with a down-pointing papilla, which was hard to cannulate, and this was a failed ERCP. So this is Rendau. I Googled that word today. It means meeting someone at a certain place. So this is a PTC picture of a peripheral duct. You can see the contrast outlining right-sided biliary duct there, and then the PTC tube in situ internal drain coiled up in the duodenum. And that's the filling defect from the stone, which looks almost essentially non-obstructive with a stenosis at the papilla. And this is the picture 2 days later with an ERCP and further management. So percutaneous transhepatic biliary biopsy, especially with a high malignant biliary obstructions, it's often the case that oncologists would want a histopathology before proceeding to chemotherapy, and often we practice stenting only after establishing a malignant diagnosis. So in cases where it's high obstruction, you're unable to extend upwards through endoscopy to get it, we offer percutaneous trans-PTC biopsy. So this one here is one such case. You see a segment 3 bile duct access with a needle there and abrupt cutoff of the left duct. This is a spine, so we're looking at the left hemiliver. And this is our next picture showing a sheath within the bile duct in there with a forceps. This is similar to a myocardial biopsy forceps with 2 prongs, and they're controlled by an external mechanism. And this is how they look on the internal end of it. And when you clamp it, it takes out a little tiny chunk of tissue, gives you histopathology. And a bit more discussion about percutaneous stenting. And as you all know, in benign conditions, it's preferable not to do metal stents. And pending histopathology, we usually offer internal external drainage and come back to the case to do the stenting. And more often than not, distal CBD stents are performed by the endoscopy teams, and we are often involved in the cases where there is proximal obstruction, difficult to access endoscopically. And the indication for stenting is often in preparation for chemo or sending home to palliate. And I will discuss it further in a few of my slides, why it's important to have a better planning in bismuth 4 cases if you're trying to offer them palliation, and not to send them home with external drains, right? Yep. So this is the APECS guideline statement from 2024, which says that it's not right or the left duct that you're trying to drain. You have to achieve at least 50% of viable liver volume drain for them to have lesser jaundice and a better post-palliative outcomes. And more often than not, for the bismuth 3 and 4 cases, you do tend to do 2 or more stents. And I want to point out this particular study from 2010 for a reason. This was a landmark study which helped do much more studies after to prove that liver volume is what you're looking at draining rather than segments or rather than right or left liver. And the reason I say that is, I'll go through the study slowly. So it was a retrospective study from 2 centers. They have taken in bismuth 2 to 4 malignant hilar obstruction, gone back, looked at their CT volumetry before drainage, and stratified the people into 3 groups. Less than 30% of liver volume drain, 30 to 50% of liver volume drain, and more than 50% of liver volume drained, and compared outcomes and survival advantage. And you can see that the p-value here is not so great, but they did find that the cohort of people who had more than 50% of their liver drain had survival advantage. And this was one of the studies which led to further studies in RCTs, which volume that to be considered when you're draining and planning jaundice reduction in malignant obstructions. So this is AEG guidelines, which also states that for peripheral or high malignant biliary obstructions like bismuth 3 and 4, either PTBD or a combined PTBD and ERCP would help in a better planning of biliary drainage. The reason I say this is because for a percutaneous access, it is easy for you to select the segments, go back in and drain a particular liver segments, rather than coming down from the ERCP, because it is quite hard to decide which segments your wires placed on a fluoroscopic image rather than coming in from the skin. And the concept remains the same: drain the liver volume, not the liver segments, and preferentially not to opacify undrained segments. The reason being, you incite cholangitis in the undrained segments and you make yourself obliged to go back, drain that segment, because you have flushed some contrast backwards into it. And the preferable stents are uncovered self-expanding metal stents for palliation. So with all this so this is exactly the same slide, which in an MDT, how you plan it is you have your CT and MR planning, look through the segments, avoid the atrophic segments, any segments with portal venous occlusion, they're non-functional, so you don't drain them. Any segments that you can't put a stent in, don't opacify them. And percutaneous access is often complementary to endoscopic access. So with all these in mind, I'll show you our case, which this is part of a case cohort that's been accepted to CSA for publication in the next few months. This is a CT scan of a man diagnosed with a high biliary obstruction. In his case, it was a GB cancer with hilar extension. I will slowly run through the case for you. So this is a portal venous axial CT. As you can see, there is bile duct dilatation. And on the left side in the epigastrium, you see a PTC running into the duodenum, and one on the other side on the left. But this man had recurrent fevers and cholangitis limiting discharge. As you can see here in the segment 7, there is this hypodense areas around the bile duct, which was a focus of cholangitis. And as you come down to the hilum, you see here how this is, isolated from the rest of the system, and that was the reason he was having recurrent cholangitis. We'll go back to the next slide. So this is the picture intra-op. We plan to do multi-segment drainage for this man and palliatively stent him to discharge home. The initial cholangiogram from existing stent shows a left-sided duct and a right-sided duct with an abrupt cutoff. The stricture is here, here, and here, and you don't see the extra, so it looks less busy on the right side because the segment 6 and 7 are missing. So this is our next slide. I'll slowly explain this one. It looks a bit busy, but so this is the segment 5 and 8 duct with a sheath at the tip and a wire in, and this is our left-sided duct. And this is this extra smaller, see how this one's smaller than the others? This is a smaller duct which we have accessed with a low-profile sheath with a narrow wire. So you essentially have left here, 5 and 8 here, and 6 and 7 here. 6 and 7 here. So the next step here is our final stented picture. As you can see, these little markings here, this is our Taewong nitinol self-expanding stent, which is a 10 by 8, I think. So that covers the CBD across the ampulla into the D3. And you see these smaller markings here. This is one stent into the 5 and 8, one into the 6 and 7, and one into the 2. I will now show you the CT picture. This is about a month after our scan. So you see those 3 stents sitting in there. There's pneumobilia on the right. The segment 7's looking better now. And as you see down, you can see those 3 stents walking into the single CBD stent and then down into the duodenum. And I have his bilirubin picture when he presented with cholangitis. And over time, this is April intervention. Until his death from his metastatic disease in October, he did not present to the hospital until October. And his presentation was for ascites and progress disease and no jaundice after or cholangitis. And with that in mind, I want to talk to you about this new trial, which is a phase 2 trial, which is published already, and there is an RCT going on in Netherlands. So they have considered doing a primary percutaneous stenting for malignant high biliary obstruction. What it involves is before they turn into cholangitis, before they have acute septic symptoms, when you have diagnosed a non-surgical or unresectable malignant high biliary obstruction, they have considered doing a primary percutaneous stenting, and they don't leave external drains in situ. 2 days after the stents start functioning, they pull everything out, and they don't cross the ampulla. So it's pre-ampullary stent. Because they're all high biliary obstruction, CBD is all intact. So there is, because you haven't opened up the ampulla, there is less chance of egress from the gut contents into the liver, so less chance of cholangitis, and they don't leave an external drain. And aim is again similar to the guidelines, drain about 50% of functional volume. And we'll look at their results. What's really interesting is no cholangitis, no incidence of pancreatitis, and about 2/3 of them went on to have systemic chemotherapy, which was not part of the plan. They were all supposed to be palliated, sent home, but they improved so well to be going on to the systemic chemotherapy. So it'd be worth looking out for the second RCT that's coming out in a year or so. And I would suggest, if anyone's keen on doing a research on that, it's a good project for your students. And this is our second case. It's another complex anatomy, which was done here in our hospital. So this man had this mid-CBD lesion, came in, had a scan, showed a mid-CBD lesion and biliary duct dilatation, had hepatico-jejunostomy and bile duct resection. It was a malignant biliary lesion, but post-procedure came in with sepsis. The post-procedural CT now showed a segment 3 bile duct dilatation, which was pre-existing but was masked because there was a biliary duct lesion. The whole ductal system was dilated, and the segment 3 stricture was obscured because you're looking at a lesion and a cause, and that second cause was not identified. Now I'll run through the CT scan for you. So as you scroll through, it's a portal venous phase CT, and so these are the 2 ducts for the hepatico-jejunostomy, and it's altered liver anatomy. As you scroll down now, you'll see that the segment 3 ducts abruptly cut off at that level. But to do it endoscopically, you have to turn a long way around because this is a hepatico-jejunostomy in here, and there is no contiguous CBD to go back in endoscopically. So this was discussed at our MDT, and we came up with a plan to do a PTC to start off, assess the stricture, and go from there. So this is our first picture showing access to the segment 3 duct. You see how there is abrupt cutoff, and you can still see one of the stents placed surgically during the hepatico-jejunostomy, and these surgical clips from the prior resection. So this is our second picture that shows we have crossed it with a wire, where you can see that about 3 or 4 millimeters of it, there is an acute tight stricture, and the rest of the ducts just look dilated from here on. We are not opacifying any other ducts because it was a hepatico-jejunostomy, and the other ducts from the right side were all connected to the HepJ. So this is our plan. We did a percutaneous cholangioscopy of the lesion, upsized the existing sheath to 11 French, used a 10 French cholangioscope to look into the bile duct from the skin, and I'm sure you guys are the better judge of this picture than me. It showed rough looking biliary epithelium I may not even have the right picture in there because I wouldn't know which one to select, but ended up having a left hemihepatectomy, and there was a focal 5 millimeter area of cancer in there, and it was worth the resection. And coming to our next topic, pancreas, and the first thing that we could do is biopsies, but we are very thankful to our endoscopy team. They're not the best ones to biopsy, and they're not the easiest ones to biopsy either. We can get there, but there is quite a few things we have to look for: critical arterial structures, pancreatitis, non-target, because you're looking at a non-con, you have to put in contrast. They're painful pre and post. So we're glad that we don't have to do them anymore, and we're thankful to your team for that. Drainages, yeah, we do play an active role in pancreatitis drainages, and it is a concept. So world of necrosis, you can start off with a small drain, but 8.5 French, 6 French drains never work for pancreatic juices because they are digested, semi-digested fat, and you need to have big drains in there for the necrotic material to be drained out. So I'll show you a case example of this. So this man is 4 weeks into his necrotizing pancreatitis. So we have started off with a small drain in here. This is his pancreas surrounded by a large collection with a lot of air pockets in there, and you can see that there is a small 14 French drain in there to start off. Give it a few weeks for the tract to establish and come back in. This is a contrast injected into the drain cavity, wired it, and put a large thalquic drain in. We go between 18 to 24 French, so they look like ICT tubes essentially, about almost double the size of a pen. I'll give you a better picture now. So this is a post picture about 6 weeks later. So that's drained pancreatic collection, and this is the tube sitting in there through the tract. One important thing when you're trying to drain pancreatic collections is the approach. You tend not to contaminate peritoneal planes to get to the retroperitoneum. The reason being you're going to seed it into the peritoneum. If it's an infected collection, you'll end up with sepsis. So this one, as you can see here, see how that tracks just under the colon. Just under the colon in the lateral cornal fascia to sit back into the, and sit back into the pancreatic bed. And these drains usually stay in situ for up to 6 weeks before they are removed. And coming to the interesting bits of it, we just have 2 more cases to show. I'll run through. This is a patient 4 weeks into his pancreatitis, acutely presenting with a large PR bleeding. That's this arterial phase CT scan, shows big extravasation in the pancreatic bed. And I would like to show you this non-con and the post-con scans simultaneously. This one's a portal venous phase. So this scan would be about 40 seconds after your arterial phase. So if you look through them slowly, you'll see that there is contrast extravasation into the pancreatic bed. But what's interesting is that he presented with PR bleeding. There was a fistulation of the pancreas into the colon. And as you keep going further down, see how the rectum is now filled with bright content, and it's only a minute past injection. So he is torrentially bleeding into his rectum from a splenic artery. So you do tend to see these very rarely, but when the artery that's eroded into is the main artery, like the splenic artery, you tend to have these torrential bleeding, and more often than not, they don't even make it to the scanner. This one did, and this is our pictures from intra-angiogram. So this is a catheter in the celiac axis there. That's the common hepatic artery to the right, gastroduodenal, dorsal pancreatic. And you see this splenic artery in here, tortuous. He was a 60-year-old man. Yeah, so, and you see that blob of contrast, which is corresponding to the CT finding. And you have the wire across the neck, coil it on both sides, and it would fix it. And I do want to make a comment about the upper GI circulation here. It has extensive collateralization, which is sometimes advantageous and sometimes disadvantageous. The extensive collateralization means that you can knock off a few arteries and no ischemia happens. At the same time, in a duodenal bleeding, if you've blocked off the front door of it via the GDA, they will come back to you overnight with an acute bleeding because SMA is supplying it. It's such a robust collateral circulation that you have to take into account what you're dealing with before you block off vessels. And this is our final case. No scrolling in this one. This is a chronic pancreatitis, atrophic pancreas, dilated MPD, portal vein, and an SMA there, IVC here. And a bit of a lower slide here in the head of the pancreas. There's no pancreatic parenchyma left. That's the duct. That's the portal vein. And he came in with intermittent melena. That's a pseudoaneurysm of the gastroduodenal artery. And there are a few ways to fix it. You can exclude it, coil it, and this one shows similar picture where there is a blob of contrast corresponding to the pseudoaneurysm coiled across, and it disappears after. Yep. And take-home messages. It always has to be a multidisciplinary approach and drain the liver volume rather than segments or hemi-livers. And this is something that you can think about as a trial in your center if you have to. And please talk to us. We always have some solution. Thank you.
Thank you. Thanks very much for that excellent talk. Are there any questions from the audience? So thank you, Nam, so much for working so hard today to put together all of these excellent cases and lectures. And thank you, Frank, who's probably still working hard up there while we're all getting ready to go to dinner.
I flock everyone very hardly today, and I hope that actually you have a relatively busy day. I mean, actually with the cases, I think we have demonstrated what we can do and what we should not do. I mean, actually, not every case is actually a success, but I think the best is actually for the patient outcome. And I think all of the cases actually today have shown that actually the decision making, that's actually the most important. The technical aspect of it is actually secondary. So I think everyone should be tired from the relentless lecture and the live case. So I think it's time to relax. For those who attend dinner, it starts 6:30 at the Playford Hotel, and I hope to see you there. It's time for us to conclude the first day. Housekeeping for tomorrow, we start at 8:30 sharp. We hope to finish about 12:45. Of course, we have postponed one talk for today to keep up the timing. So I will try to ask the presenter for first session tomorrow to cut their talk to 25 minutes rather than 30 minutes. So that's the extra talk can be given. But otherwise, I'll see you in the morning at 8:30. Thank you, everyone.